हेलो 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 ठीक। मॉनिटर मैंने अभी दिया नहीं है हैंड माइकों को, ठीक। हैंड माइकों को मॉनिटर नहीं दिया है मैंने, जरूरत पड़ेगी तो दे दूंगा। और ये सेंटर फील अपने कितने में लगाया था? 13 नंबर था, है ना? है ना? 13 नंबर सेंटर फील है ना? 13 था, 14 था? 13 नहीं है, 13 नहीं है, 14 नंबर है ना? हाँ, 14 नंबर दे दूँ? सबको थोड़ा थोड़ा दे देता हूँ हैंड माइकों को ना। हेलो 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 चेक। हेलो 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 चेक चेक। हेलो 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 आ रहा है? ठीक है। हेलो हेलो चेक। हेलो चेक साउंड चेक चेक साउंड टेस्टिंग। हेलो 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 टेस्टिंग 1 2 माइक चेक। हेलो 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 चेक टेस्ट साउंड चेक 1। हेलो check 1 sound check. Hello hello check. Hello hello testing. Hello 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 check. Hello 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 hello
बात करना है भाई, बस बात करना। हेलो तो आप, हेलो हेलो हेलो
हेलो
हेलो।
आवाज आ रही है?
मेरी आ रही है?
हेलो
मेरी आ रही है मेरी।
हेलो हेलो
हेलो हेलो चेक चेक।
आवाज आ रही है आपकी? आ रही है?
हाँ आपकी भी आ रही है,
क्लियर है?
क्लियर है।
ठीक हो गया।
ठीक है ओके। तीन नंबर पर ये लो सर, एजेंडा दीजिए ना। हाँ जी बॉस।
check this. Hello, hello, check one, check. Hello, hello, one check. Hello. Hello, hello, check test one, two. Hello, hello, check one, check. Check one, check. Hello, hello, hello. Check one, check. Test one, two. Hello, 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 hello. ठीक है. Check one, check. Test one, two. Hello, hello. Check test one, two. One, check. Hello. Check one, check. Hello, hello, hello. Hello, hello, hello. Check one, check. Hello, hello, hello. Check. Hello, hello, hello.
Is the mic on? Yeah, it's now. Good morning, everyone, and welcome to Clinics in Liver Disease and Transplantation 2025 edition. The theme of this year's meeting is Holistic Management of Liver Disease. And we will try and cover in the next 1.5 days all aspects of management of chronic liver disease and not just, focus on the complications of cirrhosis. We'll try and go through nutrition and vaccination and performance status, etc., which I think are equally important when we manage a patient of chronic liver disease. This time we have more of clinical sessions, so we have a lot of case presentations, and we have kept a lot of time for discussion. So each clinical session will have 20 minutes of dedicated discussion, and we have senior experts who will be giving their insights and practical experience into the topic being discussed at that time. We also have a very interesting institutional debate. I think that's just after lunch, and hope you enjoy that. And we will start now with our first session, the Great Hepatology Challenge. And I'll ask Swapnil to take over and invite the faculty for this session. Once again, thank you all for coming and hope you have a great 2 days of academics and networking.
So, as Sir had discussed, we have kept 7 sessions which are specially curated for the holistic management of liver disease, spliced with institutional debate, rapid fire rounds, and video lectures. And we are promoting young faculty. Most of our, almost 50% of faculties are young, and senior persons will be guiding them. So we'll like to start the first session, the Great Hepatology Challenge, and we'd like to call upon the moderators, Dr. P.N. Rao sir, Dr. V.K. Dixit sir, to take their seats on the left-hand side of the dais. We'll call all our speakers, Dr. Shalimar sir, to be on the podium for the first case. The expert discussants, Dr. Lipika Lipi ma'am, Dr. Amay Sonone, and Dr. Tarun Piplani sir, to take their seats in the center of the dais. We'll request the other speakers who are again the discussions for other cases like Dr. Charles Panakal, Dr. Sunil Taneja sir, and Dr. Arun Valsan to take their seats.
Thank you. Next. Thank you very much. I think the art is long and time is short. And therefore, I would request all the panelists to give straightforward, do and don't do kind of an answers. Dr. Shalimar, please go ahead. He's going to discuss about the case, the painless cholestatic jaundice.
Okay. Thank you, Dr. Neeraj. Thank you, Dr. Swapnil. So let's come to our case. 44-year-old gentleman, June 2020, polyuria, polydipsia. Underwent appendicectomy 2021, post-seizures had seizures, post-surgery, hypernatremia, diagnosed diabetes insipidus. Started on desmopressin intranasal. 2024, developed fatigue, diagnosed diabetes, started on OHA. Doing well, August 2024, his primary illness starts, painless obstructive jaundice with pruritus. Treated with UDCA and reported for evaluation in December 2024. Investigations. Hemograms essentially normal. AST ALT 125 in July, December 172. Essentially static, but you got transaminitis. Alkaline phosphatase 1600s, 794 in December. GGT is also elevated. So we've got a case with transaminitis, elevated alk-phos, evaluation reveals elevated IgG. Autoimmune markers, ANA is positive, is level 75. The rest of the investigations are on the screen. If my panelist or in the audience wants to ask any question over here, I'll be happy to answer. Otherwise, I'm going to raise questions.
Sir,
Please
hi.
go ahead.
So we have a cholestatic pattern predominantly over hepatitis,
Yeah.
and we have markers like ANA is positive, IgG is elevated. This points towards an autoimmune disease.
Absolutely right. You've hit the nail. Okay. Right? Good. Any other suggestions, comments? Okay. So this is the liver function trends on a logarithmic scale, not a logarithmic scale, but showing you that ALK-phos, GGT were elevated. So, because he had diabetes insipidus, somebody got his MR-Sella, empty Sella syndrome. I don't know how to read that MRI, and I'm not going to go in depth about it. Some pointers to the diagnosis. His CT chest showed cysts in the lung. Okay, if somebody has the diagnosis, we'll be happy. Please do share us and do let me know what do you think is happening to this patient. MRCP, hepatomegaly, CBD normal, no IHBR, EUS done normal. So this is the story, and I want you to now come up with differential diagnosis. He's got cholestatic jaundice, he's got both elevated OTPT, ALK-phos, IgG which is elevated, ACE levels are elevated. ANA is positive, AMA is negative, hepatomegaly, cysts in the lung, empty Sella syndrome, normal MRCP. So can we have a vote on this? Because I was asked to make a question. So I want you to raise hands who think that this is an overlap syndrome, as what our esteemed panelists said. Okay, so we've got 2 people voting for, 3 people voting for overlap syndrome. Infiltrative liver disease. Infiltrative liver disease could be anything. Okay, only 2 people think. Okay, how about sarcoidosis? This is another form of, so we've got ACE levels which are elevated. So we've got a couple of hands for sarcoidosis. IgG4 related disease. Nobody asked me what was the IgG4 levels. So IgG4 levels were normal. So are you happy with it? Or do you think there could be something else? Dr. Neeraj classically told me when you're presenting, the histology has to make a diagnosis. So that means probably there is another diagnosis to it. Okay, so as usual, you would, when you see this case, you're going to subject him to a liver biopsy, because you're all scratching our heads, was it what it is? Even if clinically you're thinking these are your differential diagnoses, these were my differential diagnoses when I saw this patient. So the next step becomes a liver biopsy, because the pathologist is going to, we have the pathologist in the panel. Oh, ma'am's there, so ma'am's going to give us a diagnosis. So, okay, so this is just a 10x image. And so this looks like quite a normal biopsy, ma'am. You think there's nothing much except a few infiltrates? If you have any comments, do let me know. And then, okay, or if of the clinicians, well, I know clinicians, many of my seniors are really good into reading liver biopsies. So please, again, portal tract being highlighted over here. Few infiltrates. Beyond that, nothing else. Any comments, suggestions? Ma'am, can take the mic and let me know your comments. So I'll go on to then showing the next slides. I have got a couple of histology slides.
I can see some sinusoidal dilatation.
Okay,
it
good.
was diffusely present throughout
Excellent,
the
yeah.
liver.
So this is what ma'am's highlighting is, there's a bit of sinusoidal dilatation.
And
okay,
in the portal tracts, I can make out mild, I think, lymphoid infiltrates.
Correct,
But
absolutely.
all the elements are there in place. I can see a bile duct, an artery, vein, so all the things are in place.
Okay, so this is 40x. So again, which shows you a zoomed image. Now you don't see those classically seen those, one of those portal tracts also. You're not seeing very classically the portal tracts like the, but what you see is, that's what I learned from my pathologist, it's not my words, but I'm just telling you what she told me. There are a few eosinophils over here. What are these white things? There's some amount of fat, very minimal amount of fat, but there are something, you see these things which are appearing quite white. Any of the expert clinicians or ma'am, would you like to take a call on that? What do you think is happening? So alpha-1 antitrypsin would, okay, that could be one possibility, something else.
Yeah, a lot of differential will come when you see these stains, this kind of picture. So we would, as histopathologists, we first do the stains.
Excellent.
Whether this is steatotic liver hepatocytes, whether this is some macrophage infiltrate, which are indicative of a metabolic liver disease, or these are the 2 differentials. So I would like to see the PAs.
I would compliment you over here. You made the diagnosis. Now I want the clinicians now to see, and if they can come up, I'm sure ma'am's going to give you a diagnosis. This is an IHC done for few particular CD1A, CD68, S100. Any other clinicians who are very smart can outsmart a pathologist. I'm sure ma'am has the diagnosis. So, what is the diagnosis?
This is Langerhans histiocytosis.
So this is classical of an LCH, where you see is a lot of proliferation and accumulation of these dendritic cells and these stain for these all IHCs, which we don't see them, but if this is how classically LCH cells would look like. Positivity for Langerhans, CD1A, CD163, and then you can also look at the molecular analysis with the BRAF V600E mutation. And this is something what is classically described. If you do an EM, you may see Birbeck granules, which are tennis rackets over here. So I think over here it was the histology, it was a histological diagnosis. Classically, these patients will also have syndromic presentations with involvement of bone lesions, especially in the skull. Diabetes insipidus is a part of this syndrome. Lung cysts is a part of this syndrome. Those they can be seen in other diseases also, but the histology with the IHC over here gave us a diagnosis. And with this, he was a diagnosis of LCH was made in this patient. So, if there are any questions or any other suggestions, comments, please.
So the ANA, IgG and the ACE levels were more of a red herring?
Yeah, possibly they were not, because on the histology, nothing to suggest autoimmune hepatitis, nothing to suggest any kind of granulomas. So you need to be aware that whenever you find a patient with even clinical presentations, your next step is a liver biopsy. You should do a liver biopsy. That gives you a diagnosis, and an astute pathologist can pick up these lesions and consider this patient for the various IHC markers and can give you, because the biopsy otherwise on an H&E didn't have anything specific, maybe ma'am can add to it, but then this kind of lesions which were picked up where you thought as possibly these were macrophages, then only the special IHC stains were done. I think that made the diagnosis. Clinically, I would not have ever suspected, because this didn't have, I would have thought this is a classical overlap syndrome.
Thank you.
Or a sarcoid.
LCH in the later stages, or actually when you do a liver biopsy, you just give us 1/1,000,000th of the liver tissue.
Correct.
It's very, very tiny.
Yes.
LCH tends to cause duct loss and duct injury,
Yes.
which explains your cholestatic
Correct.
pattern of
Yeah.
LFT.
Yeah.
So,
So I didn't go in, but these are all the clinical features of cholestatic jaundice,
I think
quite classical.
brief last
Yeah.
comment, please, because we have to go to the next case. Thank you.
Poly,
you want to ask on this?
the polydipsy and the polyuria.
Diabetes insipidus.
Yeah, so that should point to a systemic disorder.
No, that's part of LCH syndrome.
Yeah, I mean,
Yeah.
we don't.
That's why when I sent my this thing, the first my statement was it is diabetes insipidus. You need to think that how is diabetes insipidus linked to this patient.
Yeah.
Thank you.
Okay.
Only
Thank
our
you.
knowledge will go for the retrostethoscopy. I go back to my CPC days in PGI Chandigarh, such cases used to be there. And closing comments on this case, somebody mentioned about autoimmune hepatitis. Classically, AST is more than ALT always in this one. Number one, they were in the declining trend. Autoimmune hepatitis, acute presentation, anictric also will spontaneously can resolve. Okay, Charles.
Thank you, sir, and good morning all. So, my patient is a 54-year-old gentleman who's a teetotaler. His only comorbidity was hyperthyroidism, for which he was on L-troxin 100 microgram. He presented with outside hospital with history of fatigue, patellar edema, and abdominal distension of, I'm sorry, the slides are running. Presented to outside hospital with fatigue, patellar edema, and abdominal distension of 3 weeks duration and a high colored urine of 1 week duration. And other significant history was a 6 kg weight loss over the 3-month period. His investigations in the outside hospital showed a hemoglobin of 8.6, the platelet count was 1,45,000, ESR was 120, the creatinine was 1.44 milligram percent, urine albumin showed a 2+ albuminuria, and his LFT showed a bilirubin of 12.7, predominantly direct of 9.5, SGOT was 175, SGPT was 110, the alkaline phosphatase was 956, the GGT was 110, the protoprotein was 8.6 with an albumin of 2.2, and he had an INR of 2.43. And the outside hospital, they proceeded with the ultrasound, which was reported as hepatomegaly with coarse echo texture. Portoin was 13 millimeter, spleen was 14 centimeter, and borderline splenomegaly with mild ascites. And they did an elastography where the the fibrosis score was 46.7 kilopascals. So, Dr. Ame, when you see such a patient in clinic, what would be your differentials and how would you proceed here?
So here we have a 54-year-old individual, hypothyroid. There is definite biochemistry evidence of cirrhosis of liver. We have got thrombocytopenia, OT being more than PT, albumin globulin ratio reversal, high INR. The ultrasound is very suggestive of cirrhosis of liver in terms of ascites, portal vein diameter being more than around 13 mm. Elastography nails it. So basically, the only markers that I feel here are a bit abnormalized, a very high ESR, a significantly high globulin level, and a very high alkaline phosphatase as compared to the GGTP. So just probably apart from all the other workup for cirrhosis of liver, this is cholestasis with hepatitis. I would also ask for a protein electrophoresis. We have got a middle-aged gentleman, some high creatinine, albuminuria, very high ESR, high alkaline phosphatase, and a very high globulin.
Dr. Sunil, Dr. Arun, you want to add something here? Or?
So I think multiple myeloma should also be considered in such a patient.
Okay. So the outside hospital, they thought of cirrhosis with acute and chronic liver failure. They did a endoscopy, the small varices, all the viral markers including AE, B and C were negative. The extended panel of autoimmune markers, AMA was negative. Ceruloplasmin and ferritin were normal. The IgG was normal. And he was started on conservative treatment, and over the week his bilirubin worsened to 18.7, the INA went up to 2.86 and the albumin went down, so he was diagnosed as ACLF by the outside hospital and referred to our center. And in our center we did a CT, and this is a CT finding. So CT, the liver was enlarged with heterogeneous enhancement, wavy margins, volume redistribution, dilated portal vein, splenomegaly, and there were few collaterals and mild ascites. So would your diagnosis change here, Ame, or you still think it could be a infiltrated disease? Is it cirrhosis with ACLF?
ACLF, there was jaundice to start with, and within 4 weeks has developed ascites. So this could be one of the differential. Cirrhosis is definitely there, so I would definitely go and biopsy this patient as to find out what is the cause of the etiology of the liver disease. We have all the other markers as being negative, the autoimmune markers, the viral etiology is all negative. So a liver biopsy is warranted here.
We have a radiologist in the panel. Yeah. Can you comment on the CT?
Yeah, the CT findings do show evidence of heterogeneity of the liver parenchyma and irregular surfaces, but the liver is not shrunken, it's rather enlarged in size. So should be ruling out underlying infiltrative disease, any systemic involvement.
So, Ame, would you do a biopsy here? How many of the audience would do a biopsy here? Okay. Yeah, sure. So, he was referred for transplant as ACLF, but because of, as Ame said, because of the high globulin, the high ESR, the enlarged liver, we proceeded with a biopsy. And this is a low power view. Madam, you want to comment on the biopsy?
So, this is a liver core biopsy where we can see there is near complete distortion of the architecture, which is not because there is fibrous bands, but because there is deposition of some very pale eosinophilic homogeneous amorphous deposits along the sinusoids, which are compressing the hepatocytes. They are reduced to cord-like structures.
And
so this is a deposition disease. Here also higher power view shows these amorphous deposits along the sinusoids. Yeah, so this is what we are very comfortable with, pathologists. This is the PAS10, the first picture. It is pale eosinophil. It stains palely with PAS10. It's not bright magenta as it should be, but it is pale. The next stain is the Clitching stain for this diagnosis. It's Congo red. So you can see the material is Congophilic. That means the orangish color. And when you take it under polarized microscope, the next picture shows the polarized microscope. There is a beautiful apple green birefringence. So all these features point to hepatic amyloidosis.
Yeah, thank you, ma'am. So, as ma'am said, it was infiltrated disorder, hepatic amyloidosis, and we proceeded to investigate in that lines. Serum electrophores did not show an M band, and immune fixation electrophoresis, again, there was no monoclonal bands. And the blood for free kappa and lambda was done, which showed that there was very high kappa, and there was a kappa lambda ratio was distorted. And this is a bone marrow biopsy, and again, it shows infiltration with plasma cell, more than 30% plasma cell infiltration with kappa light chain restriction, size of a plasma cell myeloma. So the final diagnosis is infiltrative liver disorder with liver failure, hepatic amyloidosis, and plasma cell myeloma.
Did we do an 2D echo over here, sir?
I have not shown the pictures here. The 2D echo was done. That was normal.
And probably he also has albuminuria, so there would be nephrotic syndrome also.
Right. So it's a systemic disorder, can affect liver and kidney. So yes.
Charles, what is your normals for your alkaline phosphatase? Because there is a clue here, very highly elevated alkaline phosphatase with only very mildly elevated GGT, if you remember.
Yes,
1156. What is your normals for alphas? 300 or 100?
115, sir.
So it is a 10 times more when GGT is only twice. So that give a clue that infiltrative disease. I think please remember, always start with your case with the weight BMI of the persons, because CA, CLD, the only clue is only the past, and also have a recall weight. What was his weight about previously? By the time he come to you, he may be sarcopenic, even child A. Thank you.
Thank you, sir.
So one
yeah,
point.
Please go ahead. Last.
We currently have a patient with plasma cell leukemia, and he was having a normal liver, but deranged liver function, normal INR, but his ammonia was very high, 200s. So then literature search showed that myeloma can have hyperammonemia without liver failure. I thought it.
So I think ESR is also sometimes very helpful. More than 100, you have very few causes like multiple myeloma, giant cell arteritis, and Cox sometimes. So that also gives us a clue.
Thank you very much. I think with this we'll close. I'll hand over to Professor Dikshit, to take over the next cases. Dr. Vinod, please.
So now I call upon the next speaker, Dr. Sulita Neja.
So this was the end of our pathology-based discussions. I will request Dr.
So he will be presenting patient of Shawl actually.
And Dr. Amit to take their seats in the audience, and we'll request Dr. Neeraj Gautam, Dr. Dibyalochan Praharaj, and Dr. Manas Panigrahi to come on the dais.
Good morning, everyone. My sincere thanks to Dr. Neeraj, Narendra, and Swapnil for inviting me here. So I'm going to quickly run through this case of an unusual liver mass in a male patient, and we'll have a few questions in between just to discuss. So my panelists are there. I think we have a pathologist also with us. Okay, this is a 50-year-old male patient, diagnosed case of alcohol use disorder for 30 years, chronic smoker. In 2017 June, he came with acute pancreatitis, improved. November had cholangitis, came to PGI, underwent ERCP and stenting, and in 2018 the ERCP was done, CBD clearance was achieved. In 2019 this patient was diagnosed with chronic pancreatitis and developed diabetes also. For 4 years he was lost to follow-up, and in 24 March he came with right-sided empyema and was incidentally diagnosed with a hepatic SOL on imaging. Now, these are the baseline investigations which we have. He had anemia, platelets were preserved, bilirubin was 1.3, AST/ALT normal, and alkaline phosphatase was 309. The viral markers were negative, MON2 was negative, and FibroScan revealed a value of 8.2. And with these investigations, the patient underwent a CT scan. So, do we have a radiologist with us? Dr. Tarun, would you like to comment?
So, we can see some pneumopilia in the left lobe of the liver, and some lesions are seen in the right lobe of the liver.
So these are these lesions which are seen on the right lobe, and there was some enhancement along these lesions, and there was some enhancement in the portal vein also, and some washout to suggest. So this was
This looks more like an infiltrative disease. The lesions are not very well defined, but in the region of the right portal vein, you can see a thrombus there.
Yes, there is a
and
thrombus.
I think that thrombus is enhancing, so this could be a tumor thrombus.
Yes, so this lesion was reported as HCC by the radiologist, and these were some other findings in this patient. There was some evidence of inflammation in the head of the pancreas, and there was hydropneumothorax on the right side with an ICD in place. Now, we did the tumor markers for this patient. AFP, PIFCA, CA, all were normal, and amoebic and high rate histology was also done because there was some doubt that there could be this infiltrative disease in this patient. They were all negative. So, what should be the differential diagnosis, Manas, in such a case if you see in your OPD?
So, hello, audible?
And Dr. Manoj?
Differential in this case, of course, SCC will be there, but since portal vein thrombosis and tumor thrombus looking like as our regular diagnosis is, but we can keep differential in the background of chronic pancreatitis and having cholangitis previously. METs we can have in our differential. We can have some cholangitic abscess if patient is in cholangitis, previously in cholangitis, 10 block or something now, and cholangitic abscess, METs, and SCC.
So this was a non-cirrhotic liver. That's an important thing which we have to remember. Fibroscan was 8.2, platelets were preserved in this patient. So obviously the first differential is always HCC if you have involvement of the portal vein, and then you can have hypervascular METs, and neuroendocrine tumors are also one of the differential diagnoses in such a patient. So we went ahead, and since the diagnosis was not clear, we did a PET scan also for this patient. Again, Dr. Tarun?
So yeah, we can see significant FDG avidity. There is uptake in those ill-defined lesions in the right lobe of the liver.
Yes.
Even the area of the portal vein
also.
thrombus, that also shows us uptake.
So this whole area was enhancing, and along with the enhancement at the portal vein. And this is the other images which show that there was a lot of FDG uptake in the liver as well, some uptake in the prostate, and there was a para-aortic lymph node which was also lighting up, and there were some changes of this hydropneumothorax which was seen on this. So there was bulky head of pancreas also, and this is what the report was given to us, FDG avid enhancing lesion in the liver along with this enhancing thrombus in the portal vein. So now the database which we have is of a patient who has normal tumor markers, PET scan showing liver SOL with portal vein thrombosis, and multiple SOLs in the liver with PVT which was suggested on triple phase CT scan. Dr. Divya, how would you proceed from here? Now you have this patient with you.
Sir, we need a histopathological diagnosis from this point, I think. So, biopsy from that side.
So, as rightly said, the diagnosis was not clear. We were thinking of HCC, then neuroendocrine tumor, and metastasis also. So, next investigation obviously is histology. We went ahead with the ultrasound guided biopsy of the SOL. Do we have a pathologist?
Probably in this scenario it is not very clear from here, but I can't see any malignant cells here. There are a lot of fibrosis and amidst the chronic inflammatory and acute inflammatory cells.
So a lot of fibrosis along with the lymphoplasmacytic infiltrate was seen, and some storiform fibrosis. This is the closest section, and again the closest section showing a lot of infiltration. This is the CD138 staining. Doctor.
Plasmacytoma is the one infiltrating, or amyloid is also is differential diagnosis in this case. We need to do some immunohistochemistry in that.
So CD138 positive plasma cell rich replacing the hepatic globule and the portal tracts with some big storiform fibrosis was there, and this is IgG4 staining in this patient which was done. And this came out to be positive in this patient, and the ratio was more than 40% in this. And this is the EVG staining which highlighted absence of obliterative venolitis. Now we went back and we did the IgG levels and IgG4 levels. They came out to be positive, and this ratio was more than 50%. And we made this possible diagnosis of IgG4 related disease in this patient. Now for the management part, obviously we need to give steroids to this patient. This patient was treated with steroids, and let's look at this PET scan on follow-up. This is 6 months after treatment with steroids. Look at the comparison. The FDG avidity is gone, and the portal vein thrombus is gone. The liver looks much better here. The lesions have gone. So the learning point is that all FDG avid lesions with portal vein thrombosis is not HCC. You have to think of other differential diagnoses, and sometimes it might be a benign disease. And there are reports that IgG4 related disease can mimic like a pseudotumor. There are very few case reports of involvement of the portal vein and with the portal vein thrombosis, which is highlighting on an PET scan. So this patient is doing well. He's gained weight, and he's on tapering dose of steroids now. I will not go into the discussion part. We can take 1 or 2 questions.
So you think the IgG4 can also lead to involvement of the pancreas also?
Yes, so this could be
so
that
both
there's a
the thing
system.
can be explained by the
Yes.
IgG4?
There was some involvement of the pancreas, and there was uptake in the prostate also. They was feeling that this could be a multi-system disease.
So any other points from panelist or audience?
Pseudotumor, hepatic pseudotumors
Dr.
have been
Rohit,
reported.
Dr. Rohit, please.
Portal vein thrombosis enhancing and turning out to be IgG4 is there are 2 case reports only so far, which we could find.
Quite rare, yes.
What happened to the pancreatitis? Did it regress?
No, that he has features of chronic pancreatitis which are going on. Yeah, he has diabetes also, but then the rest of the parameters have improved.
So here clue is most probably that pancreatitis, biliary stricture and cholangitis, and this PVT, then portal vein thrombosis, is pretty rare. From our series we have now published IgG4 related morphology of liver disease, recently published in pathology. So we have never get this portal vein thrombosis. It's quite rare. However, we have seen this cholangitis and liver infiltration of the liver, IgG4 related liver disease. But this mass forming and PVT is quite exciting and rare.
So initially also we thought this is HCC with portal vein thrombosis. The first thing we did was an FNAC. Again, there was no suggestion to suggest HCC. Then the decision was taken to do a biopsy from the lesion. And obviously we were not expecting that this would turn out to be an IgG4 related disease.
Is the storiform fibrosis is a big clue?
Yeah, that's definitely is a clue.
I think one of the radiological features in portal vein thrombus is that the PVTT, which comes secondary to tumor, usually enlarges the portal vein. This was not the case.
Yes.
Here the portal vein was normal in size and had an enhancing thrombus, and which was FDG avid. So this is one differential which I always tell my fellows, that when you look at the PVTT, you don't look at only enhancement, also the enlargement of the portal vein. So that's the radiological difference.
Yeah, the point is well taken. Yeah.
Thank you, Dr. Sunil.
Thank you very
for
much.
a nice case discussion. And so now we go ahead with the next case. Dr. Arun Walshan will present the decoding the multiloculated cystic disease. Dr. Walshan, please.
Good morning, everybody. I have a very simple case. The case was given to me by the team, Medanta team. So I'll just go ahead with the case. So we have a 58-year-old gentleman who's known diabetic. He was symptomatic since the last 6 months with intermittent fever and chills, abdominal pain with occasional vomiting and loss of appetite. So an outside ultrasound had shown suspicion of a liver abscess, and he was referred to Medanta for further evaluation. So at admission, his CBC, he had anemia, mild leukocytosis. He had pronounced eosinophilia. If you can see, he has 24% eosinophil, and LFTs, except for the GGT and the ALP, and was mildly elevated, and he has a low albumin. And pronounced increase in ESR and the inflammatory markers. Other viral markers were negative. So what the this is the imaging. Can you go ahead? Somebody can take the question for the imaging. So
the liver is enlarged in size, and we see multilocular, multiseptated cystic mass lesion predominantly involving the central part of the liver, right anterior sector in segment 4, And there are some peripheral solid enhancing components. So this could be, to my mind, I'll think of echinococcal disease as one of the differentials.
Yes.
And then cystic, multicystic neoplasms.
Okay. So we can broadly take the syndromic finding as a hepatic cyst, and it can be various etiologies like infectious or non-infectious. And sir, could you comment something about the portal vein? Can you see any
so there
enhancement around the portal vein?
Yeah, the image on the left is the arterial phase, the image
Yes.
on the right is the portal venous
Yeah.
phase. But I don't see any invasion of the portal venous system.
Okay.
Rather, they appear to be compressed. There is some indentation in the posterior aspect of the cystic mass in relation to the right portal vein radical.
Okay, so we move ahead. So we had to, Dr. Manas, can you, with the clinical snippet that we have provided and the imaging, can you?
If you'll see this clinical scenario in a patient who is most probably alcoholic and febrile now with a liver sol, with
Phase inflammatory
multilocular,
markers,
symptomatic, and so infectious hepatic cyst is a possibility in this case.
Okay. So rightly so. So since it's a complex cyst and does not show significant hemorrhage, the primary diagnosis was kind of an infectious cyst. So there are other differential. I'm not going to the detail because of the want of time. So when do you suspect infection in a cyst, Dr. Dibya?
When patient is symptomatic with features like having patient fever, and obviously we have to rule out other causes of fever in the same patient. Patient having tenderness in the right hypochondrium, leukocytosis and blood culture, although it is not always positive. Along with there has to be, if cyst, we aspirate the cyst, we get necropsy debris and some organism, then we can suspect.
Okay. So are there any signs on imaging that would portend a worse diagnosis? Dr. Manas, can you take? And then we can go to the radiologist.
Signs in imaging, loculated cyst, if we are seeing some daughter cyst there, that can clinch. And this cystic neoplasm will have
About the thickness of the septations, if you are very thick.
Will be more in that this infectious cyst.
Okay. If there are any internal hemorrhage, so anything you would like to add?
So to differentiate between a simple and a complex cyst first. So the simple cyst would be a the cyst with near water attenuation and no internal contents, no septations, no debris. And the cyst wall would not typically enhance, usually, the congenital liver cysts and benign cysts.
Okay.
If we think of a complex cyst, so any features which add on to these, like if the CT attenuation value of the cystic fluid increases, there is pus within, debris within, or hemorrhage within, then the septations, then the nodularity, then the surrounding wall enhancement, and then invasion of the adjoining parenchyma. Is there a inflammatory rind around the cyst?
Okay. Or there is any hyper enhancement along the portal vein. So that all says that there are infection. So, Doctor.
So this is what do you think you are seeing the CT? Do you think this is a benign cyst? Because
no, this is not benign because the portal venous phase that we saw, there was hyperemia around the entire cyst, and this is a multilocular cyst. Either this could be a cystic neoplasm which got secondarily infected, or this could be primarily an infected cyst. This is not a simple cyst for sure.
Okay. Dr. Dibya, would you do an aspiration or a biopsy in this patient?
The aspiration, if patient actually, this is I will say, it is a subacute type of presentation over, or a chronic presentation over months, and patient probably is not responding to antibiotics, what we have given. And the diabetic patient, immunocompromised patient, so definitely aspiration has to be done. Sir.
Yeah, and especially if there is gas demonstrated or there are large infected cysts or you get the patient is having persistent fever, then probably you will do an aspiration. So the aspiration was done from this, and the gram stains showed only a few pus cells, and the serologies were negative, and no MTB was detected. So the biopsy showed there were mixed inflammatory infiltrate composing of eosinophils, lymphocytes, and plasma cells, and there was a lot of necrosis, and few granulomas were also seen composed of epithelioid cells. So the impression given by the pathologist was a necrotizing granulomatous inflammation with dense eosinophilic infiltrate, likely of a parasitic etiology. So the treating unit's diagnosis was a complex multilocular liver abscess, whether it is fasciolasis or visceral larva migrans, and they treated the patient with albendazole for 12 weeks. So
Arun, I just want. Did you biopsy that lesion or was it resected?
No, they had done a single time aspiration.
So this was the biopsy from the lesion. Maybe we can have some comments from Dr. Neeraj on this. Can you go back to the pathology slides?
Yeah.
It's an ultrasound guided true-cut biopsy?
Yeah, yes sir.
Yeah.
So,
I believe there was no surgery offered to this patient.
Yeah, yeah.
No.
So,
as a surgeon, would you resect the lesion or would you biopsy the lesion?
Prashant here from Medanta. So I think, this particular lesion, if you look at, if Tarun could little elaborate on this, this was a lesion which was appearing like this. The patient was asymptomatic other than that slight raised down. There was some eosinophilia, if I'm not mistaken.
Yeah.
And typically these ones which have visceral larva migrans, they spread along the portal vein. So
yes.
You see the portal radicals, and along
yes.
the portal radicals you find that there is a increase. Many of these are sometimes misdiagnosed even as metastasis.
Yes.
So the first diagnosis sometimes when someone looks at it, you think it is metastasis, and then you find this typical pattern where you have these cystic sort of lesions which are along the portal vein radicals.
Yeah.
In fact, I'm not sure if actually this requires a biopsy in many cases. Sometimes we've diagnosed this after having seen about 10-12 cases like this now, just on the imaging features itself.
Yes.
And given a trial, in fact, of albendazole for 1 or 2 months, and then they have completely resolved. They actually get calcified in the long term over
yes.
a period of time, and wouldn't really go ahead for, this resection here would mean quite a major surgery for this patient in whom this is like a benign disorder. So I think we have to be careful. This is like one of those cases where you should think before you actually go ahead and do a major resection for something that appears to be benign. Tarun, you said that this was complex. In what way did you think this was a complex cyst? Peripheral enhancement, any?
Yeah, there was one, the multilocular appearance. Second, there were peripheral enhancing solid areas. It was not like a complete cyst. There was some solid components. And third thing, if you, as Prashant told us, if we could see one indentation on the right anterior portal vein radical. So these tends to grow. So even if you think of, if the patient has eosinophilia and you see this cystic mass, this is our learning that they tend to grow along the portal vein radicals. So like last 8 to 10 cases, we have always now started thinking of visceral larva migrans as one of the differentials in these kind of cystic masses.
The reason for biopsy was this peripheral enhancement
yes.
and suspicion that it could be malignant.
Yes. So this was a follow-up image which was showing interval resolution of the edema, and the size has also come down, and the patient is on follow-up. So the learning points in this case are hepatic nodules should be considered as one of the diagnostic possibility. Eosinophilia might not be there always, but is a useful clue. And thick wall septa or a solid portion enhancement and a fluid signal, and also tracking along the portal vein can be a marker. Periportal distribution of the lesions and conspicuous finding on a portal venous face should raise a possibility of VLM in your differential diagnosis.
Thank you very much, and it's indeed a great hepatology challenge. I think we learned the liver LCH, liver amyloidosis, and the liver IgG4 disease, and then lastly this VLM. Thank you very much, and then kudos. Is a great start for this one.
Discussion for all the 4 cases, and session sitting can take along the questions whoever has regarding these cases?
Yeah, we still have a lot of time left. So, Dr. Shalimar, sir, any comments on any of the cases?
I think one point was regarding the last cases, visceral larva migrants, please, we need to biopsy. Please don't make a diagnosis on radiology. We've had our expert who's just said, visceral larva migrants, whatever cases we have seen, they're more peripherally located, not such big lesions what we see classically. So even there is eosinophilia, you got all these, please do biopsy. The carry-home message should be very clear on that, because you can see all these kind of atypical lesions. So better to biopsy such patients. That's my take on that.
So I think I agree with Prashant. So we had this 38-year-old female which was referred to us with the SOL, this diffuse kind of SOL around the portal vein. And she was labeled as metastatic disease. And when we did a biopsy, it came out to granulomatous inflammation. So I think biopsy should be done because there should not be any doubt of malignancy versus a benign disease.
Even LCC can cause multiloculated.
There's no as particular biopsy. We can see whether there's a necrosis or caseous necrosis, then we can label it as a tuberculosis. Otherwise, in parasitic cysts, there's a lot of eosinophils. There's sheets of eosinophil and there's a necrosis. So we can only say that it's a parasitic cyst. We cannot pinpoint what it is.
So actually when we come across any case like this, who has come with a fever and pain abdomen to begin with, and the ultrasound showing a hypoechoic lesion suggestive of abscess, and then the CT was done, which was again, then it came there as a multiloculated cyst. So we came to mind either it could be abscess or it could be a multiloculated cyst. And so third was any malignancy with cystic degeneration. And then we think of the other uncommon causes. Now multiloculation, the thick septa, definitely it goes more favor to cystic disease. And particularly the echinococcal granular, the multilocalized variety, they present like this only because there is a creeping type of necrosis and then they make a multiple loculated cyst. And most of the time they can be diagnosed by the radio imaging and hardly require actually the biopsy, to my mind actually, my opinion.
I think the other point, Sunil, which I'd like to raise out here is the IgG4 disease. So you showed this patient. So when do you really think about IgG4 diseases? So post-COVID, we've been seeing a lot of patients coming with sclerosing cholangitis. That's another peculiar scenario which we are seeing. So the question is, when do you suspect? So like this case was very interesting, but then when should we consider this as a possibility?
So I think our threshold also for diagnosing IgG4 disease has come down now. We try to suspect very early in patients. A lot of patients do come with subtle changes in the biliary system. So some would come with strictures also, some would come with inflammation in the pancreas, some would come with multi-system involvement. So there are a lot of patients who come with this some mandibular swelling and some swelling in the retroperitoneal region. So I think the suspicion has to be there when there is an atypical presentation. Always think of IgG4 related disease.
Just a comment on hepatic amyloidosis.
So radiology-wise, IgG4 disease, in our practice we have seen that they are mostly mass-forming. So the malignant strictures, if you have to differentiate malignancy versus IgG4, the malignancy would usually involve the duct wall and would like the sclerosing kind of variety. But IgG4, wherever it comes, maybe it can come here or anywhere retroperitoneum, you will see big lesions. So that is one of the pointers.
So I think PET also helps us in these patients. So if you have this multi-system involvement, then you get a clue that it could be IgG4 related.
Yes, yes.
So won't you consider IgG4 as a possible differentiator of any sclerosing cholangitis? Say you say is only mass forming, why not is just any sclerosing cholangitis? Should we consider, or do you think?
I think we should, but say 60 to 70% of the patients usually have mass forming in IgG4. So nowadays we always keep a differential there and always ask for IgG4 levels before proceeding further.
But so the question is, as a radiologist, so you see a lot of patients coming and being asked for the MR is done so frequently. So what makes you think that this is IgG4 over another, say, sort of as like a malignancy, or could that be another possible differential diagnosis? So what makes you think? So the question is, what as a clinician should I think when I'm seeing, say, the MR I'm seeing, what makes me think that this could be an IgG4 in contrast to other possible malignant or other diseases?
Yeah, so the malignancies in relation to the bile ducts would most likely they do not metastasize that early. So one thing is, if we see multiple masses, we see retroperitoneal nodes, we see multi-system involvement, then we think more of IgG4. And even the masses which are going, they might be at the hilum or in the bile duct, or they might be deep inside the liver. There is some element of, like the case that we saw, it was behaved like a tumor. And so that is one thing, that they are usually mass forming. And they, with treatment, they just melt away. So that's one of the differentials.
Another very important point is there's always a debate about HCC now. It's an imaging diagnosis. We are just making diagnosis on imaging. So whether you should biopsy all your patients of HCC also is a matter of debate, because sometimes you will pick up such lesions, then obviously neuroendocrine tumors, HCC with neuroendocrine differentiation, hepatocholecalcinosis and so on. So routinely we don't biopsy all our patients. So that is again a matter of debate, whether we should do biopsy.
Atypical views, and also when you're suspecting cholangiocarcinoma or non-cirrhotic HCC like thing, we should biopsy them.
I think when the tumor markers are negative, we have to be more careful and keep differential of IgG4.
Can I just say, Dr. Shalimar? So I think one of the things is, if you have such a mass-forming lesion, because the most common differential is between a hilar cholangio and IgG4. This is what we see clinically every day. So I think once it increases to a particular size, and when they are mass-forming, hilar cholangiocarcinomas tend to invade one side or the other, especially vascular invasion. The other thing is the length of involvement. Usually these IgG4 seem to be like more on the right, more on the left, and still you don't have that very high level of jaundice in these patients. So although you may suspect hilar cholangiocarcinoma, if you do not have vascular invasion, if you do not have a corroboration of the clinical jaundice, and it's more presenting as a cholangitis rather than a large increase in jaundice and a localized lesion, Tarun, correct me if I'm wrong, these are the things that we look at. And the suspicion also goes with the clinical presentation, age. You have typically people who are 30s and 40s who are presenting these lesions, or they have associated autoimmune disease or some rheumatoid arthritis or something like this. So I think the clinical picture, in addition to what you find on imaging, also should raise that suspicion probably, and pancreatitis along with it.
No, we had a case now. This was a 50-year-old male, and as you said, so initial possibility on radiology was a hilar cholangiocarcinoma. And we did an ERCP, brushed everything. So it turned out to be negative. And he went, surgeon said that it's involved ducts also, we will not operate. And for 1 year, he was kind of going on. And finally, it turned out to be IgG positive. And we treated him with steroids, and he has improved.
May I make a comment? Yeah. IgG4 we should suspect more oftenly now, because if there is a multi-system involvement and the prolonged course, even if you are not seeing a definite mass, you should suspect, especially get the IgG4 levels if they are raised. And I remember so many cases. A case was diagnosed at the hilar cholangiocarcinoma at Medanta hospital, and this happened about 11 years back. And the PTVD was done, and to the extent that the histopathologist, I don't know who was the histopathologist, they made a diagnosis of the cholangiocarcinoma. And the metal stent was put in, and 9 years later, that lady came to us. Probably she was not following up with the Medanta. And we were surprised to see that cholangiocarcinoma surviving for 9 years, it is not possible. So we got the IgG4 levels. These were raised, and she's on my follow-up for last 2.5 years. She is still surviving. Oh, elderly lady.
I think that's a very important point. So all have been seeing more frequently IgG4 related diseases with varied manifestations. So it's very important is to suspect an unusual presentation do get IgG4 level. So we ask for it, it does come, you have. But then I think it's more of a teamwork, it's more of how we as a clinician suspect, and we are supported by our radiologist, and the final diagnosis comes by the histopathologist. So it's the teamwork which helps you in making a diagnosis.
I think Charles, you also showed a very interesting case, and amyloid also is one condition which can mimic like ALF, ACLF, chronic liver disease, only hepatic. So that's a very important condition which we should consider.
I think now it brings to the end. I must thank all the case presenter, Dr. Salima, Dr. Arun Valsan, Dr. Sunil Taneja, and Dr. Charles, and all our panelists actually who had a great interaction, and the audience who had a beautiful. So we all had interesting cases, all the 4 cases, and thank you very much.
Sir, kindly join us for a photograph. Near the backdrop, sir. Moving ahead with our next session on acute and chronic liver failure, our moderators are Dr. Sumit Rungta, Dr. Charles Pennicle, and our expert discussants are Dr. Ashok Chaudhary, Dr. Sanjeev Sehgal, Dr. Neelam Mohan, Dr. Prashant Bhangi.
Dr. Sehgal, the chair's on the right. Yeah. No, on this side.
Yeah, they are there.
So our first speaker of the session is Dr. Ajay Duseja, who will be speaking on pathophysiology of acute and chronic liver failure, bridging the gap between inflammation, immune dysfunction, and organ failure. Due to logistic reasons, we'll connect you with him online. Pre-recorded session.
Dr. Ajay had to,
Hi, good
he
morning,
was here
everyone.
yesterday but had to go back
At the
for,
outset, my sincere
CGI
thanks
function.
to Dr. Hi, good morning, everyone. At the outset, my sincere thanks to Dr. Neeraj, Dr. Swapnil, Dr. Narendra, and the whole team of CLDT 2025 for the kind invitation. And my sincere apologies for not being there physically today morning. I bring greetings to all of you from PGI Chandigarh and in Azal. And the job I have been assigned today is to speak on the pathogenesis of ACLF, bridging the gap between inflammation, immune dysfunction, and organ failure. ACLF has become a very important emergency, I would say, for all of us in the hepatology community and in the liver transplant circles. If you look at this global burden disease data, which used canonic definition or Easel-Cliff definition for ACLF, 4 of the 10 decompensated cirrhosis were found to be ACLF. But more important than that is that 6 out of these 10 had 90-day mortality. So yes, I think this is a problem. Something has to be done, and we all been working on this for long now. So management has to improve, and for that, I think the understanding of pathophysiology becomes all the more important. Now, whatever definition you may use, whether it's a Parcel or Easel-Cliff definition, all the definitions would agree that ACLF has 2 components. One is a chronic component, chronic liver disease, with or without cirrhosis as per a Parcel or cirrhosis as per Easel-Cliff. And then there is a precipitating event which tilts the whole balance. And this precipitating event then leads on to a cascade of events ultimately turning into systemic inflammation and organ failure. So let's try to understand, which is the topic of the day today, as I said. So this precipitating event could either be hepatic in the form of alcoholic hepatitis, which we see very commonly, or acute viral hepatitis, or drug-induced liver injury, or even an extrahepatic like infection, or maybe just gut dysbiosis because of alcohol, bacterial overgrowth. So this precipitating event then leads on to the release of molecules like PAMPs, if they are coming from the bacterial translocation, or it could be DAMPs if they are coming from the liver injury. And these PAMPs and DAMPs, which kind of act as inducers, then they will act on specific kind of cells, and these cells become then the sensors for these molecules. And the sensors are usually the receptors like the toll-like receptors, TLRs, and these sensors then will secrete various molecules, predominantly inflammatory cytokines but also anti-inflammatory cytokines, and then they become the mediators for what we call the systemic inflammation. Further, this systemic inflammation has to be now counteracted by the anti-inflammatory response, so-called CARs, and there's also a component of immune dysfunction which comes in, and that is responsible for organ failure. So we'll understand it more as we go on. So again, if you look at this figure here, this tells us that if there's a gut dysbiosis and bacterial overgrowth, this leads on to bacterial translocation, and then as I said, the PAMPs or the pathogen associated molecule patterns will come in, and they will act on the receptors like the TLRs receptors, and then they will release various cytokines, and the predominant, and this could also happen even because of the DAMPs, which are the damage associated molecular patterns coming from the liver injury, as I said, because of the acute hepatitis of any etiology. And then these receptors then would secrete, as I said, after sensing, the various cytokines which are secreted predominantly are the inflammatory cytokines, which we know are the IL-1, IL-6 and others, and some of the TNF-alpha, and then anti-inflammatory cytokines also come in. The predominant for them we know is the IL-10 and also the TGF-beta as a counter mechanism to this inflammation. So these inflammatory cytokines can directly cause damage to the organs, and that is known as the immune mediated damage or immunopathology which happens. And these cytokines, as I said, counteracted by anti-inflammatory response, and then there is an element of immune dysfunction which comes in, and that leads on to the mitochondrial dysfunction, the ATP synthesis goes down, and that is how the organs suffer hypoperfusion, and finally this all leads on to the organ failure. So the various cells which are involved, again, I think are of some relevance here. As I said, after the cytokines are released, the predominant cells are released from the macrophages. These macrophages, as I said, will release various cytokines, and they can then stimulate the neutrophils, monocytes and all, and then even hepatic stellate cells. And hepatic stellate cells can secrete various molecules like endothelin-1, prostaglandins, nitric oxide, thromboxane A2, and this could be responsible for portal hypertension and various other after effects. Neutrophils which are released, I think yes, there is a neutrophilia, and we'll come down to that, but then we will also come down to the neutrophil dysfunction which is there, and the monocyte dysfunction which is there, which also contributes to the whole immunopathology, and as I said, finally affecting the organ functioning and ultimately leading on to organ failure. So let me show you now, some data on this, and one of the first studies, the earliest studies, again came from Dr. Rajiv Jalan's group, and this they tested, we know the pyro concept was initially for the sepsis, but then the Spiro concept was then tested for the ACLF patients. And we know that ACLF patients, obviously cirrhotics, are predisposed. So the injury, as I said, I told you, is the acute hepatitic injury, and the response, as I said, is the cytokine storm or the cytokine release which happens, and finally the organ failure happens. And in this particular earlier study in 2012, what they showed, around 500 patients, those who had organ failure, they had higher systemic inflammatory response. And this systemic inflammation they had tested by, again, TLC, the neutrophil count, and also if you look at the levels of CRP here, they were elevated, and they were more elevated in non-survivors in comparison to the survivors. After this, came the, well-known study we all know in the ACLF circle, which is the canonic study. And this canonic study gave us a lot of information, but again, in reference to the inflammation, the information which this study gave was that there was obviously leukocytosis in these patients, and more important is that this leukocytosis and the CRP which was elevated in these patients correlated with the mortality in patients with ACLF. So there is a systemic inflammation which is evident by increased CRP and leukocytosis, but this systemic inflammation also correlates with the mortality, and indirectly telling you that this is responsible for the organ failure in these patients. To the extent we know that, I think there are various prognostic scores in ACLF, even for apostle and for the canonic or the Easel-Cliff definition, and in the most out of these, the best score we still consider is the Cliff-C ACLF score for canonic, and we know that the TLC or the WBC count is actually part and parcel of this count, and this is because this is a very important prognostic marker and is responsible for organ failure and ultimately the mortality in these patients. One of the best studies on systemic inflammation again came from the canonic data, and this is again a canonic data which was published in 2016, and this gave the concept of so-called the cytokine storm in patients with ACLF. Again, a large number of patients from the canonic database, around 500 plus, half of them having ACLF, and then they compared the results with healthy subjects, and they studied more than close to around 30 cytokines, and also looked at the oxidative stress. And what they found was that the patients with ACLF not only had higher systemic inflammation than those without ACLF, but this was also related to the severity of ACLF, and finally this systemic inflammation was also related to the mortality in patients with ACLF. So I think, as I said, this study gave us that concept of cytokine storm, and all the cytokines predominantly inflammatory, and also the anti-inflammatory cytokines which come. So we also kind of started working on this area, and our first study from our group came in the year 2018. Sandeep Satsangi did this work with us, and I don't know whether he's there in the audience. And Sandeep, what he did was around 75 patients of decompensated cirrhosis. We divided them into half of them as ACLF, and we chose the apostle definition that time, and half without ACLF. And then we looked at the levels of different inflammatory and the anti-inflammatory cytokines in them. And as I said, IL-1, IL-6, IL-8, these are all inflammatory, IL-12, TNF-alpha, all inflammatory, and IL-10, is the anti-inflammatory. And they were obviously elevated in ACLF, and they were also elevated in decompensated cirrhosis, and we did not find much difference between the two, but this gave us the concept that yes, decompensation, ACLF do have elevated, systemic inflammation. But the second part of this study was very important, was that we looked at the immune dysfunction, which is, another thing which is given to me to cover. So we studied the immune dysfunction by looking at the HLA-DR expression, which is very important for the antigen presentation. We not only looked at the expression of HLA-DR expression, but also the density, how many, what was the density of this HLA-DR expression, and overall this was lower in patients with ACLF. And the second thing which we looked at was the neutrophil oxidative burst. So there is a oxidative burst which does happen in decompensated cirrhosis and ACLF. It is increased, but then how does this oxidative burst responds to a stimulant is very, very important. So there was increased oxidative burst, but it was not really responding well to the stimulant, which was given here. Then this was the PMA here. Continuing with the similar kind of work, then a second study came from our department, and here the 40 patients, who were taken, they were canonic definition, and they were divided into, again, 3 grades as per the canonic, and again the results were compared with this thing. In this particular study, what we did was that in addition to the oxidative burst, which I said, which we had earlier studied, we studied 2 more things. One was the neutrophil immune phenotype, which tells you whether these neutrophils are normal or they are abnormal. So, CD markers were studied for these neutrophils, CD16, CD66 markers, and also the neutrophil phagocytic capacity was studied, and this was impaired in these patients. And this was again, we kind of correlated it with the 90-day mortality. So again, you're telling you that there is a not only systemic inflammation, simultaneously there is an immune dysfunction which is going on, which is evident by the reduced phagocytic capacity, reduced antigen presentation, and the abnormal kind of neutrophil immune phenotype, which is responsible for all this. Now coming, to the last part of my presentation, which is about the organ failure, which is resulting from all this. And this is, we also know the concept which Canonic has given is a concept of so-called the pre-ACLF, which means that the patients are AD, acute decompensation, and within next 3 months, if they get into ACLF, then you can call them that, yes, these patients were probably pre-ACLF. There is good data to suggest that these patients with pre-ACLF, they also have a higher systemic inflammation than those who do not go into ACLF. So this is the concept. And on this concept, again, the third study came from our department, which was the, I would say, a multi-center study. Our department, Amrita Kochi, and the Apollo Kolkata was involved, and this was led by Nipun. And then again, 625 patients, predominantly, alcohol-related liver disease, and 1/3, progressed on to ACLF. And then again, if you look at that, the who progressed on to ACLF, which means who were those pre-ACLF, and this was in hospital, they progressed on to ACLF. This from AD to ACLF progression, you may not require 3 months, can happen even, within the hospital also. And the leukocyte count, which is evident of, systemic inflammation, was one of the factors, and this was significantly higher in the group which, progressed on to ACLF in comparison to those which, and then obviously those who progressed obviously had a lower survival. This is maybe my final slide on the mechanism as to why finally, the organ failure happens in them. One we know is the systemic vasodilatation, which is happening because of all this. But then how systemic inflammation is contributing is by 2-3 mechanisms. One is that, yes, if you look at the renal dysfunction, we know that systemic vasodilatation does lead on to, vasoconstriction to cover that, and this can lead on to AKI. But then inflammation per se can cause, this data to suggest that there is a renal injury which has been shown to be TLR4 mediated through inflammation. This inflammation also causes the LV contractility dysfunction or the cardiac dysfunction, and yes, this can also affect the renal functions. Hepatic encephalopathy because of inflammation can happen because of the stimulation of microglial cells, which are the immune cells in the brain, and they can increase the ammonia level. The adrenal dysfunction because of inflammation can happen because that it affects reduces the steroid kind of synthesis. And the HPS can also happen because of inflammation, because of the increased secretion of nitric oxide, and this leads on to the pulmonary vasodilatation. All these inflammatory markers can also secrete various molecules which can cause portal hypertension, could also be responsible for organ failure, mitochondrial dysfunction, and decreased ATP. And finally, the cell necrosis and the apoptosis and the cell death which can happen could also be responsible for organ failure. So I think the time will not permit me to get into the more details, but to summarize what I said, ACLF is a pyro concept. So the precipitating events we know can be hepatic and extrahepatic, and these can be known or unknown, and they act as injury, and they then kind of release these PAMs and DAMs which act as inducers. Then they act on these TLRs and other pattern recognition receptors, so-called PRRs, which act as sensors, and then they will release various kind of cytokines, and these cytokines are released from cells like macrophages and all. Then these cytokines act as mediators, and then they lead on to systemic inflammation, and this systemic inflammation is higher than in those who are without ACLF, and this correlates very well with the severity. And to counter this, there is an associated anti-inflammatory response syndrome, and there is a simultaneously immune dysfunction which is happening, and this also increases your risk of having bacterial infection, and this may exacerbate the ongoing cycle. And ultimately, O of the pyro is the organ failure which comes in, and this organ failure is happening because of the hemodynamic changes, what we understand, the cardiac dysfunction, but the inflammation, as I said, per se could also be responsible by various mechanisms in causing the organ failure. So thank you very much for your kind attention, and with this I'll take this opportunity to invite each one of you to Chandigarh in the month of August for our annual conference of NASL happening 7th to 10th of August, and the registration and the abstract submission for that are open. Thank you very much. I'll be happy to take any questions. Thank you.
Moving on with our clinical case discussion on management of AIH related acute and chronic liver failure, role of steroids, plasma exchange, timing for liver transplantation. Our case moderator for the session is Dr. Dinesh Jyotimani. Our panelists are Dr. Sovik Mitra, Dr. Ankur Gupta, Dr. Sachin Palnetkar, and Dr. Ashish Goyal.
Good morning, everybody, and first of all, I would like to thank Dr. Neeraj and Dr. Swapnil for the opportunity. So we're going to have an expert panel. It's filled here, and they all are managing patients with autoimmune hepatitis. So here we're going to talk about management of autoimmune hepatitis in the context of acute and chronic liver failure. So this is a case-based panel discussion. This is a 50-year-old lady. She developed jaundice in October last year, and subsequently she developed ascites. At that point, her bilirubin went up to 32. All her parameters were deranged. Ultrasound showed cirrhotic type looking liver, ascites, splenomegaly. She was admitted to a nearby hospital where she was diagnosed with acute on chronic liver failure. This is her investigations. Her ANA was strongly positive, ASMA was positive, IgG immunoglobulins were higher, and viral markers were negative. Liver biopsy showed, she had a liver biopsy locally that showed features of autoimmune hepatitis, and she received prednisolone 20 milligram. So my first question to, so who's going to take Dr. Sovik? So what you think probably the role of prednisolone steroids in this context? Steroids in autoimmune hepatitis is extremely well established, but we are talking in the context of ACLF.
So if you are talking in the context of ACLF, the question is a bit tricky because obviously you have to
that mic is not.
Yeah. Am I audible? Yeah, it can trigger sepsis or not. But having said that, if the patient is having a low MELD score, low CTP score, no ascites, no encephalopathy, I'm not sure what is this fibrosis stage, then index trial with steroids is well warranted in these patients.
Okay. Ankur, would you try steroids in this patient in this context? We're talking about ACLF, autoimmune hepatitis.
So I am a surgeon, so we are called in once the hepatologist decide that the steroids are not working. But she's already received steroids. Again, the indications for steroid in this patient population would be, as stated earlier, infection should not be there, no frank sepsis. Then basically no advanced failure. I mean, not more than possibly 2 organ failure. So it has to be early in the course of ACLF, not late in the course of
So
ACLF.
you're saying the steroids may be beneficial in a select group of patients with autoimmune hepatitis.
Okay,
any panelists can talk about steroids.
This
There's more
patient
surgeons
Dinesh had
answering.
ascites, right?
Sorry, yeah, she has ascites.
Yeah. So again, I think that's something that would probably take you away, a 32 bilirubin with ascites, presenting as an ACLF with an albumin of 2.8. I think presence of ascites and then in addition presence of infection and a decompensated state. I think that's something that probably, and again the dose of steroids, this 20 milligram of Vizolone, is it really going to help in this situation? I think these are the questions that come to the fore.
Absolutely.
Yeah.
So we are not questioning the diagnosis, that is correct. And the patient is very sick, and is steroids recommended? Is the dose correct? Absolutely, yeah. So the question here, what we want to ask is, what proportion of autoimmune hepatitis presents as ACLF? Around 20%, 1 in 5. And what proportion of ACLF patients are autoimmune hepatitis? As per the recent Kyoto guidelines, it's around 5%. So it's not that uncommon presentation as ACLF. 20% of autoimmune hepatitis are ACLF. So role of corticosteroids, because this is a very niche group, the studies are mostly retrospective and single center studies. So in this study from AIMS, if you look at it, patients who received corticosteroids in the context of apacil ACLF with autoimmune hepatitis, your 3-month survival is close to 50% and 6-month survival is only 30%. Now, if you, as the panelists said, if you have at any point infection during the course of the treatment, your survival drops to 8%. So therefore, this is really walking on a tight fence. So you have autoimmune hepatitis, you're starting them on steroids. If they don't develop sepsis, then you are okay. If they develop sepsis, the survival dramatically drops down actually. Now, who will survive with corticosteroids? So this is a question who can answer. Sachin.
In the ACLF setting, in autoimmune, we should be very selective for the patients on steroids because we should see that the patient is not having moderate ascites or above, and the CTP score and the MAID score is not more, like MAID more than 20, or the patients who are having a jaundice and the progression which is in a controlled manner. These patients will be benefited with steroids with the low MAIDs and low CTP, and ACLF grade 2 and below will respond to steroids, grade 3 and above will go to other modalities of treatment.
So not too sick patients.
Not too sick.
Yeah,
patients,
so you have to choose them very carefully. So again, in this study, the patients who survived are those with MELD less than 24, and moreover, reduction in the MELD score, improvement in the MELD score at 2 weeks. Dr. Saigal, do you want to give any comments here at this point?
Yeah, in a practical sense, when I see these patients are autoimmune presenting first time, and a bilirubin more than 20, raised INR and ascites, actually I've seen that it's very difficult to give steroids to these patients. That's a fact, very difficult. And also, I mean, if you give this, 20 mg is probably suboptimal dose, because, that's not really going to be that effective. Biopsy, I mean, was it transjugular biopsy in this patient?
Transjugular, yeah.
It's a transjugular. So it's a tough call. You're doing a transjugular biopsy in a sick patient, 32 bilirubin, ascites, borderline encephalopathy. I would be very hesitant giving steroids.
Absolutely.
That's my
I agree with you.
Yeah.
In the audience, how many of you would have given steroids for this patient? ACLF presentation, autoimmune hepatitis, sick lady. How many of you would have given prednisolone here? Oh, nobody. Oh, Srini.
Because what is the end point for this patient? The patient needs a transplant, and we're just only prolonging the treatment course for this patient. If there's an option, we should go for transplant.
I mean, we can't straight, I mean, in this scenario it's okay, but we can't write it off saying all ACLF autoimmune hepatitis patient needs a transplant. There may be corticosteroid responder. Sir.
See, this is extreme of the other end. All patients with the cirrhosis, decompensation, ACLF or decompensation, they will need a transplant ultimately. But
Yes.
can we do it? See, these are patients in whom we can try, but if you are trying corticosteroid in such a patient, you have to be very, very careful, monitoring very closely. See, any infection will kill them.
Absolutely.
So,
Yeah,
what you have to do is cover with the good antibiotic, and then after that, don't rush to give the high dose. If you give 40 mg or 60 mg, you will definitely kill this patient. And you have to be patient, and you have to start with the 20 most probably. Although somebody said that it is suboptimal dose, but this is the dose which they can tolerate. And monitor them 12 hourly, 24 hourly, and then look at the various parameters. If any parameter dips, you have to stop it and then plan the next step.
Sure.
Just taking the same point ahead, many a times you know that a patient probably needs a transplant, but it's not easy in the sense the first presentation, the patient comes with an autoimmune related ACLF to convince or to counsel and to for the patients to accept. So there will be some form of medical therapy which they would want. So what do we do in that? That's a moot question. Whether we just give supportive therapy and just wait and see, or whether we give steroids or plasma exchange, that's the whole dilemma in such patients.
That's right. So majority of ACLF, what we see is alcohol and Hep B and all those. But this is also an important cause of ACLF where the treatment modalities are slightly less defined compared to the classical autoimmune hepatitis actually. Sunil.
So I think ACLF is again very difficult group to treat, and we've treated few patients with Plex followed by 10 milligrams of steroids. We come down on steroid. So that's a very small dose, and we followed that SH model. You look at the day 5 bilirubin. If it is improving, you continue. And if they're not improving, then stop steroids at all.
That's a good, valid point.
So any markers like Procal, CRP and other sepsis markers are present, I think there is no role of steroids.
So we should screen them for sepsis before you consider them for steroids. Yeah, okay. So this lady received prednisolone. They didn't see much response. Bilirubin increased, and she underwent plasma exchange in the local hospital. And so this is her pattern of liver function test. Ashish, you published on plasma exchange. So your experience with plasma exchange overall, and in this scenario, how do you say, in autoimmune hepatitis ACLF?
So ACLF, as was described, is a complex disorder and with high chances of sepsis. So that is always a worry with plasma exchange as well. So we will, in this patient, we would have offered plasma exchange definitely. And as Dr. Sunil pointed out, we usually give small dose, even smaller than 20. So we give 10 milligram of steroids combined with plasma exchange. We always cover with antibiotics during the course and maybe even afterwards for some time. So a careful plasma exchange here would be the best way for me, for us to go around. Yes, of course, if there is a transplant option and if we are able to convince the patient and if we are able to offer it, then maybe the transplant may be the first choice.
Actually, two questions. One, when you offer a plasma exchange, what volume do you use? And second is, what's the endpoint that you look at to say response?
Okay, so volume used, we have now got we use low volume, which is 0.5 times the estimated plasma volume every day for at least 3 sessions to start with. We extend it up to 5 to 7 sessions also. How do we stop it? Patient multiple factors. So bilirubin, maybe other endothelial activation markers, other things. We make a composite decision, but it's not a clear-cut decision when to stop it. As far as whether can we use low volume, normal volume, most centers use standard volume, which is 1 time the estimated plasma volume. And recent systematic review, which will come shortly, we have completed that. showed that whichever volume we use, plasma exchange works irrespective of the volume
So
used.
we'll ask the audience, how many of you would have used plasma exchange in this context? Okay. And so there is a slightly difference, you said use steroids and plasma exchange together. In this scenario, they've already started prednisolone and then plasma exchange, and then Sunil recommends they practice plasma exchange followed by steroids.
So what we do is all plasma exchange, we start steroids before we start plasma exchange, one day at least, one day before, but we never give 20 milligram as well, because people find maybe in this situation the infections are too high risk and they define prognosis. So we give 10 milligram and we continue for definitely the duration of plasma exchange and beyond, depending on the clinical response.
Sure. So at this point of time, I would say, it's slightly unclear the role of plasma exchange, and in this scenario, okay, in autoimmune hepatitis.
Dinesh, what Ashish, were you mentioning that when you start load of steroids and you do plasma exchange, then you continue both together at the same time? You do both plex as well as
plasma
steroids?
exchange is for 3 to 7 cycles and we stop.
So during the time you continue with steroids as well?
And the steroids can continue beyond plasma exchange cycles.
I'll ask ma'am, in pediatric population, would you handle it any
Yeah,
differently?
no, what I wanted to say is, well, I was reviewing literature for adults also, because recently we were trying to look at guidelines for autoimmune hepatitis nationally. And while we were looking, so we were looking into the literature there. Yes, we do plasmapheresis and the literature is improving, but whether we talk about the adults, the EASL or the SLD and all, I mean, they were a little old, so they are saying that these data are emerging. But one thing was very clear, that if you offer plasma exchange, that would be early and you would reassess between 4 to 7 days. And it is at that time, 4 to 7 days, if you find it improving, then you would, go on with it, because we know autoimmune hepatitis is one condition which is immune mediated, and removing your antibodies and cytokine theoretically sounds very lovely that it should be, and since there is neuroimmunosuppression in the long term, it is advantageous to shy away from transplant and use immunosuppression to treat it, because the grass is not green on the other side too. However, we do not want to delay too much. So if we do not find improvement within 4 to 7, like you showed in your patient, I can see again it's like coming back. We wouldn't want to then wait, we would want to go ahead with a liver transplant. And as everybody said, basically when we talk about ACLS, the primary hit is the cirrhosis and the secondary hit is what we are talking. If the secondary hit, if it is a flare or a drug, it's easier. But if the secondary hit is an infection, then obviously you're in a different soup and you would gauge them differently. So that's how we would go with
Sure,
it.
ma'am. Thank you. I'll ask Ashok, your experience with plasma exchange in this autoimmune hepatitis ACLF.
I need 3 things. First, what is the MELD score of your patient?
MELD score is high. I mean, bilirubin touched to INA.
We have also published a MELD score below 29. You can think of this. 2 large varices, large ascites or grade 3 ascites, or histology showing having significant necrosis. If so massive necrosis, these are the people we should not venture into steroid from the beginning at all. That is one. Then presence of having a large grade 3 ascites, large varices, biopsy showing loss of hepatocytes. Obviously plasma exchange is plus minus, but that is the only thing you can afford little bit safe. So to me, in this patient, I think we should from beginning, I'll go with plasma exchange alone for 3 cycles. Then we'll see how it is behaving. Then as Dr. Assis suggested that we should go another 2 or 3 sessions. Then only I can offer steroids, neither plasma exchange with steroid combination, not steroid from the beginning. I should think of plasma exchange, then I will see for 1 week how he is behaving, systemic components, source, sepsis nodes coming up. If stable enough, then I can try for a steroid.
So as surgeons, how do you feel when a patient like this, sick patient, already given steroids, already had plasma exchange, coming for a transplantation? What would be your thought process, dealing with the sick patients?
So these patients who have who are either cannot get steroids or who have failed steroid therapy, and plasmapheresis, of course, has been used as a bridge, like in this transplant. Yes, we'll go for transplant, provided, of course, there are no contraindications like active sepsis going on, or patient is too hemodynamically unstable. We would obviously accept this patient for transplant.
Prashant, any?
I strongly feel that 10 milligram steroid is for physician satisfaction. I don't know. There are senior hepatologists here whether it's really any sense in using steroids in these patients. And I would agree with Ashok that I would go for plasmapheresis from the beginning. If you are even waiting as a bridge for transplantation, you're working this patient up. You look at that golden window period of 7 days. Do plasmapheresis initially. If you have telltale signs that this is not going to salvage without a transplant, I would think of a transplant.
Dr. Prashant, Charles, yeah, if the patient's got a donor and they're willing for a transplant, would you still want to do a bridging, or you directly go for a transplant?
No, I don't think that there is any evidence at present to show that bridging really helps in these patients. So if the patient has a donor available, ACLF, I would work this patient up in 2 to 3 days and
go for a
go ahead
transplant.
with transplant straight away.
So how many of you would offer upfront transplant to these patients without plasma exchange, without stent? So quite a few, quite a good number actually there. Okay. So this patient came to us and bilirubin was 27, INR was quite high, quite sick. She already been tried on other modalities. This is a scan showing a cirrhotic liver, splenomegaly, ascites. So we recommended liver transplantation for her, and so she underwent transplantation. So what is the experience on autoimmune hepatitis and liver transplantation? Autoimmune hepatitis, ACLF as an indication for liver transplantation. Anybody in the audience? Autoimmune hepatitis is a common indication for liver transplantation. So the survival wise, any different to others? Sachin?
As far as the survival goes, they are on immunosuppression. The only thing is that they are on a longer period on steroids, so not less than 6 months or year, but they are having a good survival, but the recurrence rate sometimes is high, especially in a patient with overlap or PBC with autoimmune, the recurrence is high. So we can straight away go for transplant, and the success rate is good post-transplant.
So autoimmune hepatitis is one of the common indications for liver transplantation, and the survival, as Sachin said, it's quite good, patient and the graft survival. However, you need to modulate their immunosuppressive medications slightly compared to other patients. So liver transplantation for autoimmune hepatitis related ACLF, this study actually nicely showed that what determines the outcome is not the degree of liver damage in the ACLF, but actually if you have kidney injury, your ACLF has slightly reduced survival. So what this indicates is if you're higher grades of ACLF, like in other conditions, your survival may be slightly lesser actually. Prashant, any comments for this here in this situation? Somebody who has already had a plasma exchange, steroids, and they have some degree of kidney injury, but no sepsis, they're coming in for liver transplantation. You've been given a very sick patient for transplantation. So any comments on that in terms of, this is a LDLT scenario maybe?
So I think having received steroids, been in hospital for a long period of time, I think that itself is a straightforward, plus having received plasmapheresis. So that's a sitting duck for having infections post-transplant. So generally in these patients, we would actually even think of upgrading their antifungal cover in the perioperative period. Obviously we give antifungal prophylaxis in all, but here I would go to a higher antifungal since they've had lines for a long period of time, they've had extracorporeal circulation. So the antibiotic cover, antifungal cover would be high, number one. I expect a higher perioperative mortality in these patients, up from about 5% to about 10% in these cases because of the chances of infection post and because of hospitalization, hospital acquired infections, everything else. But kidney, I think we are slowly moving away now from contraindicating patients for transplant who have creats of 2 and still are producing urine, not having significant metabolic acidosis, not having, anuria. I think, we are moving away from contraindicating them, knowing very well that it takes it from grade 2 to grade 3 ACLF or whatever, an additional organ dysfunction with a slightly worse mortality. But solely looking at the kidney and AKI, I would not shy away.
Sure.
And of course, AIH with ACLF will be similar to any ACLF. I think outcome is determined more by the number of organ failures rather than the disease itself.
Dr. Prashant,
Dr.
sorry.
Saigal, you want to put some...
Just brief comment, very briefly. One is that we all agree that sepsis is the biggest challenge here. But we need more clarity on thing with Ashish mentioning. I'm not sure whether a combination of plasma exchange and steroids both at the beginning is like something which we should follow. We need more evidence for that. Plasma exchange, yes, it is a modality. It's good modality. There's no question about that. If you can use, you should do that. Renal dysfunction, which is happening, is going to be there, but this young patient, younger age group, autoimmune, I think autoimmune is an excellent indication for liver transplantation. So I personally feel that unlike other patients, autoimmune patients should do very well. And even if they're sick, I would not shy away. Even if they're sick, I would go for them. If there's a opportunity for me, I would offer them a transplant, and because I know that they can sail through despite some other organ problems.
And these patients may require slightly higher immunosuppression in the post-op period, but yeah. So, so is steroid truly beneficial in decompensated cirrhosis? In the interest of time, I'll just go through the slides. Answer is yes. Your median survival improves even in patients with decompensated cirrhosis, even in the absence of transplantation. However, if you have ascites or if you have a higher MELD score, then you should be very careful. ACLF patients often have ascites, but if it's mild ascites or only liver failure, then still you may give steroids. Whereas if they have other organ dysfunction or if they have moderate ascites or severe, or with hepatic encephalopathy, you should be very careful. This is the only prospective study I could see where patients with ACLF did well with steroids. They have reduced ICU stay and improve 90-day survival. Sepsis rates were very similar when they received steroids. But only thing is, patients who have poor response to steroids are those with higher MELD of 27, hepatic encephalopathy, higher grades of fibrosis, and also hepatic necrosis in the biopsy. If they have large areas of necrosis, they do poorly with corticosteroids. And these patients may be offered liver transplantation upfront, actually. This is a nomogram. I thought I would go through that. Just last slide. Do you want to add anything, Charles? You want to say something?
No.
Okay. So if you have, this came out of the multivariate analysis, if you have increasing age, higher MELD score, ascites, encephalopathy, you give them score. Say for example, if somebody who's 70 or 60 years of age with MELD of 21, your score is already 7. And if you have ascites and encephalopathy, your score is 9. So if you score 9, your survival, 90-day transplant-free survival is only 50%. So there's no point in giving steroids to these patients. You may consider going for upfront liver transplantation. And also similarly, response to steroids. So if you give steroids for a week, and we need to know whether these patients respond or not. Once again, you can use the score here, what the MELD score is. If the MELD score doesn't come down with the use of corticosteroids, or the ascites is still persistent, patient is still encephalopathic, once again, they are non-responders to corticosteroids. Therefore, you should consider them for early transplantation. So in conclusion, I would say autoimmune hepatitis presenting as ACLF is a challenging situation, unlike without ACLF. Trial of corticosteroids may be tried, but balanced against risk of infection. Assess the response to steroids in a week's time. A role of plasma exchange in this situation needs further clarification. Early transplantation should be offered upfront if the MELD is more than 27, if they have other decompensation like encephalopathy or increasing ascites, or if they don't respond to steroids. Thank you. Thank you once again. Thank you all the panelists and moderators for this interactive session.
Thank you, sir. Now the house is open for question answers and expert insights.
Yeah, thank you, Dinesh. And can I just start with asking the experts So we talked about inflammation in ACLF. Are there any, other than the total leukocyte count, are there any other inflammatory markers that can be used for prognosticating these patients with ACLF? One. Second, can we prevent progression of ACLF by using any of the anti-inflammatory drugs that are currently available or in the pipeline? Are there any drugs?
Nice. NLR, the neutrophil lymphocyte ratio, is already published. 3-4 articles are there. It's a very simple marker. If you more than 13, they are likely to have either existing infection, they are having more inflammation and prone to develop infections, and indirectly towards the organ failure. So that is a very simple bedside, you can say. Otherwise, no other parameters for the answers for the prediction from this.
Can we use interleukin 6, TNF-alpha, all those things?
No, there's composite parameters you can think of. Now, last is they have used metabolomic score. They come with the metabolomic score that they are profiling for the glycolysis pathway, protein pathway, and from there they develop a score. So that are the few value additions to do, but that is not routinely used. And the second question you asked about
any of the anti-inflammatory markers, you have the IL-6 inhibitors, you have other anti-inflammatory drugs.
No, they have been tried for the alcoholic hepatitis. I think that increases the mortality, not for the SLF. So no others, but now HMGB CoA, there is some HMG CoA inhibitors, which is basically inhibits the transmigration of the inflammatory parameters. This is an animal studies and phase 1 of the clinical trials coming up. Or there is no parameter available for the anti-inflammatory actions. All has been tried as a failure. Infliximab or whatever you say.
And
we talk about.
Just add one point here.
Yeah, please.
We do a bit of inflammatory markers beyond the, and we have published on macrophage activation. So, as Dr. Ajay Duseja pointed out, monocytes play a key role. So, we do, we have found ferritin as a good marker for ACLF prognosis. Other markers that we use is von Willebrand factor and other things which are macrophage or endothelial, reticuloendothelial activation. And part of the mechanism of plasma exchange may be actually anti-inflammatory. So what you are speaking about is there any anti-inflammatory procedures? So I think plasma exchange partly will work through anti-inflammatory procedures, and maybe a cytokine cleaning or other markers may be useful in that.
And we talk a lot about bacterial translocation. So are there any studies that target the bacterial translocation? Any ongoing studies or in the future, anything?
I think you think of FMT or the gut modulation by probiotics. I think there has been 2 studies. Then Anand Kulkarni shows that norfloxacin prophylaxis little bit helpful. So these are the 2-3 trials targeting the gut micro translocation related inflammation injury. That is one. That I am name forgetting that Homeobox G, I think HMBG. That inhibitor is coming up multiple pathways. That is for the bacterial translocation, nuclear, and at the last it prevents the LPS correlation integration. So this is a new drug which is coming up mainly in the basic domain. So that I just got a review in article that is very interesting one. So they are doing. So this is only one I can say in the pipeline for the inflammatory mediated modulation of the SC.
Any question from audience?
Just again revisiting the plasma exchange, I think the message should in ACLF has not been found to be of any significant role in most studies. In the sense, we have to differentiate between ALF and ACLF. I think in plasma exchange, the message should not go that we should use routinely if the patient is sick, because there is no endpoint to plasma exchange, unlike in ALF where there is a hepatic regeneration. If it is a cirrhotic liver, I think we are not looking at, so for just as a routine to use plasma exchange in every ACLF where we cannot give steroids, I think that is, there is no evidence for that.
So would you agree if I say that if your MELD score is lower, you should go for plasma exchange? Because when we say ACLF, it's not necessarily that it's always the extreme end.
Just supportive management, management, and
at least in children we see that in the earlier PEL scores, whatever.
Ashok, can you counter that?
Plasma, you will find it easier. But when they are advanced, no. So that is my thought, that it should never be a no, it should be individualized to that patient. where you are able to assess how severe the patient is in terms of their score.
And my problem is with sepsis.
Including the
we
cliff
consider
score.
plex as a safe procedure, but it is not absolutely safe, and the risk of sepsis is much higher in ACLF than in the ALF cohort. So that is where
No,
the whole
Amit,
issue is.
sorry ma'am. I just want to add, ALF, you think that liver failure is a must, that bilirubin, INR, HC should be there. But in ACLF, there is a big confusion between East and West. If you think of liver predominant ACLF, definitely plasma is going to help. If infection is not a precipitant, if liver failure is at the core, definitely there is some role as far as liver, bilirubin, INR and hepatic encephalopathy is concerned. I think the same we have done a meta-analysis.
They always coexist. I think we can never rule out sepsis in an ACLF cohort.
Then we have done the meta-analysis. I think Dr. Ashish can tell the results.
Maybe I'll just add before Dr. Anand says something, just 2 seconds, sir. I think ACLF is a big basket diagnosis with the current definition, APASL, EASL, hepatitis B with underlying chronic hepatitis and not cirrhosis. So we are not talking about underlying cirrhosis all the time. So it is always with any procedure there is a window of opportunity. That window will close sometime. So that window is what we have to define, and we all have to define our own windows where we can safely offer plasma exchange.
I'd like to ask the experience of the expert panel about patients of ACLF who are found fit for transplantation and they are being bridged with plasma exchange for the transplantation. Has it ever happened that during that bridging period they have been made unfit for transplantation due to worsening sepsis?
Yeah, I think this is a very, very important point, and this is what I would say. I mean, I personally feel that the success of bridging, for example, is very low. I would disagree from Ashok that in ACLF per se, I would not, I don't think there's evidence enough to support plasma exchange in general. It's only specific autoimmune hepatitis where we're talking of, where I think it's a different thing. And this also is AIH is more presenting like an ALF. This patient is presenting more like an acute liver failure. So in a standard, I just reviewed this and we published a review article of JCH about the role of therapeutic plasma exchange in hepatology in general, where we extensively reviewed about this. We also had published recently with the Dean Carvalha's manual on acute liver failure, which also got published last month. So what I understood was that ALF, there is a specific role which of plasma exchange I'm talking possible. ACLF giving plasma exchange and bridging and transplant, I think it is talked more often, but I don't see that practically it's possible. But your other point is more true that you may end up in sepsis, and actually if there's a living donor patient who's very much fitting a transplant scenario and it's not autoimmune, then it is better to do an upfront, which I think Prashant would like to do that. Whereas in such patient, plasma exchange is very controversial.
So, yeah, sorry. Can we conclude that in a very sick ACLF patient, not autoimmune, but any ACLF who are very sick, they should be offered an upfront transplant? And if you want to do a bridging for any reason where there's a waiting period, it should be done only in a transplant center.
I mean, this is a very weak bridge, to be honest with you. So
Yeah.
I don't see there's evidence strong
we
that
can't,
we can.
there's no endpoint to that bridge.
Yeah.
So in addition to infection, like Dr. Anand said, one more thing that we've lost patients is with ARDS. So patients who undergo high volume exchange or patients who are undergoing not the low volume plasmapheresis, many a times go into this ARDS with secondary hospital acquired infection, and we lose those patients. So one has to be very careful, and now our ICU critical care guys are going more towards, rather than doing a plasma exchange, to plasma filtration. So they've changed it. They do it with a lesser amount, and they do it with a plasma, not a full plasma exchange, but they do a filtration procedure, which is over a short period of time. It's only over 4 hours that they do this, and then they probably go on to, if at all required. But again, to stress the point, in ACLF, there is no evidence for plasmapheresis, and I would not do it if he's a straightforward candidate for transplant and I have the logistics available.
I think the most...
Dharmesh, want to...
So I think Dr. Anand asked a very pertinent question. One could rephrase that question, and probably all of us are speaking from the experience that we have in our centers, which might not be huge, but I'm sure there are databases, and if there are some overseas colleagues over there So there are two things to define. One is that you become very sick and you are delisted for transplant. But what about those who had an exposure to plasma exchange and then they get transplanted? What are their outcomes? And these need not always be with respect to survival. It could be length of ICU stay, needing various interventions, length of hospital stay, and coming back in again. Because I know that we are in Delhi and we are talking predominantly of living donor. I have my reservations about living donor and DDLT in this situation. More importantly, steroids. So that's something that we can all very easily answer. So 40 milligrams, 20 milligrams, 10 milligrams. And I'm sure there would be enough even in databases in the Western world, where again now it's become very commonplace, slightly digressing from ACLF, AH, who have been exposed to steroids and then they undergo transplant. So you know the seminal study was that, Philip Emathurin study was that every patient received steroids, their Lilly score did not improve, and then they went on to undergo a transplant. So 6 out of 26 had invasive fungal infections and 5 of them had invasive aspergillus. So I think these are questions which are very easy to answer, provided we go back to those databases. But we keep talking somehow all the time about 0.5, 1, 1.5 high volume. I would in any case go with, Finn Larsen's group. So that is a group which has been using plasma exchange for decades. And that group has serially done plasma exchange volumes. And their last paper, which got them a category 1 for the American Society for Apheresis, which is ALF, is only with large volume plasma exchange, not with any other volume. So I'm not saying that that was a great study, but I think there is a lot to learn from what already exists. Probably we've not gleaned literature enough to know.
Okay, thank you. So to conclude.
So if there are no more discussion, then thank you, Dr. Dinesh, for all the excellent case, and thank you all the experts and panelists for the case. Thank you.
Thank you, sir. Now I'd like to request all the doctors involved in the session to kindly come for a photograph near the photo booth.
So our third session is on portal hypertension. Let's invite our moderators for this session, Dr. Dilip Sharma sir and Dr. A.S. Puri sir. The expert discussants for this session will be Dr. Gaurav Pandey, Dr. Virendra Singh, Dr. Puneet Mehrotra, Dr. V.A. Saraswat. Simultaneously, let us also invite a speaker for the session lecture, Dr. Akash Roy sir, who will speak on portosinusoidal vascular disorder. The expert discussants will be here on the right hand side.
To make our sessions more interactive, we have included the voting. The voting pads are placed on each of the round table, and we'll request the speakers to involve the audience in the voting.
Thank you, respected chairpersons, and thank you to the entire organizing team from Medanta, Neeraj sir, Swapnil sir, and Narendra sir for the invitation. It's always a pleasure to be here. So the topic that's been assigned to me today is portosinusoidal vascular disorders, screening, evaluation, and management. Before we move on to delving into the intricacies, let's first start with a poll, which is, which of the following is incorrect about PSVD? Number 1, liver biopsy is mandatory. Number 2, absence of cirrhosis is mandatory. Number 3, presence of portal hypertension is mandatory. Number D, ascites is a part of the diagnostic criteria? It's an easy question starting from the definition and classification, so I expect that everybody's going to get it right. Can we have the polls, please? So the majority chosen option is that ascites is a part of the diagnostic criteria is incorrect. Unfortunately, is not the correct option. So we'll come to this. So this is why I had put it up. Things look simple from outside of what PSVD is, but as you go and try to deliver into the intricacies, you find some things which are not clear. So that brings to the next question. Can I have just a show of hands, how many of us here are clear and confident about PSVD? 1, 2, 3, 4. I'll not count Akash sir here. 5 out of a house of which is, I think it would not even be 10%. We'll come back to this again. So, agenda, first of all, why PSVD? So we go back to a brief history in time. That portal hypertension, if you see broadly, you will classify as cirrhosis and no cirrhosis. And in no cirrhosis, you've got many names. Over time, it has undergone transformation of changes, starting right from 1959, then seminal works from Japan, from Kolkata, from Professor A.K. Basu, and other sequential works coming out of Europe, which led to different nomenclatures. And there was a final consensus nomenclature of idiopathic non-cirrhotic portal hypertension, which was going through quite well until again it was decided to have a name change, which now has become very common in hepatology to come up with newer and newer names. So if you see this, it's like a garland of terms which are actually separated by geography and pathology, because some terms originated in some geographical areas and some geographical spots and got named in that way, and others are pathological terms which got translated into establishing the diagnosis. But overall, they all tended to inform to a possible similar pathology and a similar progress of disease. So what triggers any new nomenclature? For any new nomenclature, there has to be gaps in knowledge. If you don't have gaps in knowledge, there is no point in having a new nomenclature. So the group which proposed the new nomenclature of portosinusoidal vascular disease, or PSVD, argued for some limits of the nomenclature of idiopathic non-cirrhotic portal hypertension, and they were, number one, it excludes absence of portal hypertension. That means if you don't have portal hypertension, but you have a group of diseases which behave similarly, you will be excluding them. Number two, it excludes concomitant pathology. We know the presence of MASLD is upwards of 30%. So you're excluding all those groups who have got MASLD from the diagnosis because you can't have concomitant pathology. You're going to exclude hepatitis B, you're going to exclude hepatitis C, you're going to exclude autoimmune hepatitis. And lastly, you exclude portal vein thrombosis. And they argued that portal vein thrombosis can be present from before, or they can be incipient in the natural history of the disease. So based upon these three cardinal points, and if you go back to the original paper where the statements come out, the philosophy was that since these three things are absent, you need a way to unify these concepts so you can simplify and bring about a new terminology. So this new terminology was an attempt to unify clinical characteristics, which we termed before as non-cirrhotic portal hypertension, idiopathic portal hypertension, and those histological variants, which have a philosophy which I believe, which stems from something which is aberrant in the hepatic vasculature and is triggered by some abnormalities of some factors which can be inflammatory, which can be systemic, or it can be hypercoagulation. So the idea was to unite these two concepts and bring about a definition. So this is what the definition and diagnostic criteria of portosinusoidal vascular disease is. Let me walk you through that. What you need was the first option in our question, that liver biopsy is mandatory. The second option of the question was absence of cirrhosis is mandatory, and if you see, liver biopsy has to be without the presence of cirrhosis. Plus, you have either a specific portal hypertension sign, which you come on the left side, which is varices, portal hypertension related bleeding or collaterals, or you have got a specific histology like obliteratory portal venopathy, NRH, or incomplete septal fibrosis. Or if you don't have those specifics, then what you have to have non-specific signs like ascites, a low platelet count, a spleen size of greater than 13 centimeter, and a wide variety of histological signs. So if you satisfy these two definitions, then only you go on to have the diagnosis of portosinusoidal vascular disease. So those are very much based upon histology, and histology is the essential core of making the diagnosis. But for clinicians, those histologies are not always clear. So let me walk you through some of those histology. This is a classic trichome staining where you see there is minimal fibrosis. Next, this is what an obliterated, you see the portal vein in the center, and this is what an obliterated or a stenosed portal vein would look like for clinicians or lay people like us. Then you had portal vein abnormalities. You see there's a patent portal vein, but there are branchings and herniations of the portal vein. And lastly is what we classically see as nodular regenerating hyperplasia, which is again sort of a sine qua non or 1, 2, 3 of those characteristics. So that's about the histopathology. What about the associations? This entity has got certain associations which can be hematological disorders, immunological disorders, multiple drugs, genetics, and infections. All of this, and this goes on to a long list of entities which have been associated with this disease, but it also has some exclusions. It excludes bone marrow transplant and SOS like physiologies which happen after transplant, outflow tract obstructions, schistosomiasis, congenital hepatic fibrosis, any cholestatic or infiltrative disorders, presence of cardiac failures, Fontans or post-Fontan status, disorders like HHT and Abernathy. So you'll have these associations and exclusions. The exclusions need to be met prior to making the diagnosis. So if you see the clinical presentation, you would be dividing it into two parts, and that's what the third part was, that presence of portal hypertension is not an essential criteria for the diagnosis of PSVD. It can happen in the absence of portal hypertension if you have specific histological criteria which is there in the biopsy. So how can they present? They can present in two ways, either with portal hypertension or without portal hypertension. If they are without portal hypertension, they're usually asymptomatic, abnormal chemistries, thrombocytopenia. With portal hypertension, varices being most common, ascites then, or hepatic encephalopathy. If you see the natural history, if I go back, the left-hand group has excellent outcomes, though we still do not have good quality natural history studies on these entities where you are labeling it as PSVD, but you do not have a long-term history data, but we presume that they are going to be excellent based upon some studies when you do their subgroup analysis. Once you go to the other part, which we think that the PSVD population would be doing good, this is the recent, this year's JHEP paper, which actually shows some of the determinants which bring about poor prognosis in patients with PSVD. We had a nomogram in the last discussion. This also has similar conditions of advanced age, associated conditions, creatinine, bilirubin, albumin, and ascites at diagnosis, which indicates towards a progressive liver disease. So this indicated that this is possibly not a very benign course of the disease. Third step is radiology. There are multiple imaging characteristics that you're going to look at. I usually like to break it down into, you look at the liver, you look at the portal vein, you look at the spleen, you look at some other features, and if you have the facilities for invasive assessments, you're looking at the invasive assessments. So just like we saw histology, let's see what some of the radiology is for clinicians. Ultrasound, smooth liver, you see the portal veins, there is thickening around the portal veins. You go to an elastography, you've got a liver elastography which is lesser than a splenic elastography. You see a CT, a smooth non-nodular liver which is almost there in around 80% of the cases, and you see what's known as the hypertrophy of your segment 4. Then you see abnormalities in your right lobe, large dilated portal veins, large spleens, peripheral portal veins which are abnormal if you see at the end part of it. And lastly, if you've got characteristic features of NRH which are there, they also become conclusive. Elastography to approach to PSVD, the idea being simple, that in comparison to patients with cirrhosis, the elastography for patients with PSVD would be lower. And you can take it ahead to add into splenic stiffness to it, that the splenic stiffness in patients with PSVD is usually higher than those with other entities. And you take the ratio of the splenic liver stiffness to splenic stiffness, and this small study has found an excellent AUC of upwards of 0.9 for the diagnosis of PSVD. So if you summarize these two evidence, this is from Suprabhat, that you have these specific imaging characteristics, and if you put in the LSM features, they give you the ways to have a non-invasive diagnosis of PSVD. So if you go to a radiologist who is looking at these parameters, looking at a CT and an LSM, this is probably how you're going to look at that. You've got a smooth liver surface, a normal size or an enlarged segment 4, you've got an LSM of less than 10, you think about PSVD, biopsy is essential for the diagnosis. You've got a smooth, similar faces or either of the two, but you have an LSM which is in between, that's 10 to 20, not at the lower cutoff of 10, you remain in the gray zone. Again, you need to have a biopsy for your diagnosis. If you are on the extreme end of it, then possibility or probability of having PSVD is low, and you would be difficult to term these entities as PSVD. Coming to management, the management options are actually data which is all derived from cirrhosis and portal hypertension. You have to identify any offending agents. In those without portal hypertension, we do not have any evidence as to where any therapy works or not, because the natural history is still not clearly known. The role of anticoagulation is again debatable and not a universal recommendation for evaluation or anticoagulation. Rest of it comes from data which is mostly from cirrhosis, small studies which have been looking at outcomes of TIPS and other parameters. One single study on liver transplantation, 2023, is around 79 patients who were transplanted for complications like refractory ascites, hepatic encephalopathy, modest overall survival, some degree of recurrence of PSVD post-transplant. I leave you with some thoughts to ponder. I asked you about awareness of PSVD, and we saw a 10% hand. This is a survey that comes out of Korea from gastroenterologists, pathologists, and radiologists, and it's similar. 80%, 70 to 80% had no idea what PSVD was. If you see how pathologists, this diagnosis is based upon pathology. This is a study on IBD patients with NRH. When you looked at concordance between pathologists for NRH, and NRH is a sine qua non diagnosis which you can have in PSVD, the concordance was 0.2. Look at the inter-observer variation, 14 to 71%. That brings some questions, which are additional to it, that single biopsies have limitations. They might overdiagnose your finding, they might underdiagnose it. Your natural history that was shown in the JHEP paper is very unclear. We do not see people who we originally termed as INCPH behaving the way that those patients behave, which is more like a child B cirrhosis. And lastly, you're clubbing together people who have portal hypertension and others who have only histological features without any complications or any features. So we summarize the approach to PSVD, look for the appropriate scenario that it exists, look for signs of portal hypertension. If there are no signs of portal hypertension, you straight away go to a biopsy. If there is an agent which is associated, you stop the agent, and we don't have any other options. If you have portal hypertension, manage portal hypertension as per the sequence.
You can combine LSM along with SSM and the radiology. But whether we embrace PSVD as a term, which emanates a thought from what today's conference proposed of promoting younger people, is this lines which have been again used from Professor Serene in one of his letters, that a scientific truth does not triumph by convincing its opponents and making them see light, but rather because its opponents eventually die and a new generation grows up that is familiar with it. We look forward to the next generation, whether we would accept and embrace this term PSVD, or we would generate our data to say that what we had originally described actually holds good. Thank you, everybody.
Well, thank you, Akash. That was a very good coverage of a new topic. But just to be a bit provocative, I would ask you, are we convinced that PSVD, we should surrender our old familiar NCPF and now move on to PSVD nomenclature? PSVD number one is based on histology. As you have just shown, histology is very far from being reliable or being a gold standard in this situation. Even pathologists don't tend to get to agree with each other whether this entity exists or not. Apart from OPV, obliterative portal venopathy, NRH is seen in at least 15-20 other conditions which have a very different prognosis and outcome, and to make it a sine qua non of a new condition, it appears to be a bit of a overkill. And similarly, incomplete septal cirrhosis, which they are saying is the other typical feature of PSVD, is a part of the evolution of cirrhosis. Alcoholic cirrhosis, as it is evolving in one region, you might find incomplete septal cirrhosis. When you treat the etiology and the cirrhosis reverses, then you might find incomplete septal cirrhosis. So if you have read the editorial by Professor Serene on that natural history paper in JHEP, his argument is that you have misclassified people with cirrhosis as PSVD because you've included ALD, MASLD, every etiology of chronic liver disease. And with these, what I personally feel are not very specific features, you are calling them PSVD while they're actually cirrhosis. And the natural history you have shown of these in the European cohort is closer to cirrhosis than to our NCPF. So I think it raises a big question mark about the validity of this entity as of today without prospective studies following the histologic features and seeing what happens to them 10 years down the road.
I agree with
sir,
each and every point what Sir has made. I do not agree with this umbrella basket being proposed. It is too heterogeneous, it's too unclear, it's possibly a way to collect multiple things so that you get a large number of patients and a large number of groups. We need to be more selective, the science needs to be better. Such clubbing of umbrella science actually would not lead to better patient outcomes, because patient outcomes is our ultimate priority.
Akash, we'll have the discussion at the end of the
small
session.
comment?
We have dedicated 20 minutes time for discussion at the end of the session. So thanks, Akash, for filling our gaps in knowledge on PSVD. We will like to request you to take the seats, and we'll like to call the next panel for the management of refractory ascites. Akash, you can sit here. We have panelists who are sitting.
So the case moderator for the clinical case discussion is Dr. Mridul Dharwad and Dr. Akash Shukla. The panel members are Dr. Amritangsu Barkakoti, Dr. Amit Gupte, Dr. Naveen Kumar, and Dr. Ramit Mahajan. I'm sorry.
Good morning, everyone. I would like to thank the management for the invitation for this presentation. We'll start with the case. It's a management of refractory ascites, midodrine Wapton's, TIPS, and post-TIPS complication.
So this is how it will go. We'll have Mridul who will be presenting the case, and then we'll be asking the questions to the panelists, and then we'll have the experts commenting on that at the end of it.
So just a slide, what is refractory ascites? So it has been defined by the International Club of Ascites as an ascites that recurs within 4 weeks after large volume paracentesis and cannot be prevented by medical therapy. And we have certain criteria which have been adapted from Moore KP et al., like lack of response to maximum dose of diuretic, diuretic induced complications, early recurrence of ascites, persistent ascites despite sodium restriction, mean weight loss less than 0.8 kilograms over 4 days, and urinary sodium excretion less than the sodium intake. So we'll now go to the case and see how we can make a strategy for the refractory ascites. So this was a 57-year-old male, no history of diabetes mellitus or hypertension, alcohol-related liver cirrhosis, first diagnosed in 2021 when he had an GI bleed for which a band ligation was done, currently abstaining and has been on beta blockers. Started developing ascites since Feb 2023, initially controlled on diuretics. There has been a doubtful history of IHD. Angiography has been done, but probably not significant coronary artery disease, and was only on ecosprin. Salt restriction was counseled and has been confirmed by the relatives. Currently on torsemide 20 mg and spironolactone 100 mg. But now, since the last 3 months, has had undergone 6 times large volume paracentesis every 15 to 20 days. These are the examination and labs. Blood pressure slightly on the lower side, 90/45, grade 3 ascites. Labs, creatinine this time first on presentation to us has been 1.26. Liver-wise, bilirubin 1.26, enzyme 6447, albumin 3.2, triple H negative. USG showing typical features of cirrhosis, no PVT, no HCC. MELD 11, CTP B7.
So Amit, we'll start with you. So I don't think there's any problem with diagnosing refractory ascites in this patient. But do you really have a checklist which you say it has to be tick marked before you label the patient as refractory ascites?
Yes, so basically refractory ascites, the definition given by the International Ascites Club is quite sort of strict, and but still before labeling someone as purely refractory ascites, we need to first see whether the medical therapy is optimized, which is most importantly salt restriction, which many times doesn't happen. There is a lot of occult sodium intake that happens with the diet. So that is something that history-wise and based on urinary excretion of sodium or spot urinary sodium potassium is something we can check and see. The diuretics as well, whether the patient is receiving optimal maximally tolerated dose of diuretics, and also the type of diuretics that we are using, because we need to counteract the RAS system which is hyperactivated. So aldosterone antagonists have to be the backbone of your diuretic therapy. Also whether as you have mentioned, whether the patient is having intravascular volume depletion which triggers more of RAS is something that is also very important. How much is the blood pressure? Sometimes the BP is on the lower side and patient may be on certain drugs like beta blockers and then if there is lower MAP in presence of beta blockers, then we need to stop them. Whether there are any other structural issues like portal vein thrombosis, hepatic vein outflow tract obstruction, presence of HCC, which will worsen the portal hypertension and increase the risk of make the ascites more difficult to control. And finally, whether we are dealing with some other pathology. We have a patient of liver cirrhosis who is having large ascites but not much of pedal edema, preserved liver function. Then we need to be sure whether we are dealing with some other pathology like peritoneal TB or carcinomatosis of peritoneal carcinomatosis. So all these things have to be ruled out before labeling liver-driven refractory ascites.
Yeah. Thank you, Amit. One request to the panelists, we'll restrict your answers, try to restrict answers to around 60 seconds, otherwise we'll not be able to finish, and because we need our experts also to give. So this is a rapid fire. So 60 seconds per question. So Naveen, how do you counsel your patients for salt compliance? Are you very strict, or you go by the JHEP editorial around 5 years ago where they were said that you have to be liberal so that the nutrition is not compromised?
I am liberal with the salt intake because if the salt intake is too restricted, then that will lead to sarcopenia, and that is going to increase the morbidity and mortality. And my advice is just whatever the salt the patient has been regularly taking, just make it half, because the average Indian salt intake is around 10 gram per day. And if we make it half, then it is around 5 gram per day, which is the recommended salt intake.
Okay. So I think we can have an audience poll on this. How many of you will advise a strict salt restriction? Okay, so that's almost 2/3 majority. Okay. And coming to the second part, what are the common foods which have where salt intake is there, but the patients don't realize it?
Actually, there are many hidden food which have a high salt content, which patient may be taking, and he may not remember it. And like bakery products, packed foods, and sausages, pickles, and this noodles. These are all many foods and seafoods and packaged meats, and these have quite a high salt content. So these has to be avoided.
So even butter for that matter. So I think that's something which is so commonly used. Effervescent tablets are the other thing which they have a high sodium content. ENO, which many of our patients very commonly have for acidity and all. So that also has a high sodium content.
Yeah, so we evaluated this patient further. The 2D echo was normal. Salt restricted diet was confirmed. The blood pressure was around 86/52 on subsequent evaluation. Beta blockers had been stopped by then. There was slight postural drop in the blood pressure noted. And the ascitic fluid evaluation showed a low protein high sec ascites without any SBP or without any overt other infection.
So, Amritanshu, so we'll come to you. So, when you are changing the dose of diuretics, how important is the blood pressure, and what is your starting and stopping rules for the same?
Sir, systolic BP beyond 90, at least minimum 90 is acceptable to me, or MAP is at least 55 to 60 is acceptable in case of refractory ascites, because they will have a lower MAP in general.
Below 90 you will stop?
Below 90, yes.
Above 90 you will continue. BP. So if you have the first time patient coming like this with a blood pressure of 92, would you start the diuretics, or you are hesitant to start diuretics?
Yeah, we can start diuretics. Majority of us advanced cirrhosis will have lower mean arterial pressure and systolic BP.
Again, I would want the experts to come in here. So what is your threshold for the blood pressure?
Yeah, MAP is very, very low actually. See, the issue is, if you give me 2 minutes to what I think is that first of all,
experts will get more time.
Oh, thank you so much. So, refractory ascites, as per definition, refractory word was used by authors who could not mobilize ascites. The pathophysiology is MAP is coming down. BP has become 90 by 45, MAP is around 45, 55, 60. MAP is 60. With MAP of 60, he will have a very high renal artery resistive index. So what it means is that blood is not reaching the kidneys. That is very, very important. Beta blockers, ACE or whatever drugs may make it worsen. If you want a good filter or a good urine output, you require adequate blood to reach the kidneys. Diuretics act in the tubules. If the diuretics won't reach kidney, how will they act? Then we go on increasing the dose of diuretics, knowing that blood flow to the kidneys are poor, and we will hike up the diuretics without assuring that adequate supply of diuretics is made to the kidney. To make that, we have to increase the MAP, decrease the RARI, improve the renal blood flow. A beautiful study was first published in 1985 by Perigines. That time we didn't have Mirodrin or terlipressin in most of the countries. He said that MAP of more than 82 with large ascites, refractory ascites, better survival than MAP of less than 82. Multiple future studies have done that. It started in 1985. MAP, urine sodium, very, very important prognostic markers than many other conditions mentioned here. Okay. So the goal should be to increase the MAP, get the renal blood flow. Until we have good renal blood flow, albumin will not combine with furosemide and furosemide will not act. Furosemide is more than 95% albumin bound. You require fresh albumin to bind with furosemide excreted in OATP, one receptor of proximal convoluted tubule to act in the tubules. There is no point increasing the dose of diuretic reaching 160 milligram and 400 milligram without the drugs reaching the tubules and acting.
Yeah, thank you, Gaurav. So to simplify things, the first step for diuresis is filtration in the glomerulus. Only if the filtration happens and sufficient volume of fluid reaches the tubules, the diuretics can act and throw it out. If you are not having filtration, there is no point in giving diuretics. So unless you have sufficient perfusion pressure, unless sufficient filtration is happening, the diuretics are not going to work. So that is why you require a good mean arterial pressure.
Can I make a comment?
Yes, sir, please.
See, even if the MAP is low, we will have to give diuretics. We cannot avoid that. Only thing is that we'll have to find out what is the reason of this low MAP. And majority time, this is the SBP. And you do a diagnostic tab, there will be SBP.
Yes.
If the SBP is not there, probably there is something wrong. This patient is not going to improve. And then you see, maybe sometimes we may have to do a repeat tap. Maybe after 2 days you repeat the tap if the patient is not improving. The MAP is low, we have to look for the infection. But we cannot avoid the diuretics. Without diuretics, this patient will not improve. The only thing is that which diuretic. See, the aldactone has to be given. See, it is not that a patient comes with the
Yes, sir, we'll be
low
coming
BP.
to that, sir.
We will not give the diuretics and the ascites will be controlled. It will not be controlled.
So absolutely right. So that is why you have to build up the blood pressure and give diuretics. So, but the blood pressure has to be built up. So without that, not much can be achieved. And that is where the role of vasoconstrictors comes into being. We have already discussed the checklist in these patients, and Amit has already mentioned that we'll be ruling out infections in these patients before we do anything. So that was the first point that we've already covered. So coming to Ramit, so when you use midodrine, which is the most commonly used drug for this setting, what are the concerns that you have? And how do you titrate the dose? What is your starting dose and how do you titrate it?
So mitodrine is a drug which acts very fast but has a very short half-life. So we would have to give it in the daytime, one, because it can cause supine hypertension. So it has to be given, say, in the morning at 7 o'clock, then every 4 hours, and then the last dose should be around 6 p.m. Second thing is that it can also cause urinary retention. So that is why it should be used with caution in patients who have prostate issues. Third, it can cause bradycardia in very high doses because it can stimulate the vagal system. So that is one thing where beta blockers are there, so we have to be extra cautious. And it can also cause some minor side effects like pruritus and scalp irritation, which goes away in a month or so. ICU setting, the dose we start with is 5 milligrams 3 times a day, and then we monitor the patient's MAP. And accordingly, every 2 to 3 days, we increase the dose by 2.5 milligram per dose. That is 7.5, then 10 TDS. ICU setting, mitodrine can be...
Yeah, so that is the second question which I have for you. And that is, in ICU, very often what we have seen is the intensive, especially when their patient has come initially in a sick state because of an infection, he is septic, and he is requiring inotropes, he is on noradrenaline. And then when they are trying to taper the NORAD, they come to a particular level and then there is a plateau. And that is when they usually introduce midodrine so that they can taper off the noradrenaline. So this is a very common ICU practice. So do you agree with this practice? Is there a rationale behind it? Or do you think that the noradrenaline should be stopped only when the patient is really out of the acute illness completely?
So the purpose is to maintain the MAP. So either vasopressor can do, and if we can shift out the patient early from the ICU by reducing from an IV to an oral drug, possibly that can be an okay thing. And I suppose it may be a good drug to de-escalate from an IV inotrope to a drug which can maintain blood pressure in a ward.
Okay, so let's have a vote of hands again because there is just no data on this. So everybody will have personal views. So how many of you are comfortable with use of midodrine so that noradrenaline can be tapered off? So almost half. So the other half is not.
I think can I make a comment?
Okay.
See, we are going the other way. See, the patient has come with the hypotension. Rather than trying to find out the cause of hypotension, we are giving midodrine, especially when the patient is admitted in ICU.
Sir, that has already been done. The first checklist is there where we have excluded all the causes like infections and pneumonia. Everything has already been excluded, cardiac illnesses.
That's fine.
Yeah.
But if the patient is in ICU, you are giving the NORAD, or you can take help of
we are
talipressine.
assuming that the etiology is being treated. So like the patient has come with, let's say, a pneumonia, and was in hypotension. Now you have treated the pneumonia, the noradrenaline is nicely coming down, and then you get stagnant at 2 mils per hour. It's not an uncommon situation. You're not able to taper off below 2. The patient is fine, the counts have come down, there is improvement in the pneumonia, but the noradrenaline is not coming down because the moment they come below a particular level 3, let's say 0.1 mics or 0.2 mics, the BP drops to 80 systolic.
This,
so in such situations,
this patient is still sick.
Yeah.
This patient requires still the maintenance in ICU. And rather than, you can take help of terlipressin in such patients. Okay. If you give terlipressin, these patients may improve. And then when you are discharging these patients, you can take help of midodrine.
So absolutely. So terlipressin or vasopressin is also
Akash,
these
just
options.
coming back to the scenario that you are addressing, which is that a person is on NORAD being tapered and then plateaus and you now need an inotrope. I think that there is a role for midodrine in this situation, but one should also rule out other possible causes of why he is being NORAD refractory, you can't step down. Another fresh infection somewhere, or volume depletion. The POCUS shows you an IVC of 15, 14, the person is volume depleted. That may be a reason. Or rarely you might find adrenal problems. There's adrenal insufficiency and you have to check the steroid levels, and a brief small corticosteroid dose might make him weaned off. Once you've ruled all these out and still not happening, then you might take the help of
I completely agree with you. And in fact, this is a daily debate in our ICU rounds also, where me and Amit are on the side of continuing noradrenaline and finding the cause, and Mrudul and Mihir are on the side of using midodrine. That's why I brought this question up specifically for this purpose.
They give the wrong impression, and all the audience, especially the junior ones, they will start giving them the midodrine in all patients with the hypotension, which is wrong.
I think, Akash, I would agree that the message which is getting across is that use midodrine in case you are not able to taper off NORAD.
No, that's not the message. That is exactly what that is something which should not be done. But where you have the patient was, there are some patients who have a baseline blood pressure of 80-85 systolic. In those patients, you will have to, because you cannot eternally continue noradrenaline. So it also depends on what the baseline blood pressure was when he was coming in your OPD for the last 3 months, because you have a record for these patients.
Terlipressin should be a better choice. Terlipressin should be a better choice.
But try to find out what is the reason of this. Many of these patients are receiving beta blockers. See, this is a major problem.
So that we have already ruled out, because that was the first step.
Ruled out, and see the infection which has not been treated.
Yes, so all these are valid points, and that is where we started, sir. The first slide and the first question was on this checklist. Yeah.
So you started on midodrine, 5 milligram 3 times a day, and titrated to target a MAP of 82. We were able to use a higher diuretic dose, 30 milligram of torsemide and 150 mg of spironolactone. Now he had a better ascites control. On subsequent routine investigations weekly, 6 weeks later, he was found to have a serum sodium of 121. He still had anasarca, and volume status was overfilled. Salt compliance was confirmed, and he was taking around 1.5 liters fluid every day.
So Naveen, would you discontinue diuretics in this patient now?
Yes, sir. At this sodium level, I will discontinue diuretics.
Okay. And how much fluid restriction do you advise in presence of hyponatremia?
What is the urine output of the patient and the insensible loss, and to make a deficit, I will minus 500 ml from that volume.
So let's say this is on diuretics or off diuretics?
In this case, the diuretics will be already.
So let's say you have stopped the diuretics today. What is your advice for today?
Definitely, the patient was taking 1.5 liters per day. I will make it less than 1000 ml.
So 1000 ml roughly. So most of us would usually give an arbitrary figure to start off, and then as per the urine output, as you very rightly said. When do you use tolvaptan or any of the veptans?
Because the role of veptans is coming in refractory ascites, and it is initially was used for the cardiac failure patients only, and it is indicated for euvolemic or hypervolemic hyponatremia and in refractory ascites. And if the patient is not responding to diuretics, is diuretic intolerant, or if we need to increase the we are not able to increase the dose of diuretics, and then we can start.
So when you think that the patient is hypervolumic hyponatremia, so that is where you would add a tolvaptan. So what dose do you usually use tolvaptan?
The starting dose is 3.75 milligram.
Yeah, so that is based on the Japanese study. At 3.75 milligram also sort of helps, but you can go up to what is the maximum dose that you have used? Because there are people who start off with 15 milligrams also. There are 15 milligrams twice a day also. There are people who are using. So
I have not gone above 15 milligram.
okay.
Can I make a comment?
Yeah.
See, in this patient who has developed a hyponatremia, and this is probably because the diuretics, and we should also be careful regarding the renal function in this. What is the creatinine? Because if we add the tolvaptan in such a patient, the creatinine is going to worsen and the ascites will not settle down. And the tolvaptan should be given only and only when the MAP is good. If the MAP is not good, if the MAP is 70 or maybe less than that, there is no point in giving the tolvaptan. And when you are giving tolvaptan, you have to be very, very careful. Otherwise, this patient will land up in trouble.
Yes.
The careful points are that...
So as you can see, sir, the map here is 82. It's already been shown.
Yeah. So after stopping the diuretics, see, because the major component which is causing the hyponatremia is the loop diuretic. The furosemide is causing the hyponatremia. What you can do, you can take help of the spironolactone only and then remove the furosemide. And after that, do the other measures, that is the restriction of the fluid. And then you can see if the patient is not improving, the MAP is good, and patient is admitted, no encephalopathy, nothing. In that case, you can take help of the tolvaptan. But if you are giving 3.75 mg of the tolvaptan, that is a very low dose, although the Japanese have shown. But to start with, you can use a higher dose, maybe 7.5 or 15 mg. But you have to be careful regarding the sodium increase. If you don't do it 12 or 24 hourly, you may land up in the demyelination. So, and especially when these patients are having malnutrition, the demyelination is much more commoner in those who are having demyelination. So you have to be very careful.
Yeah, so very important that tolvaptans are not used casually. You have to be careful about using them. Not only that, some patients will have massive diuresis if you use higher dosages. So if you use 15 milligrams and all, there are certain patients who are very sensitive, especially if they have a good MAP. You can get 4-5 liters of urine within 12 hours. And therefore, you can actually cause severe intravascular volume depletion in these patients. So be very careful about using tolvaptan. It should be, if you look at the guidelines, when given, should be given only in indoor setting, and it should be with very close monitoring. But of course, people have now stretched, and there are data that you can be used in outpatient setting also, but again with extreme care, and once you've already titrated the dose and adjusted the dose. So, Amritanshu, so how will your treatment differ in a patient who has got refractory ascites with edema feet versus refractory ascites without edema feet in terms of diuretics? And then I'll comment on the choice of diuretics because Dr. Viren Singh raised the point of use of spironolactone in hyponatremia. So we'll discuss that. So,
yeah. Just the amount of weight loss we are expecting, 0.5 kg per day or 1 kg per day. Other than that, the diuretics will be same because we are not targeting the edema, we are targeting the ascites.
Okay, so but usually when we are talking of patients who already have refractory ascites and they don't have much of edema feet, what is it that you usually think and target?
Okay. So basically the volume status we want to know.
Yeah, so usually they would have intravascular volume depletion, and therefore you have to be much more careful about the use of diuretics in these patients as compared to the other patients. Okay.
So the further management, the serum osmolality in this patient was 274, started on tolvaptan half tablet once a day, that is 7.5 milligram. We were monitoring the electrolytes daily. Urine output had increased to 3 liters in 24 hours and there was slight drop in the BP. Sodium increased to 128 by day 1 We reduced the tablet to further half tablet on alternate day, and then the urinary output stabilized around 2 liters. The sodium increased to 135 in the 4 days. This was the black box warning. He was managed on low dose of torsemide, spironolactone, and twice weekly tolvaptan. Midodrine we continued. Again started needing monthly large volume paracentesis few months later. Had couple of episodes of hyponatremia and an episode of creatinine going up. So now this time, after having all sorts of medical management, was still getting refractory ascites. So this was the time that we advised TIPS, and a CT scan triphasic was done to rule out any other cause. So this was the CT, no overt HCC, a large caudate lobe, hepatic veins were patent.
So I differ with Mridul again here. The Brahmastra here is actually not TIPS. The Brahmastra is liver transplant. And we should be doing transplant for this patient. We should have done it a long time ago. But that was not the mandate. So while we are discussing all this, once you have refractory ascites, the only definitive therapy is liver transplant. And that should be very, very clear, and we should not mince words in that. So Amit, coming back to you. So what is your checklist before doing TIPS? And which patients are you concerned and where you will not do TIPS?
Yeah, so it is important to ensure that the TIPS, whatever we do, it is safe and it improves the patient outcomes. So we need to see the clinical parameters, age, history of encephalopathy, sarcopenia. So numerous studies have shown age more than 65 to 70 sarcopenic patients don't do well after TIPS. MELD score more than 18 don't do well after TIPS, although there is no specific cutoff where you should not do TIPS for refractory ascites. And apart from encephalopathy, what is also important is to consider and prognosticate whether this patient may develop post-TIPS heart failure. So patients may not have overt structural heart disease but cirrhotic cardiomyopathies, and there are various ECG 2D echo parameters which can predict this. So diastolic dysfunction and pulmonary hypertension are main two features that that will predict development of heart failure. There are various indices and algorithms, but there is no specific cutoff. So I would say that if patient is having moderate or severe pulmonary hypertension and right ventricular systolic dysfunction, then I would not do a TIPS. And patients with grade 3 diastolic dysfunction, I would not do a TIPS. Grade 2, I would be concerned in offering TIPS to them.
Akash, can we just hurry up the case, please?
Yeah, sure. So anyway, this is the last question. How to manage post-TIPS encephalopathy and post-TIPS liver decompensation?
So, to prevent first thing is to prevent a post-TIPS encephalopathy, we should be using a smaller size stent. So we can use an 8 millimeter stent over a 10 millimeter. But if the patient has undergone a TIPS, then he should be on anti-coma measures like lactulose, rifaximin, and we should also take care of the sarcopenia, giving a good high protein diet, branch chain amino acid based diet.
So this is quite interesting. So do you really give a high protein diet immediately after doing TIPS?
So
because that's sort of
restricting protein
or a standard 1 to 1.2 gram protein per kg.
1 to 1.2 gram branch chain amino acid based, so that the patient doesn't go into encephalopathy because of a complex animal based protein, plant based protein.
So immediately after TIPS is not the right time to actually give a high protein diet. Let this thing adjust. So, but yeah, so 1.2 gram per kg is good enough for this setting. So I think that was the case about, and so I'll ask Mridul if you can summarize, and then we can have the opinion of experts.
Yeah, so this is the various therapeutic targets in the cirrhosis which cause the ascites, and where each individual the medical management would work. So where the TIPS would work, where the vasoconstrictors would work, where the TAPS Veptans would work. So this is my summary slide. Salt compliance needs to be thoroughly ensured in refractory ascites. Beta blockers should be used with caution, especially because we need to maintain a certain target MAP of around 82 for the diuretics to work. TIPS should be used as a bridge to transplant if there is no contraindication. Diuretics need to be used carefully with renal monitoring, especially creatinine and electrolytes. Midodrine, we have already discussed, should be used when patients with low MAP. Tolvaptan again should not be used casually, and frequent monitoring of electrolytes need to be undertaken. And liver transplant is the only definitive therapy, unfortunately not available for most of the patients. Thank you.
This is we should be very careful that liver transplant is the ultimate in these patients, but the most common procedure is the large volume paracentesis. And that is also fought with so many complications. So we should be careful in doing the LBP in these patients.
Akash, can you join there on the stage? So we can have some questions for Akash also.
Yes.
And any comments from the senior experts?
Akash, if I got it correct, you used midodrine to increase the MAP. Along with that, you used 30 milligrams of torsemide and aldactone, and then you added tolvaptan in the same patient at the same time.
No, sequentially.
So sequential was first increase the
You have
MAP.
to increase the MAP, then add
continue
diuretics.
midodrine,
Yes.
add diuretic along with that.
Yes.
And then add tolvaptan.
Yes.
I don't think so. We usually do it this in clinical practice. So the MAP is already increased. Then you will wait for some time for if you want to add diuretics. You try to taper off the midodrine also. Not that you add everything together.
We would usually continue. If you taper off, if you reduce the dose of midodrine, the blood pressure will fall. You will not be able to use diuretics. So it has to be continued. That's the paper which Dr. Viren Singh had shown in 2008, his paper in gastroenterology.
See, I also agree with Dr. Akash. I fully agree with Dr. Sunil that we are pushing too much. This horse is already tired up. So if you try to put the midodrine and then the diuretics, and then the tolvaptan, I think it is too much. We'll have to be very slow in increasing one after the other.
Akash, if we go back to the CT scan you showed, CT scan picture, we see that liver volume is really shrunken and caudate lobe is enlarged. So can caudate lobe compressing or IVC be a factor here in refractoriness? Number one. Number two, is liver volume a consideration while choosing for tips?
So the first question is easy to answer. So in this patient, there was no gradient. What we usually look for is the gradient across the caudate lobe compression. If it is more than 20, that is when it is significant. This patient actually did not have much edema feet either. So obviously it was not a clinically significant thing. Liver volume, although it is not mentioned as one of the considerations, we would always look at the liver volume when we actually take a decision in patients. So somebody like this patient, I would not do a TIPS because the liver volume is really small. Even while doing a transjugular liver biopsy in such patients, I'm extremely worried because the throw of the needle can actually puncture the capsule and go out, and you can get a hemorrhage. So it's extremely important that you do your cross-section imaging for such patients. And like I said, this patient should have been transplanted much earlier. But if transplant is not an option, then you have to be aggressive. And for controlling ascites, you have to use all the tools which are there, which includes use of midodrine and diuretics and tolvaptan as and when required.
Sherry Milan, thank you very much. As a hepatologist of a surgical center, I've always got major problems in management of ascites after surgery in a small foci syndrome which doesn't recuperate. Would you have some suggestions as experts on what to do? What is the timing to consider TIPS? And would you manage ascites after surgery in the same way?
So the question is after hepatectomy or after a transplant when you get a small foci syndrome? Okay. So after hepatectomy, if it's a non-cirrhotic liver, usually you have to just buy time and the liver will grow back. If it is a cirrhotic liver, then we are in trouble because then it is what you need to really do is reduce the portal pressure and reduce the portal flow. And for that, you have to be very aggressive. Usually, we would put these patients on octreotide and beta blockers and diuretics to start off and ensure that there is no infection which is lingering and good nutrition. I think those are the things which will work for these patients. At times, we have also used noradrenaline for these patients, which helps mobilizing ascites for patients with post-hepatectomy ascites. Yeah, Dr. Dharmesh.
So just to add to what you said, so you could divide them into two, with cholestasis, without cholestasis. So essentially without cholestasis, whatever Akash said, and if it is with cholestasis, then you are in deep trouble. So coming to your second last slide, I completely agree with what Dr. Saraswat said. So you started off by saying suspected PSVD. And if you go down the left path of your algorithm, there is no sign of portal hypertension. You've mentioned some host of other conditions. So if someone has got altered liver tests, how did we suspect PSVD?
Very true. First of all, so this is not my algorithm.
Whosoever, because I think Sir has said,
Second.
so I agree with your last slide, which you mentioned about what Dr. Sareem said in one of the talks. My bad luck, I didn't hear that talk, because over generations we have also been taught that there is an entity which I don't think exists. So I hope the next generation realizes that.
Yes. So
and this PSVD thing, no portal hypertension and abnormal liver test.
I completely agree. That's what I was trying to point out, that segment which you're pointing out, you have to start from, it's not like you see the biopsy, then you go and make the diagnosis of PSVD. It starts with the patient. How will the patient come? The patient has no portal hypertension. Maybe he has some associations where you might have a suspicion that as an association is having abnormal liver function test. You have ruled out all other causes. That's what I believe what the hypothesis is. You've ruled out everything. You're seeing that your liver function tests are not normalizing. Then you do a biopsy and then you establish the diagnosis. But that would be a very small group. And there are majority groups where you will not have, we might end up with doing unnecessary biopsies in such cases.
So how did they diagnose portal hypertension or lack thereof in this condition? Is there a sinusoidal hypertension? Because you are taking away the portal word from it. Actually, portal hypertension is essentially sinusoidal portal hypertension.
Yes.
So is there a sinusoidal hypertension in this group of patients?
Sir, portal hypertension is not a feature. The term they want to use is portosinusoidal vascular disease, not portosinusoidal portal hypertension.
No, so I'll answer, because why the word portal and sinusoidal both are there. These are based on two studies. One is by the Yonel Trebicka study published in 2014, where he demonstrated in the animal models that the changes of fibrosis not only take place in the portal areas, but also in the sinusoids. And if you go back and look at Professor Sama's paper in 1972, in fact, he has also described exactly the same. So it was 50 years apart, two papers which have shown exactly the same pathological changes. That is why they proposed to include both portosinusoidal vascular disease and not just portal disease. So that is the basis. But I completely disagree. So that's anyway. So that's.
I'm surprised by your answer, Akash, to say the least. How does portal hypertension occur? The first stage is the stage of colonization of space of Dicey, which is essentially collagen being laid down in the sinusoids. So portal tract changes occur much later. And just for this audience, and this is going off the track, all of us, because this is a meeting held by Medanta, liver transplant is also a very common cause of PSVD. Just go back to the biopsies and see, and you will get the
20% in fact. That's a paper published.
Akash, Roy, very interesting talk. So I am worried about this biopsy part here. Now, you have deranged LFTs because of various reasons. If you have portal hypertension, obviously the indication is very clear. MASLD is so common, so a lot of patients will have some transaminases. If this indication is included for biopsy, that means a lot of patients would require biopsy.
Exactly.
So that becomes a difficult situation for a country like India. That means you will be ending up doing biopsies for too many patients.
Very true. And there needs to be clarity on this. There needs to be more clarity on what.
Dr. Akash Roy, I think another point that I'd like to make it, for the practicing clinician, what is the message? When there is portal hypertension, you have NCPF, treat it like NCPF. We know what NCPF is. We have known it for 60 years. When there is no portal hypertension, there is some deranged LFT, then unless there is light at the end of the tunnel, you have a treatment to offer. You have come up with a novel thing that will cure PSVD without portal hypertension, great, do biopsies. But otherwise, just to do biopsies, to give a label which you're not going to do much about, I don't think is really something that one could recommend from this platform and say that all those patients then just try to figure out PSVD without portal hypertension. What the natural history of this entity is also is unclear. 10 years later, how are they going to behave? We look at it. You're looking at it backwards. A subset of patients who've undergone liver transplant, you're saying liver transplantation was for PSVD, and the diagnosis is retrospective. So I don't really think we have enough data to go away from our current practice and recommend the use of biopsies in people with just deranged LFTs in the hope of finding PSVD without portal hypertension, particularly when you have nothing to offer. So I think I would probably refrain from that.
I agree on that again, sir.
Can I make a comment? Dr. Akash, see, especially what is deranged liver function? Raised bilirubin at what level? Raised OT, what level? Raised PT, what level? Raised alphos, what level? So this is again, it will put so many patients for the liver biopsy.
So, sir, again,
Anand,
agreeing.
Anand,
Can we have just last question by Dr.
I
Anand?
don't have a question.
Comment.
In fact, due to aggressive questioning of Akash, I stood up to defend him. I think he has answered all your questions in his last slide. He said that when you all old people who are familiar with NCPS will die, we'll convince ourselves that it is PSVD.
Dr. Thompson, I'll just summarize it. I agree with all the viewpoints, and again, to put forward to the matter, I do not endorse this definition of PSVD. Yes, you can pragmatically view it as a purist versus a pragmaticist. As a purist, you will say why that patient has a persistent abnormal liver function. Let me search, let me search, let me search. Let me have a biopsy. Maybe with collection of data 20 years down the line, I might find something which would change science. As a practicalist, when today I do not have anything to offer, I would say, why to do it if nothing's going to change my practice?
Yeah, so in insider information, the reason for changing to PSVD was because when you wrote grants with the disease name idiopathic non-cirrhotic portal hypertension, you never got the grants. But if you give it a positive and a novel entity and call it portosinusoidal vascular disease, you will get grants. So that is the real reason why this name is changed.
Great.
Can we end the session now? Please.
I request all the doctors involved in the session to kindly come for the photograph. So let's proceed to our next session. Our moderators for the session are Dr. Anup Saraya and Dr. Deepak Agrawal. Now let's invite the chairperson, Dr. Neeraj Joshi, Dr. Rohit Gupta, Dr. Dinesh Balakrishnan, Dr. Devesh Yadav, and Dr. Kamal Yadav. Our first speaker for this session is Dr. Sherry Bhuri, who will talk on redefining HCC screening.
Good morning, everybody. Okay, so first of all, I would like to thank the organizers for this invitation. My affiliation is from Italy, but probably you won't know that I'm of Indian origin, so I'm very proud to be here, and I made my family proud to be here, so thank you very much. Anyway, this is the title I was given, Redefining HCC Screening. Actually, I would like to anticipate the last slide. I will not give you any answers whatsoever. I'll just tell you what's happening in Europe to try to overcome the major problem of HCC screening today. Unfortunately, I'll have to start with some epidemiological slides. This is just to show you the WHO estimates of 2019 and to show you that in most parts of the world, tumor is the major cause of death in patients less than 70 years old. And this is due mainly to, of course, aging, growth of the population, and all the changes in the risk factors, which are mainly correlated to socioeconomic development. Let's see what happens with HCC. As we stand today, HCC is the fourth cause of cancer-related death. And even here, the estimates are that it will grow in the next years. But what is even worse, and you find it in the right part of the slide, is that incidence overlaps and mirrors mortality. This means that the diagnosis is done when it's just too late. In order to overcome this, medical societies, as you all know, recommend biannual screening with US and AFP. This has been proven to early detect HCCs, to increase curative treatment receipt, and to prolong survival, even though, as you all know, there are some statistical doubts with lead time bias and length time bias, but anyway, overall, it seems to increase survival. Now, having said what I said, and keeping in mind that the survival rate of HCC at 5 years is of 20%, we surely should know and notice that there are some limitations of the surveillance of HCC. Now, these are the main challenges. As you all know, sensitivity and specificity are quite low in early detecting HCC, approximately 40 to 50%. The performance of both the provider and the patient can, of course, limit the procedure, for example, obesity or low expertise. And of course, in major parts of the world, mainly in socioeconomical problems, we do not have a very clear-cut adherence to screening protocols. This is Amit Singhal in the white paper, which was published by ILCA a couple of years ago, showing the cascade of the vulnerable points that limit HCC screening and define an HCC screening misuse or underuse. And I think that the major point of our attention is that we still don't know now who to screen. Screening is cost-effective when the incidence rate of HCC, the annual incidence rate, is at least 1.5%. This was the assumption when the major cause of HCC was HCV cirrhosis. Now, as you all know, the epidemiology of HCC has completely changed during the last 10 years. And now the incidence rate is barely of 1.1% or 1.5%. That means that the number needed to screen in order to detect an early HCC is extremely high. And these numbers are due to increase significantly if we do include the NAFLD population. This is the study that analyzes a big amount of papers. This is a meta-analysis showing that actually NAFLD is one of the major causes of HCC. And this number, the NNS, number needed to screen, will increase even more in an unrealistic way if we do consider the MAS-LD definition. So the first point is whether we are able to accept this burden of screening patients. This is why in Europe, and of course in all over the world, we are trying to redefine screening procedures. And I'll show you what's going on. Actually, we don't have any answers yet, and we have to do with what we've got. That means with the biannual US and AFP, but just to show you how we are moving on. As you all know, we've got several HCC scores, but the most important limitation is that all these are limited to particular populations. You all know that, for example, in the HBV population, we have the page B score, but again limited to HBV, the reveal HCV, limited to HCV patients, and we have also scores which are mainly focused on multi-etiologies. The bottom line is that no HCC risk score has been proven to be superior to others. And the most important factor is that we need to define that all these scores need an extreme validation cohort, which we do not have in all these papers. Probably in the HBV risk scores, we have validation populations, but we don't have in all scores. So we've tried to adopt multimodal information in order to define HCC risk scores. We are relying on radiomics. This is a nomogram which was created with radiomics and clinical features. As you can see here, we actually tried to develop it on MRI. On the left side of the screen, you find the liver segmentation. They define particular features of MRI that could create what was called a RAD score. And in the, I don't know if you can see it, yes, here, in the nomogram, we have actually the RAD score, and we had clinical features like sex and Child-Pugh B. Just trace the line from whatever kind of feature to the points. You add up to the total points, and you define what is the 3 and 5 year non-HCC specific survival. So we are trying to pull in all the data we can, but again, let me remind you that this kind of nomogram was created on HBV populations, so very limited to a particular kind of population. We've tried to do the same effort with strong polygenic risk scores. This paper comes from Milan, from Luca Valenti. again concentrated on NAFLD patients. You all know that these metabolic patients have a very strong genetic predisposition. So they took all the polygenic scores and they evaluated the association of these scores with different grades of liver decompensation, from fatty liver disease to HCC, and they tried to correlate risk scores for specific NAFLD populations. A good effort, but again, not clinical adopted, not on the bedside, and again concentrated on NAFLD patients. Let's go on. Let's increase the level of complexity. This paper comes from Dallas. It tries to concentrate mainly blood features and tissue features with hepatic transcriptome and serum secretome signatures. But again, even in this case, this particular screening was dedicated to patients with HBV and patients with NAFLD. So again, a very precise way of defining risk scores for HCC, but not practical at all. We are including AI in whatever we are doing. This is another very interesting paper showing that AI, and mainly deep learning, is very effective in trying to analyze what the risk score for HCC is, and it is much better than logistic regression models we have adopted till now. This is a paper that tries to analyze what is the worth of logistic regression models and deep learning models, and it tells us that, quite obvious, that deep learning models outperform logistic regression models. So actually the future is dedicated to this. Considering all the limitations of US and FP, we are trying to define emerging surveillance strategies. We have several biomarkers, like for example, the Gallet score. The Gallet score is now in a phase 3 study trying to define its utility in clinical practice. But as you all know, when we're talking about biomarkers, we need phase 4 and phase 5 trials to define the exact role and the exact worth of these biomarkers. That means stage migration, curative treatment, HCC mortality, and we need stronger studies in order to define the worth of this. We also have last line methylation signatures, that is mainly liquid biopsy. We have 2 FDA kits which have been recently approved, but I think one is called OncoGuard and the other one is called LAM. But these are mainly industry sponsored, so we really need to have a point of communication between industry and academia in order to better the performance of these tools. You all know about abbreviated MRI. Now, this is a big limitation because MRI is very poorly available in most countries, but it's a very useful tool in order to overcome all the limitation of contrast media for CT scan, renal insufficiency. It is a very short procedure, but again, the limitation is due to the availability of the MRI. Now, the major point is to try and go from a one-fits-all screening to a very personalized surveillance strategy, and this is called precision strategy screening. Now, precision strategy screening, and this is what we are aiming at, is very useful because it first of all tries to define what is the pre-probability of having an HCC in our population. Now, precision surveillance screening means that within this population, which has a cirrhotic liver disease and should undergo surveillance, we should define which are the normal patients who deserve a biannual screening and which are the patients at a very high risk, which deserve a completely different screening. And precision medicine means that in these patients without cirrhosis, for whom actually screening strategies are futile, try to identify which are the patients, and I think this is the major problem, which patients deserve a screening, because even though without cirrhosis, this patient is at risk of HCC, and this green sorry, I can't show you, the green chart here in the slide. Anyway, this is the main issue. Precision medicine, from one fits all to a personalized evaluation of the risk score of developing HCC. Once upon a time, it was very easy. Cirrhotic patients had a risk of HCC and non-cirrhotic patients didn't have risk. Now the epidemiology is completely changing and we have non-cirrhotic patients with a high risk of hepatocellular carcinoma, which do deserve to get into a screening program. The industry has moved very fast. We have now these panels that provide a screening test for multiple cancers. Patients love these kind of screening panels because they're very easy to perform. The industry likes these kind of panels because, I mean, we all know the economical downstream effect of these panels, but for us clinicians, this can be a problem, especially in patients with a low risk of developing tumor, because they can create false positive, and this can be a problem for, of course, all the downstream effects of this condition. So these are my conclusions. Abdominal ultrasound with AFP remains the current gold standard, even though with several limitations. And the several limitations now are not just sensitivity and sensibility of the procedures and cost of the procedures, but mainly the limitation comes from us providers because we still don't know who actually needs to be screened for HCC. We have several novel imaging and blood biomarkers that show promise, but they need further evaluation in phase 4 and 5 studies. And as I said before, as industry is moving faster than academia, we should meet halfway in order to define which are the populations that deserve this kind of evaluation. So if we were together in a lift, I would say a couple of concepts. First, sustaining adequate adherence rate. Make the most of what we have. We have now a biannual screening, but we should increase the knowledge, especially in the providers. We should stratify the risk of HCC for our patients. We should evaluate the potential expansion of patients with steatotic liver disease. And we should consider all the limitations of our populations, for example, obesity, and we should change the kind of surveillance test on the basis of our patient population. And above all, we should deliver a personalized surveillance approach on the basis of my personal own risk of HCC. So I would like you to go out the lift with 2 important messages. First, tailor HCC screening. We are quite far from this, unfortunately, and prevent liver disease above all. Thank you for your attention.
Thank you so much, ma'am. Next, I request you to kindly take your seat on the dais. Our next speaker is Dr. Dieter Broering, who will talk on robotic surgery in living donor and liver transplantation. Due to logistic reasons, we would like to play pre-recorded lecture.
Dr. Dieter is live here.
Good afternoon, everybody. You hear me?
Yes, we can hear you.
Very good. So, good afternoon, and thanks for being with you. Thanks for the invitation, and hello to all my friends from Medanta. It's a great pleasure and honor for me to present you our actual status of robotic living donor liver transplantation. Where are we now in Riyadh? And we are, as you know, here in Riyadh, running a high-activity organ transplant center with more than 800 solid organ transplants per year. And since years now, we are investing in robotic transplant surgery and minimally invasive transplant surgery. As you can see here, last year we did more than 50% of all our transplant procedures, donors and recipients, minimal invasive, and the green part, the robotic group, is really growing. And this goes along with the overall evolution of robotic surgery and transplantation. So it's, I think, now fully established in a lot of countries the robotic donor nephrectomy and also the kidney implantation. One part of the robotic or minimal invasive transplant surgery is going also robotic, the kidney implant. Then also the pancreas is a perfect indication to do it robotically, as well as the donor hepatectomy, which is really changing the whole phase of living donation, and I will show more in detail later. Then now recently the robotic implant makes faster progress than we expected. It's due and always due to the superb visualization, the precision of the instruments, and everything you can just do more precise. Therefore, this is the future. And robotic lung transplant and uterus transplant has been done, and recently even a robotic heart transplant has been done successfully in our institution. We are in the same situation like India, so 80% from all our transplants in liver and kidney are deriving from living donors. And therefore, we invested much to push minimizing the risk for the donors. The donor safety is the most important part of the whole procedure. So therefore, we started in 2012 our minimal invasive approach, and now we are proud that the last 3 years, no donor, neither kidney nor liver, had to be done open. So all could be done, like last year, 729 donor surgeries, fully minimal invasive. And this is, of course, a major team approach. This is our center, and the team who's behind this, big numbers, and so a big team. All this development, yeah, it's a combined effort between India, Saudi Arabia, and then Korea. So these are the three, and Taiwan, the main countries who are pushing and pushed for these innovative procedures to minimize the donor risk. Now, laparoscopic versus robotic, I think this discussion should be over, and at least in our center, as you can see here, we went through a laparoscopic phase, which is in blue. We started in 2013, but there is no need to go through laparoscopy to robotics, so I advise that directly you go, if you want to go to minimal invasive, go directly to the robotic procedure. If it's financially affordable, of course, this is always a condition. And so this, you can see the green bars now dominating, and we're pushing totally away the laparoscopic and the open. And this is because of the lower mobility. If you see the CCI over years here, we started in 2011 doing only open, and then the laparoscopy was able to reduce the CCI a little bit. But once we started the robotic procedures, then really the CCI, the comprehensive complication index after donor surgery of the liver, went almost down to minimum 0. So here you see the numbers in details. The overall mobility really went down in this comparative study, robotic, laparoscopic, and open area, with good patient volume and numbers. And only the robotic came up with the lowest number. And in the multivariate analysis, the robotic platform turns to be out the most important prognostic factor for low CCI in the donors. And as well in the recipients. This was surprising for us, that the recipients also benefiting from this perfectly harvested graft. So if you put the robotically harvested graft into an open liver implantation procedure, even the outcome is better for the pediatric recipient, as well also for the adult recipient. Here in the multivariate logistic regression analysis, you see that the fact that the donor surgery was done robotically is benefiting the adult recipient. So this encouraged us to move on. So for us, we are now in a phase that we cannot train any more open donor surgery, which because everything is done minimally invasive robotically, and this is encouraged us now to move to the recipient. And this also, again, a combined effort between India and Saudi Arabia, Korea again, and now also 2 European centers started this. And we were able to do the first fully robotic, everything via funds deal in the donor and in the recipient. So we call it the fully robotic living donor transplant procedure. Then now more than 1 year ago. So, and again, here, just some video sequences of the recipient surgery, fully robotic. This is the patients benefiting from, and the better visualization, the more precision of the instruments. You can enter difficult spaces better, and the abdominal pressure is reducing the blood loss. It's multiple bleedings of collaterals. And it's really, this will be also the future. Yes, it's more expensive, but as we can see soon, will pay off by reduced mobility. So we did now 76 cases, and here in this analysis, we did already more than 50 fully robotic. And we did also left lobes. As you can see here, you can also nicely implant left lobes in the right cavity, right abdominal cavity. But you need logistics. And this is, of course, if you do them one donor, one recipient, parallel, you need a minimum 2 XI systems. You have to have proper access. We are lucky that we have now 4 XI systems in our transplant field. Transplant OR, and I'm happy to present you the first really statistical comparative study between robotic recipient surgery and open recipient surgery. Here, these are 54 fully robotic recipients, so hybrid excluded. This is all everything done via fan steel incision, and here the characteristics of the this recipients in 453 versus 54. And this is the graft recipient rate ratio is a little bit lower because we don't, in the beginning, we didn't want to have this big grafts. And then here the type of graft. So we did now 9 left lobes and 44 were right lobes. We did 1 whole liver, and we had 1 conversion in the robotic group. And that it takes longer, yes, it takes longer operation time, but the blood loss is significant less, the transfusion rate lower, and which due to the pneumoperitoneum. The INR is a little bit higher on day 1 in our robotic group. I'm not clear why, but it can be a combination of the manipulation of the organs with the robotic arms or the intra-abdominal pressure. We think it's more likely the abdominal pressure, but then it's at day 7, it's even then lower. And the bilirubin clearance day 7 is also better, so the bilirubin is lower. AST a little bit higher, which we explain with the, so we'll try now after reperfusion to have a low abdominal pressure, and hopefully this will then also diminish. Most important, the infection rate significantly lower. Otherwise, biliary complication rate, it's almost the same, trend towards lower, but not statistically significant. And so in the overall analysis of the overall morbidity here and the major morbidity, there is a significant reduction of the overall morbidity. In-hospital mortality was also 0 in the robotic group. So CCI is significant lower in the robotic group compared to open recipient, and in the multivariate analysis, so the robotic recipient approach turns to be out also the most important factor for low CCI. We did now recently a systematic review of the world published cases. So it's an individual patient data meta-analysis. We included all the publications available. And here we see that it's now dominating living donor surgery. So 89% of the worldwide published cases are from living donors. The operation time takes longer. The warm ischemic time is a little bit longer. But again, the blood loss overall in this meta-analysis is lower, transfusion rate and infection rate lower, major complication around 20%, no in-hospital mortality so far published. And we have 100% 6 months recipient survival in the published series. So there's always the publication bias, but where are we now in 2025? So we did already retransplants, fully robotic retransplant recently. We can left and right grafts. We did the first pediatric recipients. We did domino whole liver transplants. We already did in situ reduction of the cirrhotic livers, because one of the main challenges is the space. And one solution is what we now did, that we reduce the cirrhotic liver, the size of the cirrhotic liver, to then be able to mobilize the liver properly and facilitate the robotic surgery. You can do a advanced tumor go in the diaphragma. You can also robotically do a diaphragmatic resection. We did disease donors through funnel steel, and we did now Budd-Chiari syndrome, and portal vein thrombectomy is also YADL1. So this is where we are now, and yeah, I would like to encourage everybody to submit their cases in our International Living Donor Liver Transplant Registry, and I would like to thank you again for this fantastic invitation and wish you all the best for your conference. And looking forward to questions if questions are rising up. Thank you so much.
Thank you, sir. Coming on to our third speaker, we would like to call Dr. A.S. Soin, who will speak on robotic liver transplantation. Indian experience.
Don't we want to ask questions to Dieter, or you want to have it later?
Sir, we will be taking questions.
Questions in the end?
Yeah, sir.
Okay. So after that amazing experience of robotic liver transplantation from Dieter, who has... Dieter, are you online? Is he online?
Yes, I hear you, Avi. Thank you. Yes, I hear you.
Hi. Thank you very much for that talk. We'll ask questions later. So after that amazing talk on liver transplantation by the robotic approach and how they are adopting recipients also by the same approach, I'm going to talk about the Indian experience, just to contextualize his talk in India. So at Medanta, we've done about 4,561 transplants. We have done 4,417 living donor liver transplants, and the robotic experience, total hepatectomies that we have done robotically are 407, of which 11 have been major hepatectomies, and 396 robotic donor hepatectomies, of which 388 have been right lobes, 2 left lobes, and 6 left lateral sector. We do about 15 robotic donor hepatectomies every month, 15, 17, something like that. In the last 3 months, 70% of our total donors have been done by the robotic approach. We now do not select our donors. We offer it to everyone that wants it. Unfortunately, there's a small financial constraint. Actually, 100% of the donors want it, but 70% of them are able to have it because it costs 4 lakhs extra. I collated data from the institutes across the country that have done robotic donor surgery. So AIMS, Kochi, Amrita Kochi are leading the pack. They started their program in 2018. They've done 400 plus cases. 90% of their donors are robotic. They've done 1 robotic recipient. Medanta, I already told you, 396, 70% of our donors are robotic. We haven't done any recipients so far. Rela Institute, they started their program in 2020. They've done 380 robotic donors. 2/3 of their donors are done robotically, and they've done 2 total robotic recipient surgeries, but they've done many partial, it seems. And at BLK Max Hospital, they started last year. They've done 89 cases of robotic donor hepatectomy. No recipients. Nobody else has done any recipients. So the only 2 institutes to have done recipients are the Rela Institute and the Amrita Kochi guys. So Artemis has done 8, Fortis Mulund 7, Global Mumbai 12. So that's the overall Indian experience. So you can see that the adoption of robotic donor hepatectomy in India is obviously increasing. And I've not included 2 other institutes here because their numbers are included in our total numbers. That's Medanta, Lucknow, and Reliance Foundation Hospital in Mumbai. We operate in these 2 places, and we've done possibly about 8 in Lucknow and 7 in Mumbai. So that's about 10 hospitals in the country that are doing robotic donor hepatectomies. Thank you very much.
Thank you, Dr. Soin, and we'll ask you to stay there, and we'll have questions at the end. Now, we have a very interesting talk by Dr. Soin. So we've all started, this concept of having tumor boards for HCC. A lot of hospitals are having tumor boards. So this topic is on the next generation tumor board in HCC. That means integrating artificial intelligence. And Dr. Soin tells me that he's going to use an AI platform to do this talk, and this talk was also made by AI, and it is on AI. So let's see what Dr. Soin has to tell us.
So part of that is true. I used a lot of AI to make this talk, but this platform is a regular PowerPoint presentation. I could have done it from a platform called Gamma, but the problem is that the slides that Gamma churned out were not up to the level of this audience. They were pretty basic. So I decided to put all the data into a regular PowerPoint presentation. So I think this is what it's going to look like in the future, with holograms and AI with us, all around us when we sit on tumor boards. Now, what are the challenges and opportunities in multidisciplinary tumor boards for HCC? We all understand that HCC management is a multidisciplinary action and event, and hepatologists, surgeons, oncologists, radiologists, interventional radiologists, pathologists, they're all involved in managing these patients. And patients, especially who've got recurrent tumors or systemic disease or isolated systemic mets with primary liver, with HCC, or BCLC-C, where the liver disease is bad but the tumor is early. So you have a lot of situations in HCC where you're confused, or there is multiple factors that come into decision making. So that's where AI is going to help us. So complex decision making across heterogeneous populations. There is always limited time for case discussions. There is variability in treatment plans between centers and even between clinicians. I mean, if X in the same team conducts the tumor board versus Y, the plan could be different. You know that. There is radiology variability in imaging, interpretation, and often rescans are necessary, or repeat scans are necessary just because of either image quality, or the senior radiologist is not there and the junior radiologist can't make out from one imaging modality, so you order the other one. So that happens all the time. There are therefore delays between diagnosis and treatment initiation, and the time has come to integrate molecular and genetic signatures and precision medicine into decision making. I mean, the clear example you all know is we do next generation sequencing for patients with cholangiocarcinoma, and those with IDH1 mutations do slightly better, and they respond to ivosidenib. So that's just one example. So the general use of AI in multidisciplinary decision making is that obviously it can help you do literature search, guideline search. It can make summaries for you. That's very simple. We all use AI for that. In radiology, it can improve image quality and reporting quality, and repeat scans can be avoided. And they come down by about 40%, and obviously time is saved. And in pathology, what happens is typically the pathologist just comes in and just gives his or her view and just shows a couple of slides, if at all, and people just move on. There is no discussion. It could be a senior pathologist, it could be a general pathologist, may not be a liver pathologist. So there is a lot of, again, variability and I would say not enough involvement of pathologists and pathology. And that can be resolved by using AI to help the pathology interpretation and reporting. I mean, if you have digital pathology, you can share photomicrographs, you can select which ones to, if you put in the data of the patient, then AI-aided pathology can actually select the right PMGs to look at. That's just one use. But those are general uses. Now I'm going to concentrate on 4 next generation uses of AI in multidisciplinary tumor boards. So first is radiogenomics. And this basically means that you use genomic profiles. You don't do genomic profiles, you just look at the imaging and you will know what sort of genomic profile you're dealing with, right? And this obviously avoids non-invasive procedures, and there is about 84% accuracy in this prediction. Then multi-omics can be integrated into decision-making, basically, which means molecular subtyping is done before the treatment is planned. And this results in about 37% modification of treatment plan. And then you can select treatment according to AI-aided algorithms. And there are machine learning models for personalized therapy. And it's been shown that there is nearly 90% concordance with tumor board decisions when you use these treatment selection algorithms. And then there is response assessment. So if you use computer vision, you can basically pick the response earlier and better. In one study, it showed that they picked it up about 6 weeks earlier than manual reporting. So now let's look at radiogenomics. Radiogenomics is basically, like I said, picking up genomic profiles just from imaging without actually having to do a biopsy. So there is this deep learning platform that Tanaka et al. Have published, and that correlates imaging with genetic profiles based on about 1,500 patients across 8 centers that they matched up the imaging and the genomics. And different mutations had a pickup rate of about 76 to 92%. And what are the benefits? Benefits are that treatment decisions are influenced in 30% cases, unnecessary biopsies were avoided in 40%, there was a month reduction in time to treatment and treatment initiation, and there were cost savings. And what are the use cases for radiogenomics? These are patients who cannot have a biopsy or who need urgent treatment initiation, because obviously biopsy turnaround will take a week or so. And then people who have, patients who have recurrent disease with insufficient tissue for genomic profiling. Now, let's look at its use in molecular subtyping. So there is an excellent study published by Chen et al. Last year, 1,000 patients across 7 centers. And they talked about a platform that integrates all the omics, the transcriptomics, proteomics, metabolomics, and genomics. And you can do that manually as well, or with regular statistical methods, but the AI platform reduced the analysis time from weeks to hours. And in this platform, they identified 5 molecular subtypes. The immune-activated ones, which showed higher immunotherapy response 3 times. The beta-catenin activated ones, which basically proved to be immunotherapy resistant, and there was enhanced TKI sensitivity. Then the proliferation type, which would benefit from combined approaches. Then the metabolic dysfunction type, where NASH was the etiology, and they were not good candidates for local regional therapies. And there was stem cell type, who had a better response to developmental pathway targeting agents. So basically, looking at molecular subtyping is not very common in HCC currently, but this study does identify, based on 1,000 patients, 5 types which influence clinical management. So I've already talked about this. Now, there was another study, again on molecular subtyping, and this was a platform that integrated genomics with treatment prediction based on about 1,700 patients looked at from 11 centers. And what were the components of this platform? There was genomic profiling, there was literature mining for treatment biomarker associations, and treatment response prediction algorithms. So these were the parts of it. And what were the outcomes? Operationally, 95% concordance with expert opinion, and they identified actionable alterations which were missed by standard testing in about half the cases, and the preparation time reduced from 7 hours to about 2 hours per case. And the number of sessions, the number of patients you could discuss in one MDT or one tumor board meeting was doubled. So obviously increases the efficiency and increases the, reduces the miss rate and improves the management of patients and eventually the outcome, right? And those were the operational outcomes. Clinically relevant outcomes were that basically they were, in about half the cases, there were treatment changes, right? And eventually there were one third of the patients had improved response rates, and there was about a 3-month extension in progression-free survival, and patients with rare genomic alterations had much more improvement in clinical benefit, and again there were cost benefits. Now, what about treatment selection? We've spoken about radiogenomics, we've spoken about molecular subtyping, and what about treatment selection? Now, there was this machine learning framework that Zhang et al. Have published. This is from 5 US centers. 4,200 historical cases were used to train this algorithm, and then this was validated on 3,000 new patients. And the key areas that were impacted were BCLC, like which of the patients will be impacted by this, BCLC-B with comorbidities, or patients at the interface of A and B, and those who needed to have second-line therapy because of treatment failure, and those who had rare genetic mutations or uncommon presentations. So these were the ones who benefited. And clinical outcomes-wise, again, in a fifth of the cases, the treatment plan was modified, and there was improvement in progression-free survival, and there were cost savings. Now, you can have machine learning-based treatment plans, but I mean, do we trust it? Do we trust these plans? And I think that the main thing is that there has to be transparency. So if you all know what factors are going into this black box before the recommendations come out, we'll be more confident in accepting them. And then, of course, we are used to having confidence intervals and comparative outcome predictions, so we must have that for all treatment plans that are AI generated. And the other thing that helps is if you have small summaries incorporated into tumor board presentations. So there is a manual presentation and then there's an AI summary. So everybody can appreciate the differences. And in terms of adoption, the people who participated in this study, the trust scores, there was a scoring system that improved from 64 to 87% over 6 months. And the greatest impact was obviously observed at a center with less HCC experience, because they were short on logistics, so they benefited more with AI. And there were quarterly model updates incorporated into the new outcome data, and of course, always there was a human oversight, and humans made the final decisions. So now, what about computer vision for response evaluation, which basically means that you have AI-aided reporting for response, right? And these guys basically looked at 700 odd patients with sequential imaging, and they made deep learning algorithms for treatment response evaluation. And again, there was 90% plus concordance with expert radiologists, and the analysis time obviously came down from 25 minutes to 3 minutes per case. The advantages were that response detection was earlier by 6 weeks, and there was a superior differentiation of treatment-related inflammation versus viable tumor. That's obviously a problem. Sometimes a PET lights up, and you're worried whether it's inflammation or it's viable tumor or recurrence or residual tumor. So with AI, the differentiation is easier, and there is improved detection of new smaller lesions intrahepatically, and there is reduced inter-observer variability, obviously. And again, a third of the cases had treatment changes based on AI findings, and costs were saved in all of these papers. Majority of them are from the US, they're very cost sensitive. Now, I've quoted these 4 or 5 studies, and what are the common challenges across these studies? Obviously, technical integration into your current workflows, that's the main thing. So the solution is that they should be standardized APIs for our electronic health records and PAC systems. And obviously, each hospital or each institution will need site-specific calibrations. And we often feel that it will cause workflow disruption. But I think that it just means that you have to have continuing education and phased introduction. And in terms of clinical acceptance, obviously the solution is to have transparency in AI decision making. And it always has to be positioned as something that supports rather than replaces clinicians or radiologists or pathologists, right? And data quality and security are always issues. But I think if the clinical acceptance is there, this will progress. AI is going to progress whether you like it or not. So we should accept it. So to summarize, basically AI integration reduces invasive procedures, there is better treatment and survival, and there is cost saving. And the next steps will be that this should be implemented across big centers and then small centers. And they should be like a multimodal tumor board platform, which is basically a software into which AI should be integrated. And they should be prospective RCTs comparing AI augmented and standard tumor boards. And so I think to conclude, augmentation of HCC tumor boards with AI is obviously a paradigm shift in precision medicine or precision liver medicine. But it does enable personalized treatment selection, more accurate response assessment, and eventually we hope better patient outcomes. One thing I've missed in my talk, and that's disclosures. So I used AI as co-pilot, and I used ChatGPT, Claude. I also used DeepSeek. I used Gamma. I told you the Gamma is the slide presentation platform, but didn't work very well. No other disclosures and conflicts. So first I asked Claude to give me 20 references on use of AI in HCC tumor boards. Most of it, the last 15 were not that good, so I chose the top 5. And then I asked ChatGPT to make summaries of all these papers. And then I asked Claude to make them into slide content on text. And then I did some work myself and made this presentation. Thank you very much.
Thank you, Dr. Soin, for this very interesting lecture. Now the house is open for all the 3 keynote addresses. Dr. Sherry Bhuri's lecture on HCC screening, robotic lecture by Dr. Dieter, and the tumor board talk by Dr. Soin. So we can have questions now.
Can I have a question? Can I have a question? Am I allowed a question, Professor Soin?
Yes, Dr.
Okay, the first one is if robotics will change the paradigm of non-operating child PUC-B patients. I mean, what is the effect on liver decompensation of robotic surgery? Will we operate on child PUC-B patients with robotic surgery in the near future? This is the first question.
So that's a good question. What you're saying is that if you were doing a hepatectomy for HCC in cirrhosis patients, then would the robotic approach make it safer, right? Is that your question, Sherry?
Or possible.
Yeah.
Or possible.
So before Dieter responds, or Dieter, you want to respond first?
No, go ahead, please.
Well, I think that so part of the decompensation that you fear will happen to these patients who have cirrhosis when they undergo hepatectomies is because of anesthesia, just the stress of surgery. I think that will probably remain the same, but I may be wrong there because there is no retraction of the parietes, although the liver is manipulated. So I'm not sure how that will pan out, but you'll have to compare robotic with open approach. in similar patients, like basically do a case control study or ideally a randomized control study. Secondly, I think that if the blood loss is less in the robotic approach, that could actually benefit the patient and reduce the decompensation rate. So I think that there is no clear answer. Right now, I would treat the patients the same way, whether I'm doing a robotic or an open hepatectomy. But potentially, aided by studies and experience, there could be benefit in the robotic approach. Dieter, your comments?
Yeah, I agree exactly with all what you said. There are studies, not randomized, but there are studies about it that there are advantages of the robotic platform also in cirrhotic patients when you do liver resections, but it will not, this advantage not to a degree that there will be a paradigm shift. So because the limiting factor is the cirrhotic liver itself, and this robotic platform will not change. So you can be a little bit more brave, and you have a better outcome in this patient population, but you cannot do major liver resection in cirrhotic liver, so because it's robotic.
Can I make a comment? Can I make a comment?
Yes, sir.
Professor Sain, thank you very much. That was a very enlightening talk. It's a cutting-edge technology, and its time has almost coming. But I quite agree with you, there are limitations to AI techniques. And all the AI models are known to confabulate. Wherever there is a gap in knowledge, the AI models have been trained to give near perfect answer, and therefore they draw information which is not exactly relevant to the question. But they, for example, if you ask a question about HCC, they may draw information from cholangiocarcinoma and place it in the HCC. And you yourself said that Claude AI last 15 papers were not very relevant. So this kind of thing is very routine with AI. And therefore the reliability at present is not very great.
So fair comments. As far as hallucinations go, I mean, do you know human beings? Confabulation is in our, is in our blood as human beings also. But yeah, I completely agree with your comments. The other thing is that, there's always going to be human oversight. So you're never going to actually give the reins completely to AI, and that's never going, hopefully never going to happen.
Dr. Swain, does AI help in learning surgeries and doing robotic transplantation? AI?
So I think that the answer is it will in the future. We don't use it extensively for learning right now. For learning, what is used is XR, like AR and VR, augmented reality and virtual reality. Aids are there for learning surgeries, for demonstrating surgeries to students, or even demonstrating anatomy to students. So that's where XR is used. But AI is a slightly separate thing. And what is happening is Intuitive Surgical that do the robot that we use, the Da Vinci robot, they actually have an app where they are, and a website obviously, and you can actually upload your procedures that you commonly do, and they are having this input from key people across the world. So let's say Dieter uploads 5 robotic donor hepatectomies and 5 recipient hepatectomies, recipient surgeries, and I upload 5 donor hepatectomies that are done robotically. And similarly, this happens from 20, 30 people across the world. So then the platform has data, and then the AI basically gives the ideal ways of doing something in terms of patient outcomes, time, etc. And the learners can actually learn from that. So that is one area where Intuitive Surgical is actually developing AI to teach the students how to do better robotic surgery. I mean, this is happening right now.
Yeah, my question is for Dr. Sherry. So excellent talk, and I think we all would agree that surveillance for HCC is not good at present. And so our experience with abbreviated MRI has been very good. You've just published a data on 75 patients with MASLD. Obviously, in MASLD, the pickup rate of HCC is quite low. And abbreviated MRI is very quick. You can do it in 5 minutes, even faster than an ultrasound. And the pickup rate was too good, the sensitivity specificity. What is your thought on abbreviated MRI as a screening strategy for HCC?
It's really an amazing option we have for our patients. But for example, in Europe and in Italy, where I come from, the limitations of the MRI are really severe. So we can't rely at this time point with abbreviated MRI. But of all the options I showed you, I think that MRI with AFP or with other features, other clinical features, may be the next option in the very near future. So abbreviated MRI above all, yep.
Buri, do you screen for HCC in patients who are child C cirrhotics and patients with HCC who are child C cirrhotics, for screening for HCC in child C cirrhotics,
Well,
who cannot afford or who can't go for a transplant?
Well, in Italy, we have a very strong surveillance program. And so we do also screen patients child Chi, even though they do not have a particular therapeutical option at that point with HCC. So we do. Professor Soin, may I just ask you, now I want your comment on this. I think we are in an era in which we are not learning from AI, but AI is learning from us. So if we confabulate, AI will confabulate. What do you think about this?
Well, I completely agree with you. Everybody knows that there are biases in AI depending on who's actually, which data scientist is training the model. You know, there is this interesting short incident that I'll relate. Basically, what happened is in the US, there are cameras and this data is then analyzed by AI. And one given year, it was thought that the blacks were responsible for half the accidents on New York roads. But that was actually not true. It was just that, one, the white scientists actually that had done the algorithm. And the second thing is, there were just too many blacks in that particular area in which there were cameras. And it just picked up that population as being responsible for the accidents. It didn't actually pick up the people in the cars, right? To the extent it should have. So I think that what you give AI is what the AI will churn out eventually. But then, you know, there is deep learning. So AI is learning on its own. So once you teach it wrong habits, maybe that will never go, right?
I'm a little bit concerned on the quality of the data we are putting in.
Yeah, yeah. I mean, I think that a lot has been done on this in terms of having equality and balance in who and how the data is fed in actually. So I think we have to police it.
So my question to Dr. Buri, can we combine USC ultrasound with 2 biomarkers or 3 biomarkers like AFP? Can we combine with PUCA2 or DCP like that? Can that increase the sensitivity of SCC screening, combination of biomarkers and ultrasound?
Well, if I may refer to the very recent EASL new guidelines, unfortunately, that combination doesn't improve sensitivity. So at this time point, I would say no.
Even the GALAD is not very good. The GALAD score is not.
Even the GALAD, yeah.
I think we need to end it here. So thank you all speakers and panelists for inputs and discussions. We would like to have the backdrop for a photo. We will take a break for an hour from 1 to 2 for lunch. But be here at 2 p.m. sharp because we'll be having a very interesting topic, institutional debate between 2 institutions, ILBS and single-based MACS on management of drug-induced acute liver failure. Thank you. The lunch is at the back side of the hall, on the left side.
ठीक है ठीक है
Hello. Welcome back, everyone, after the lunch. We have a very interesting session now. This is an institutional debate, ILBS versus CLBS MACS. So we will first present a short case on drug-induced acute liver failure. And then we have two speakers from both the institutes. Dr. Harshvardhan, from ILBS, who will speak for CRT plex initially in the case. And we have Dr. Sushant from MACS, who will speak for upfront transplant. And to back them, we have their teams consisting of Dr. Rakhi Maiwal and Dr. Pamecha from ILBS and Dr. Shweta and Dr. Shekhar from CLBS MACS. So can we have everyone on the stage, please? And we have two judges who will judge the best team. The judges are Dr. Mettu Srinivas and Dr. Saraswat. Can we have you on the stage? So first, Dr. Harshvardhan will talk for CRT/Plex. No, sorry. First, we'll present the case.
Good afternoon, everyone. I'm Dr. Radhika, and I'll be presenting the case for today's institutional debate. So the case involves a 37-year-old male patient weighing 71.6 kgs with a height of 170 centimeters. His BMI is 24.8. He was evaluated initially outside in July 2024 with constitutional symptoms of weight loss and fever lasting for 8 weeks. A PET-CT scan was done, which showed mediastinal lymphadenopathy, raising suspicion for granulomatous lymphadenitis, possibly of tuberculous origins. He was started on anti-tubercular therapy based on these findings and had been on the medications for the last 5 weeks when he presented to Medanta with a new set of symptoms. His symptoms were fever with jaundice in 7 days and altered sensorium since 1 day, which meant that the jaundice to encephalopathy time was less than a week. On admission, his vital signs showed hemodynamic stability, and on neurological examination, his pupils were found to be bilateral equal and reactive to light. He was classified as grade 2 hepatic encephalopathy with restlessness and irritability. Routine evaluation of the fever and viral markers also showed, which were negative, pointed towards a non-infectious etiology. So his outside investigations from the day before showed that the patient had coagulopathy with a raised INR of 7.34, a total bilirubin of 21.3, and elevated liver enzymes of AST at 299 and ALT at 568. His ammonia levels had risen to 175, and his kidney function tests were normal. After admission, a repeat set of investigations were sent for the patient, which showed that his coagulopathy was worsening with INR at 8.34, his bilirubin was now 22, and his ammonia had risen to 283. Signs of cerebral edema and increased intracranial pressure were evident based on his non-contrast head CT and transcranial Doppler. The transcranial Doppler showed an elevated pulsatility index of 1.2 and a raised resistive index of 0.8. The optic nerve sheath diameter was increased bilaterally. The patient's clinical condition was rapidly deteriorating with worsening of the hepatic encephalopathy to grade 3, which required elective intubation. The patient's family was counseled on his disease condition and possible line of management. The line of management considered were plex with or without CRRT and liver transplantation. Based on the patient's history, examination, investigations, and radiological reports, he was diagnosed with acute liver failure of ATT-induced hepatitis related. The features and the findings are mentioned in this slide.
With that, I would like to call Dr. Harshvardhan for his take for CRRT and aegis.
At the onset, I'd like to thank the organizers, Professor Soin and Dr. Neeraj Saraf, as well as Dr. Swapnil. Yes, so we already seen the case, and the only line that I'd like to start with is that words ignite and debates enlighten. So let's have this an enlightened session. So this is already the case. We already know the salient features. He has a high INR, ammonia of 283, a high ONST of 0.6, and etiology is drug-induced liver injury. And he's also an AB positive recipient with grade 2 to 3 hepatic encephalopathy requiring mechanical ventilation. Now, if you use the KCH criteria, which has been used in this patient, I think he meets the single criteria. He's a universal recipient. So I don't think without any doubt we should not say that he requires anything else except a liver transplant. However, if you go back to the case, and that's what was mentioned, that the family was counseled for a donor. So the next important question is, when do you identify the donor and has he been worked up? Because at this point in time, the patient is in the liver ICU, is intubated, single criteria, diffuse cerebral edema, high ONST. So some of the issues that come about in a real world setting are the donor identification, especially in a live donor setting. Managing the complications of acute liver failure till the transplant workup is complete. So time to liver transplantation. And of course, the fallacies of what the present criteria offer us. So more importantly is donor identification and timings. So one of the first few studies on a single center experience from ILBS in 2016 has shown that nearly 460 donors were evaluated for about 367 recipients. Among those, you could see that nearly 69.5% could not go for a donation, and donor-related issues were close to 63 to 64%. And more importantly, there was a donor reluctance of close to 24%. So 1 in 5 individuals were actually reluctant to give a liver for transplantation. Another study, which was subsequently done in Korea, had shown that nearly 30% of the times and 20% of the time on recipient causes, you do not find a donor either of an indication of cirrhosis as well as acute liver failure. So some of the limitations in an LDLT setting is the donor selection and the donor criteria that is based upon. Now, the largest single center study for acute liver failure in LDLT, which was performed by Dr. Pamecha, had shown that only about 14.9% with acute liver failure underwent a liver transplantation. The median admission time to transplant was 48 hours, and yes, it takes time to evaluate the patient. The patient has to be optimized before they go in for a transplant with a very good survival of nearly 66.7%. It's important to note that the significant mortality factors included persistent cerebral edema and the presence of SIRS in the group of patients who eventually had an adverse outcomes. Now, in the same study, nearly 188 patients over a 6-year period of acute liver failure, only 61 of the patients, which is 32% of the patients, underwent the live donor transplant, whereas nearly 68 of the patients could not undergo a transplant because either the family was not willing, there were financial constraints, there was no suitable donor, or there were complications related to the recipient at that point in time. So this tells us that if you have a patient who comes in for acute liver failure, donor identification as well as the time to a liver transplantation may take some time. And in the same study, if you look below, most of these patients, nearly 38.5 patients, had undergone a plasmapheresis prior to the liver transplantation. So is there a role for plasmapheresis or CRRT prior to these patients actually undergoing a liver transplant as and when the donor is identified? So one of the important caveats was that it could possibly bridge more patients for liver transplant and improve post-LT outcomes. Now, these patients, also if you look at, this was in 2012, again from Korea, and if you look below, you can see the transplantation number of days was nearly 3 to 4 days. So nearly 72 to 96 hours was taken for these patients to undergo an acute liver transplant for an acute liver failure. Now, also we need to keep in mind that even though this patient is not septic, the TLC count is normal, even if you use something called as a biofire, respiratory biofire in these group of patients, you do find in nearly about 25% of these patients to actually have carbapenemase resistant organisms. So optimization of the patient at T0, which is the moment the patient enters into an ICU, is of paramount importance. So as I would say, the transplantation would depend on the donor factors, recipient status. Most of the centers within 24 to 48 hours till the selection for liver transplantation, and optimization of hemodynamic supports and ruling out septic should be considered in the time given for liver transplantation. So again, is there any benefit for using these two modalities prior to a transplant? Well, we go to plasma exchange, and this has been now heavily studied, and if you look at most of the mechanism, and as I had shown you earlier, some of the poor prognostic markers was the presence of SIRS. So if you have plasmapheresis and the patient is suitable for plasmapheresis, it actually helps in clearing toxins. It improves the systemic hemodynamics, which has been shown in the recent studies, as well as improves the endothelium 1 function. Some of these studies which were done, and the first study was done in 2016, and this was a cohort of patients from Europe, had shown that the overall survival was close to 58.7 to about 47.8. Our own study, which was published in Clinical Gastroenterology, which was primarily viral hepatitis, had also seen a higher transplant-free survival of close to 75% as compared to 45%. These patients did not have a transplant donor, and that's the caveat behind it. You can also see the other trial, which was in 2019, and these were patients who had actually had a toxin-induced acute liver failure. Even there, the survival was close to about 65% compared to 50% in these group of patients. Now, other is the mechanistic part of plasmapheresis. And if you look at the mechanistic part, as you can see here in this study, that there is a decrease in IL-2, IL-17, IL-1 beta, whereas there's an increase in IL-4, 10, as well as FGF2 and TGF-alpha, thereby suggesting that there is also a scientific basis to why you could do a plasmapheresis prior to the patient receiving a liver transplant. Another single center, the largest study which was done at our Center for Pediatric Acute Liver Failure, had shown that if post-operatively these patients had received plasmapheresis, they had rapid clinical recovery, as well as early extubation and shorter ICU stay. Even though the mortality benefit was not there, but you could actually see that there was a better recovery in these group of patients who did require a plasmapheresis by the time they were optimized for a liver transplantation. Yes, there is one study which was very recently published on why plasma exchange may not improve the overall survival in these group of individuals. However, this study had also shown that it was associated with significant improvement in hemodynamic parameters, but there was no significant survival benefit. There was some criticism to this study, and as you can see, there was some data discrepancies as well as for survival outcomes. So this is a debate which is going to be ongoing, and proper randomized trials could answer this question for us. The next is CRRT. And if you go to one of the earliest studies for using early CRRT, which is in the year of 2018, and when I say early CRRT, this is on day 1. And they used it for hyperammonemia, because hyperammonemia, CRRT has been shown to be beneficial, and it had been shown that if it was used on day 1 or day 2, it had also shown to have a survival benefit. And look at the ammonia levels, it was more than 181. Our patient has an ammonia level of 283 at the time of presentation. So early CRRT, if you could see from day 1, the median ammonia decreased from nearly 38%. So earlier you start a CRRT till you optimize the patient for transplant is the way forward. Another study from an Australian and New Zealand cohort of nearly 62 patients where the mean ammonia levels was only 132. And these patients also did not have acute kidney injury. So 10 patients, nearly 23% of these patients did not have an acute kidney injury. Even there was significant reduction of ammonia as well as helping in CRRT. So we looked at this RCT, which was presented at ASLD, which looked at the preemptive administration of CRRT with acute liver failure. And the only point I'd like to highlight in this is each hour delay in CRRT was associated with increased mortality. So still the patient is optimized for liver transplant. It's imperative that you start these measures, including CRRT or plasmapheresis. Next question is if you do not fulfill a KCH criteria, and that is the fallacies of the present day scores. If you look at the KCH score, poor sensitivity, they do not have the dynamicity at this point in time, do not know if there is futility for transplant, they still do not consider using, say, brain volume or a liver volume. We looked at it using an ALIF score, which is an acute liver failure score in the emergency, and we actually found out that if you can use a CT image and a liver volume, you could actually start predicting the mortality on day 1 or day 0 when the patient comes to you in the emergency. So this is another management, and this looks at if a patient presents to you with acute liver failure, has high grade of hepatic encephalopathy, you send him for a CRRT or a plasmapheresis depending on the indication and the optimization. And at this point in time, you're actively working up the patient for liver transplant as well as counseling the donors for it. Now in this battle, I would say, and I would rephrase the question, a patient comes to you with diffuse cerebral edema, grade 2 hepatic encephalopathy, meeting all the criteria for a transplant. Team ILBS would say CRRT with or without plex till the donor is identified and fit for a liver transplant. At the end, I would say one size does not fit all. I think the approach has to be case-based. It's more of an adjuvant rather than a versus therapy. And if you're planning for CRRT or plasmapheresis, it starts at T0, which is time 0. Timing is early for better outcomes. Thank you.
Dr. Shushank for against TRRT or
Very good afternoon to all. I would like to thank the organizers, Professor Soin and Dr. Saraf for inviting me, and Dr. Gupta for giving me a chance to represent our institution. Now, coming to my first opening remarks, first of all, this debate does not question the non-transplant management of ALF. Many patients will improve with standard medical therapy, and my colleague, I would like to differ from my colleague, Dr. Harsha, where he said it's the battle between institutions. No. It's the battle for the patient. Even if the patient improves without the transplant, I think the battle is won. And as Dr. Harsha also elaborated, that unfortunately a robust criteria for deciding transplant is still lacking till date, and most of the institutions would go forward with a dynamic assessment even if the patient does fulfill 1 or 2 criteria. And this dynamic assessment, where we assess the neurological status, where we assess the INR, will be impaired by both the plasmapheresis and CRRT. So the optimal timing of deciding whether to transplant or not is going to be lost. So just briefly about a case, it's a case of ATT-induced ALF. The jaundice to encephalopathy time is 6 days. Patient is having grade 3 encephalopathy, has been intubated, there's no inotropic support, there are normal renal functions, and there is no obvious sepsis here. So what are the issues that have to be addressed here? As per the King's College criteria, liver transplant is strongly indicated. So listing the patient in a cadaveric program would be appropriate. And in cases, in centers which predominantly do LDLT, where supposedly a donor can be worked up quickly, should we even be thinking of going for plex first in such a case? Is there even a need to bridge this patient who is stable, there is no inotropic support, and the renal functions are normal? Cerebral edema, yes, can be felt, and so far we have not devised any standard method for measuring the CPP. Neurosurgeons have refused to insert any intracranial bolts, and in such a setting, ONSD may be the best marker, which is elevated in such a case. Now, I would just like to briefly tell my audience, how does ATT ALF differ from the other categories of DILI-induced ALF? As we all know, there are 3 categories: direct, idiosyncratic, and intermediate. And generally, ATT-ALF is because of idiosyncratic reaction, an immune reaction which has already been there for the last 1.5 months, which is given in this case because the ATT was started almost 1.5 months ago. So I am not sure whether plasmapheresis would help in reducing the inflammatory markers which have already been there for the past 1.5 months. So ATT-ALF generally presents with a high grade of encephalopathy, higher amount of cerebral edema. The mortality is 67%, and the prognostic markers are bilirubin, INR, and creatinine, which need to be monitored serially. And in this study, it was found that idiosyncratic DILI has a very high mortality of almost 75% if they are not transplanted. Again, this study from AIIMS New Delhi says that there's a very high mortality with ATT-ALF, and ICU care, including plex and CRRT, they improve outcomes only modestly. And 76% of the patients will die within 5 days of hospitalization unless and until a step like liver transplantation is undertaken, which should be the case and should be considered at the earliest. So the bottom line is ATT-induced ALF has a very high mortality. Being idiosyncratic, survival without transplant is only 25%. And the immune reaction has been there for weeks, 1.5 months, and so on. And we have to understand this, that many patients of early CLD with nodes and fever likely would be diagnosed as a granulomatous lymphadenitis and would be started on ATT empirically. In such cases, this would not be an ALF, this would be an ACLF. The liver will not be able to regenerate in such cases. So this has to be kept in mind specifically for ATT-induced ALF. INR, bilirubin, and creatinine are important prognostic factors, and they have to be monitored serially, and transplant should be considered at the earliest. So what does the standard medical management entail in a case of ALF? It includes protocol-based antibiotics, cerebroprotective ventilation, maintaining the fluid homeostasis so that the patient has the optimal chance of recovery. In addition to that, liver assist devices have come up in a big way, which includes CRRT, MARS, and plasma exchange and bioartificial liver. But the experience with all these liver assist devices have not been favorable. The evidence is not robust as of now. So the case against PLEX and CRRT, specifically in this case, is an hyperacute presentation. Most of us would believe that hyperacute ALF generally does resolve. They have the highest amount of self-resolution. Prognosis in ALF is determined by etiology. In this case, ATT induced, obviously, with a very poor prognosis, the presence of cerebral edema, and the ability to regenerate. Again, I would like to emphasize that empirical ATT is sometimes started in patients of early CLD, and hence the ability to regenerate might already be compromised. So coming to plasma exchange, which my colleague has said that would be a very important management for bridging to transplant. It all started with this study, Larson et al. It is the largest randomized control trial, and based upon this study, it's being advocated very, very strongly. I would like to draw your attention to certain subtle points in the data. First of all, that 50% of the patients in either the PLEX group and the SMT, the standard medical treatment group, were already fulfilling the King's College criteria before being included in the study. Secondly, ultimately, out of these 50% patients, 26% of them, of the total cohort, and 35% in the standard medical therapy, ultimately went and received liver transplantation despite the therapies being done. And this did not reach any significance. That means that in those patients who were transplanted, this plasmapheresis had no survival benefit at all. So this can be seen very well in this graph, where the highest survival is seen in those patients who received transplant directly. Now, please do not misunderstand me. Transplant directly does not mean that the patient did not undergo any period of medical monitoring or medical therapy. They were started on standard medical therapy, and if their parameters were not improving, they were given an upfront liver transplant. The PLEX was not done, and these patients had the highest possible survival. Now, coming to this study again, as I said, that 50% of the patients were already included in the KCC criteria and were listed. Out of them, 26% and in the PLEX category went and received transplant, and 35 in the standard medical therapy went and received transplant, and there was no benefit in survival overall when we considered these two groups. So patients who were listed in the King's College criteria, who were listed for transplant, and if they did not receive a transplant, that means they resolved spontaneously with either the standard medical therapy or PLEX. Again, the study says that there is no survival benefit in such cases as well. So patients who are meeting the King's College criteria and get better on their own, again, in this case, PLEX did not seem to provide any benefit compared to standard medical therapy. The only benefit that is there, which is driving this group to have a very high survival rate, is the patients who were fulfilling the transplant criteria but were not listed because of medical contraindications like severe psychiatric illnesses, etc. So we can say that it resulted in benefit, or we can interpret that this listing criteria is not up to the mark as of now. So Larson et al. Is definitely a landmark study. However, in the real world cohorts, its benefit is still unknown. There are concerns about sepsis, coagulopathy, and worsening of brain edema, especially with high volume plasmapheresis. And they used high volume plasmapheresis, which is hardly used now. It causes worsening cerebral edema, fluid imbalances, cardiac failure, and sepsis. This recent study, as mentioned by Dr. Harsa, has proved that plasmapheresis does not provide any survival benefit within or outside the King's College criteria, and does not provide any transplant-free survival benefit within or outside of the King's College criteria. So to summarize the plasma exchange, in Larson study and most of the studies which advocate plasmapheresis, they use paracetamol was the major cause. We hardly see them these days. And the advantages of Plex seem to be there when it is started within 12 hours. I mean, is that even possible in the Indian context? And if there is no benefit if started late. All of the studies say once the sepsis and MOD start, there is no benefit of Plex. But this is the phase where maximum patients would be referred to the transplant centers. And we lose the single most important prognostic factor, which is serial monitoring of INR. Now coming to CRRT, which I think is now just a ceremonial purification. Most of these studies advocate CRRT, but there has been no improvement in survival. There has just been decrease in levels of ammonia, which are there, and that too in very high flow rates. I mean, all of us know that high volume plasmapheresis is not tolerated, yet all of us, most of the studies advocate CRRT at high flow rates to lower the ammonia. I mean, that has to be taken with a pinch of salt. There is hardly any data to support the use of RRT outside the context of AKI and ALF. And this largest study by Cardoso and Carvalho et al., although it's a retrospective study, in fact showed that CRRT resulted in a higher mortality. This meta-analysis, which has recently been published by Dong et al., had taken into account the largest retrospective study and some of the unpublished data as well. They showed very modest improvement with CRRT on overall survival. In fact, some of the studies even not favoring CRRT, and some of the studies even going on to say that there is, in fact, decrease in the overall and the transplant-free survival and increase in the overall mortality with the use of CRRT. So, coming to my plan. So in this patient, when the patient needs a transplant, I'll do it quickly, obviously. There is no question about it. We will lose a very golden opportunity of providing a cure to this patient. So in our institution, we would begin with medical management. We would monitor the INR, bilirubin, the enzymes, and we would monitor the neurological parameters. We would simultaneously work up the donor for liver transplant. We'll do up the formalities. And if the patient improves, excellent, that's the goal. No one is trying to justify a transplant in a case of DILI or in ALF all the time. But if the patient does not improve, there is no doubt that this case should be transplanted at the earliest. And obviously, we would not do Plex as it alters the INR, and there is no data on rebound INR as claimed by some of the groups. There is very limited evidence to suggest CRRT or Plex to avoid transplant improves any sort of or gives any sort of overall survival benefit. CRRT for reducing ammonia with normal renal functions is still debatable. Alteration in coagulopathy can hamper because heparin is used more often to, so that the kids do not coagulate. And citrate anticoagulation is fraught with very severe complications of acidosis and poor outcomes. So hence, I would like to conclude that this patient who has been suffering from ALF for the last 6 to 7 days should be transplanted if the does not improve until the time we can get the patient a donor. Thank you.
Thank you, Dr. Sushant. I would like you to take the seats. I think it's a very high voltage debate, and now it's the turn of the mentors for the rebuttal. For Team ILBS, Dr. Rakhi, Mehwal ma'am, and Dr. Pamecha sir for your rebuttal and comments.
So my first point is we have been given a dynamic assessment of the patient, and the patient has failed standard medical treatment because we've not done anything, so patient is worsening. Obviously, he meets the transplant criteria, and we're not denying it at all. He meets the absolute criteria, looking at all the features. We're not saying we're against transplant, and the patient should not be taken up for transplant. At day 1 itself, I think so the transplant donor identification should have started in this patient. And the patient has now progressed to a stage of grade 3 encephalopathy. The cerebral edema at the onset itself is suggestive of very high ONSD and TCD, which needs immediate attention. The ammonia has risen by 100 points, and in a liver intensive care, if you're not giving anything and just continuing the standard medical treatment, counseling for a liver transplant, I feel we need to start some management to alter the natural cause. Plasma exchange, we are not saying we are given 2 options in such patients, CRRT. I totally agree, plasma exchange will alter the INR. So we will not do in such patients plasma exchange, where we are very clear the patient needs a transplant. CRRT is upfront modality. We start the patient on CRRT, we manage the cerebral edema. The Indian series itself, there was a publication by Dr. Akash Roy looking at 4 centers' data. They had shown only 3% patient of the entire cohort of patients could undergo live donor liver transplant. The real life scenario in our country is that, okay, you tell about transplant, but the donors are not there. We are not talking about the cadaveric center at all. First, we are discussing about live donor liver transplant, which we all are working in, and we have live donors. So that is the time which is required, and many a times the donors are not there. So what do we do for such patients? If supposing we have a donor, we start CRRT, we manage. Dr. Nandi's group, initial group from Gangaram had also shown, and Dr. Pameja had published, 2 factors in such patients, cerebral edema and sepsis, which also predicts outcome after liver transplant. So if you've managed your cerebral edema well, so you've done a good job, and even the transplant gets better. For plasma exchange in the pediatric data, patients who were awaiting for a liver transplant, what they did, they showed, Harsh had briefly mentioned, 30% patients only. Those who were meeting KCH, counsel for transplant till they're getting their donors, we saw that the patient is worsening, taken up for PLEX. More severe patients were taken up for PLEX, but the outcomes with respect to PLEX post-transplant, just single session or not more sessions in such patients. So they found that in the study, the improvement of HE, so the recovery post-transplant, the shorter duration of ICU stay was also seen in such patients. The sicker patients given PLEX were doing well. CRRT, no doubt, world literature, globally people know it is very good therapy for reducing ammonia, and cerebral edema is supposedly to be managed, and people are now going to intra-op and even post-op CRRT for patients who have residual cerebral edema in the post-op phase. So those are my counter with this thing. Now supposing if we forget about this patient, and the patient would have come to us with an INR of 4. He's in grade 2 to 3 HE, he meets criteria. So these are the patients where we've shown, if we are not talking about ATT, we have shown that you don't need to watch the patient, the INR should worsen to a stage and not doing and just going by standard medical treatment. So dynamic monitoring of INR and ammonia is important, and we should not say because the plasma exchange would alter the INR and I will not be able to do liver transplant, so I should not be treating somebody and giving that chance the patient for spontaneous recovery. And there is enough data to suggest the early you start plasma exchange, the better are the results. So that is one point against your INR correction. And then if the patient has met the transplant criteria, when we are doing PLEX, we are not looking at the INR when we know the patient is meeting criteria. When the patient is evolving, there are other parameters to suggest that how we choose the patients for a liver transplant. So we don't need to escalate and keep doing these things. Patient does not have a liver transplant, you cannot be just saying that we will not do anything and just wait on standard medical treatment in the current era.
Yeah, I will agree with whatever Rakhi has said. Both these therapies actually give you time. Plasma in children, we have shown there is benefit. There is more intraoperatively also, the hemodynamics are better maintained if the patient had plasma. And that's our experience. And post-operative recovery has been better as well. In terms of doing CRRT, again, both this therapy, when you're working up for liver transplantation, you need to give that time to the family to think about, to identify the donor, work up the donor, and that time has to be used in a productive way in order to decrease most important thing, that is cerebral edema. And then if you can give management in terms of whatever which can lower down the ammonia levels, which was by CRRT, then it is definitely going to help in terms of improving the outcome, and that more patient actually becomes transplantable. Because, a typical Indian patient, they come very sick actually because they are late in the course, and then most of the patient when they come with grade 1 encephalopathy, within actually hours they get tubed because of progression of cerebral edema. And that's one of the main reasons for them to become untransplantable. So if you ask me how you can actually bridge more patient towards transplant, that's the most important thing you need to do actually. Coming to INR, and once a patient satisfies the criteria, I don't think then you need to look at again in terms of whether you are going to continue with that treatment and not transplant them. Because then you need to look at what is the clinical trajectory of the patient. what is happening to the cerebral edema, what is happening to the hemodynamics, and other parameters which are more important actually than INR in terms of deciding, because that's what decide your post-transplant outcome. INR doesn't decide your post-transplant outcome. Okay, so those are important things to look into those patients in order to decide whether you're going to transplant or continue with this therapy.
I think now it's the counter rebuttal by CLBS Max team, Dr. Shweta ma'am and Dr. Shekhar.
So I think Rakhi first, when she talked about this particular patient, at least half my battle is won, that she agreed that there was no role of plasmapheresis in this case, when this patient is qualifying with King's College criteria for transplant. And as far as the CRRT goes, I would say that yes, you have this thing that you are wanting to treat the patient, and everybody is trying to avoid a transplant if they can, the family, the doctor, the whole team. But is it really working in the direction of reducing ammonia? Because the flow rates at which we are able to achieve reduction in ammonia, they are not happening really. So in my experience and whatever literature I have reviewed, I don't think that I can bank on CRRT to run when I know that this patient has come to a transplant center. He has already got a history that he has been taking ATT for 2 months. He does have a short jaundice to encephalopathy ratio, onset of time, but that doesn't mean that his liver isn't already gone to that point where it is not likely to regenerate. So I would put him on CRRT, and then I would think that, is this patient going towards sepsis, and am I going to lose that window which Dr. Pamecha talked about, that I'm worried about, if I take up this patient for transplant, is he going to wake up? So in this particular case, I think there is complete clarity that this patient needs to go for a transplant, especially when he's reached a center with a donor that he wants a transplant. He's been told so much perhaps. That's why he's come to Medanta for the transplant. So that takes care of what Rakhi talked about initially. And then coming to the second part, Shekhar, you want to say something?
So this patient has meeting alpha criteria, KCH, having cerebral edema. Patient is at the liver transplant center. So this particular case has more than 80% mortality without liver transplant. And if we do the liver transplant, more than 93%, 95% survival. So, and the landmark study, Larsen et al. And all, they have shown that the patient who underwent the liver transplant doing plaques will not improve the survival. So a patient who have the 93% survival chance, why we do the plaques? To increase the risk of sepsis, to increase the risk of permanent neurological damage, because patient already has the cellular edema. So we should immediately fasten the process for the liver transplant and do not do the things that are not shown the survival. If not for the patient is not for the liver transplant, then do the plaque, do the CRRT. But in this patient, those patients who underwent the liver transplant, plaques has not shown to be of beneficial. It will not improve the survival. It will increase the risk of the sepsis. It will increase the risk of, by delaying unnecessary, maybe the permanent neurological damage, LTV may become futile. So I think this patient, in this case, we should go as early as possible. We should go for the liver transplant.
Any comments from the audience? 1 or 2 maximum?
I think before we start with the audience, can I have a quick one question for our team ILBS and one question for team CLBS?
Sure, sir.
Thank you. Dr. Rakhi, Dr. Pamecha, I think very well discussed. Now the thing that your opponents have pointed out, that identification of spontaneous recovery in ALF is hampered by these interventions. If a priori you have assumed that this patient is anyway going to go for transplant and we do not need to assess the possibility of spontaneous recovery, which may be anywhere from 20 to 33, 35%, then maybe the strategy is justified. But if you at all there is a theoretical possibility of spontaneous recovery, then how are you proposing to identify that situation once the patient is on these liver assist interventions? Maybe you could have a quick response.
So as I said, Dr. Saraswat, it's the rebound which is very important actually. If you're doing a plasma, then rebound in INR, if it happens, then those patients are not going to do well anyhow. So you have to continuously look at. It doesn't mean that once you've done a plasma, that the INR has come down and it will stay down. It doesn't happen like that. So you have to still monitor the INR, and if the rebound is happening, if it is still doubling up, then those are patients where liver is not going to work, liver is not regenerating. Then the other clinical parameters about signs of raised intracranial tension, those things come into play, how the hemodynamics are behaving, and obviously whether the sepsis is coming in. Those are the parameters, they have become important in the context. So there are many more things which can be looked into rather than just hanging on to INR in terms of deciding whether you're going to do transplant or not.
Thank you. For team CLBS, what I'd like to know is that you have been given a patient who had an initial ammonia of 173, gone up to 280 plus, and also ONSD and other transcranial Doppler signs are suggesting that there is significant cerebral edema. He may have to wait 24-48 hours. There is possibly a risk of cerebral herniation and you lose the patient to cerebral edema. So how are you planning to manage that, or you would ignore that possibility and simply quickly take him for transplant despite the fact that cerebral edema might be worsening? So I'd like your thoughts on that.
Obviously, the patient, we will do all the possible medical, all the contemporary medical management, including the, and in this patient, like all these mannitol, keeping the serum sodium level on the higher side, and all the proper closed neurological assessment, we're going to do that. And CRRT can be considered in this patient. It may reduce the ammonia level, but we will not delay the, we are not going to delay the liver transplant by doing the CRRT or by doing the plaques in this patient.
So we're not saying that you're going to delay it. It doesn't happen. And
But
one of
in
the
this,
most important thing, the beauty of CRRT is you get better hemodynamic stability intra. And actually, the peaks, the sharp shoots in intracranial pressure during intra, if the patient is on CRRT, it doesn't happen. That's the beauty of CRRT during the operation when you are doing an ALF.
And the CRRT improve the patient with cerebral edema. They are very poor evidence. We do not have any RCT. We do not have any prospective trial. They are very poor quality evidence. We cannot bank on CRRT to improve the cerebral edema.
So the last thing you want is a patient not waking up after transplant, and then you regret that you could have been better managing patient pre-op in order to have a.
Before the patient,
the last thing you want in an LV.
One at a time, please. Yeah.
Right?
Before patient going to the OT, obviously we will confirm that the patient does not have any permanent neurological damage.
So we have agreed on taking the patient for transplant on CRRT.
So I would just say the lack of evidence does not mean that the patient, till they are subjected to a clinical trial and the recovery is shown.
So the trial,
so patients are being treated over the years. The data is very clear for CRRT. For a patient of ATT ALF, at day one itself, he met the criteria of transplant in our center. We would start CRRT. We will consider transplant at day one itself because INR, bilirubin and creatinine, important parameters, including an ATT as the etiology itself. And the patient has gone into ventilator within a span of 12 hours. ONSD above 6 is like next to herniation. You cannot just say that I'll not do anything and give mannitol. We have shown in another trial that mannitol is a lot of tachyphylaxis.
Okay, I think all these points have been made in the presentation and as well as by both of you. So I think we are repeating things now. Maybe we can have discussion from the floor. Oh yes, Dr. Reddy.
Let's take a final opinion from the audience. What do they think? Followed by the comments from the judges, and they can declare the winner. Can we have an audience poll? Yeah, I think the voting pads are there on the table and you can choose either of the teams. The final comments from the judges, I think the audience thinks that.
Can I just ask one question to both the teams?
Sure.
So the topic is CRRT, plex versus upfront liver transplantation. So first to Dr. Pamecha. So your patient is with you, the donor is ready, you can go for transplant immediately. Would you still try and do some plex or CRRT to stabilize the cerebral edema and then go for transplantation? Would you go for it directly?
So Mittu, they didn't say donor is ready actually.
No, it said upfront.
They didn't say.
Upfront liver transplantation.
Even
I read the topic just now, but it's upfront liver transplantation.
Neeraj, did you say donor is ready?
No. I mean, actually, doesn't matter.
It's upfront liver transplant.
What I'm trying to say is, the arguments you made are very relevant. In somebody who's got high ONSD, probably impending herniation, would you still take some time to do CRRT to stabilize and then do transplant in the morning, or would you say, I'll go ahead and do the transplant in the night?
So I'll start CRRT and take the patient to theatre and maybe do intraoperative CRRT as well.
Okay.
And continue the
So-
CRRT
sorry.
post-operatively for
Okay.
at least 24 hours.
Okay.
And then see where we are.
And what about the CLBS team? Would you
Sir,
directly go
as
for
such,
transplant or would you
intraoperative-
stabilize?
Intraoperative CRRTs will not be counted as a pre-transplant, no? As we were discussing the
I
thing.
said I will start before. I'll start before the transplant. Take the patient.
No, so
later
the question
on
here is,
CRRT,
see, your
and
donor is ready
continue
at
post
9 in the night.
Yeah, so
Okay,
I
you
think-
want to do overnight CRT, take him in the morning, or you want to take him right now?
See, every intensivist would want to start a CRRT, but I would like to see the delta of ONST. I'm not going to see the value of 0.6 and just say that this patient is moving towards cerebral edema. And if we want to take the patient at 9 p.m. for surgery, we just wheel him into theatre. We have mobile CT and then we'll take him up for surgery.
Okay.
And we can take the we can hook on the CRRT then, not do a pre-op CRRT if we really have to.
So obviously there's no discussion of plex here, it's only CRRT we're talking about. Okay, thank you.
Can we have the final verdict?
So what happened to
by
the patient?
judges?
What did you do?
So we did plex for the patient, and we started plex at 6 hours after hospitalization, and transplant was done at after 24 hours. So because of logistic reasons, he was overseas residents of India, so there were some logistic issues which needed at least 24 hours to get clearance from the embassy.
So can I just ask,
Yeah,
why
that's
didn't
what
you do
happens,
CRRT
isn't it?
instead of plex? Somebody who's got, brain edema on CT, ONSD. I mean, if you had if you can only use one of these two, I would actually start with CRRT and not plex in this situation when you know you're going to do the transplant next day. I mean, that's a question to the Medanta team, I think.
The patient had both hyperammonemia and significant coagulopathy. So, with an etiology being drug-induced acute liver failure, which favored us plex over CRRT.
This is the trial which we have now completed at ILBS, and this is what we're suggesting. Start CRRT, add plex. If the patient needs more time, add a plex to CRRT. It reduces the side effects, also gets better volume control, no complications, pulmonary and other things. So it is a very safe modality if you add it on to CRRT.
So just
CRRT upfront.
one question to Dr. Rakhi. So if the patient is planned for the liver transplant, in these patient doing plex means we know that patient going to have in this
That's why
patient.
I made a point very clear. If the patient, I know 6 hours he's going for transplant, I'll just start CRRT.
No, plex. I'm talking about plex. Will you do plex in this patient? We know that patient is going for a
No,
transplant.
I will not do. I said 24 to 48 hours. If the patient needs more time, obviously I will do plex.
I
will
think
not
can we have the final
just-
verdict by the
Just
judges?
one more point, just to, I don't think we should say plex is the treatment for coagulopathy. Treatment for coagulopathy is giving FFP or clotting products. I think plex is something else. It's extracorporeal therapy to treat the process of ALF, not for coagulopathy.
Srini, can I just make a point? If you look at this specific patient, he was having a bilirubin which was like 23. He had an ammonia which was 280. And in addition to that, he had an INR of 8.54. So I think this is the reason why we use plasmapheresis in this patient. Because plasmapheresis, before CRRT came out, I think again if you go back to literature, in ALF, plasmapheresis was used not only for coagulopathy, it was also used for hyperammonemia. So I think with plasmapheresis you can do all the three things, and this was just used as a bridge. CRRT of course is better for hyperammonemia, now we know that. But I'm just telling you the situation of our patient, and we were not sure whether this patient is actually going to have a transplant because of logistic issues, and that's the reason why we did it.
Can I make a quick point, please? So it looks like the team CLDS was absolutely certain that the donor is going to be fit and anatomy and logistics and everything is going to be sorted out. I think when we are managing a patient like this, you have to start thinking that this patient has to be managed even if the transplant option does not exist. I do not know how many centers will be able to gear up a patient for transplant surgery within 6 hours. So I think it's a little hard to believe. The second thing is, and the problem with all the renal assist devices and why they are still at a stage of discussion like this is because the injury is ongoing and continuous, and most of the liver assist devices are intermittent. So you have to think about it. You've not talked about fever, hypothermia, sodium balance, so on and so forth. So these are the advantages with CRRT. So these are not the advantages that you will get with the plex. So still far more patients worldwide would have been treated with CRRT vis-a-vis plex. And I think in every patient who has a presentation like this, you need to have a liver intensive care management, which would be in the form of some device. And of course, there were many things which you cannot talk about here. There is no data to say that if you use high flow, you do better. There are a number of trials in critical care which have refuted that. Thank you.
I think we need the final verdict from the judges.
No, I think, Dr. Neeraj, we have done our assessment. Dr. Mehta has also done, and I have. So maybe you can come and announce the results, because we are only doing the judging. I guess you're running the session from the floor, isn't it? Like the chair and the moderators. So please come up and I think take, unless Dr. Mehta would like to do it. 36 and 29. This is audience. No, this is just totaling of my assessment. See, running the whole show from the floor, you were basically chairing the thing. This is my, yeah, no, I've not added the audience, but I didn't see what it was. I couldn't figure out to add that. In real life, it doesn't happen for transplant.
Okay, so I think the judges, so there was a sheet given to them and they've assessed it on various points, and the final verdict is in favor of team ILPs. So congratulations. And congratulations, I think CLBS Max did a wonderful job of presenting the case and giving the adequate report. Picture. Yeah, team CLBS, please join the picture. Shweta, please join the picture. Next, we have a session on pre-transplant challenges, timing and optimization for liver transplant. May I call upon the moderators for this session, Dr. Vijay Voda and Dr. Manoj Joshi. The expert discussants for this session are Dr. Karthik, Dr. Narendra Chaudhary, Dr. Mukul Rastogi, and Dr. Naveen Ganju. So can you please take the seats on the right side of the dais. Dr. Voda on the left, please. And for the first talk, I invite Professor to give a talk on liver transplantation, late referrals and lost opportunities, the strain on patients and transplant teams. Professor Rela, please.
Thank you. Thank you for inviting me to give a talk. First thing to say is I'm not a hepatologist. And I thought long and hard about this. I didn't know how to present it. And I apologize to the hepatologists if this is too basic for you, because I put my thought process at a very basic level. A lot of the times, I think I don't know what we are looking to, or who we are looking to blame here. Who are the referrers for transplantation? Are we talking about the gastroenterologists who keep people under their care for too long, tapping their ascites, giving albumin, and not knowing when to refer? Or are we referring to hepatologists not working in transplant centers for holding on to patients? But I personally think that giving the right time. I think when the indications are clear, we'll talk about it. Where the indications are very clear for transplantation, everybody would refer for transplant. There is no issue with it. The borderlines are the problem. The early cirrhosis and when they transform to when they require a transplant is really the problem for timing. And that is what I'm going to really, that is what I thought as a process. And for that, I probably want to tell you a story as well. I think this was probably 1998, or I've been a consultant maybe for 3-4 years, and Samir Shah always, when I came to India, would have a meeting in Bombay. We were pretty close because he wanted to start a transplant program. And he'd always line up 3 or 4 very wealthy patients who would want to come to London for transplant. We were able to transplant patients in London in the early days in Cromwell Hospital. Samir Shah also worked in Cromwell Hospital at that time. I'm talking about before the MEL score, actually. So I saw a very young, not very young, maybe a man in his 40s and a young wife who had, which those days I thought had some ascites and decompensated liver disease. Samir Shah felt that he needs a transplant, and they asked me how quickly should I come to the UK, and I said, I think you'll be all right for 6 months or so. And they came, actually he was getting sicker, and they came to the UK in about 3 months' time. He was much sicker than I saw. He arrived in Cromwell, decompensated, and died in 3 days. And I thought I had got completely wrong my assessment that this guy was going to be okay for at least a year to wait for a cadaver organ. And I have to say that the wife was very distraught. She was very young but very trusting in me. There were only 2 funerals that I attended in my life for the patients I've treated. One was that, because they were alone there. And the other was a young man that I operated for a HCC, who really clung to me, and he came back repeatedly with lymph node recurrences, and I had operated for 4 or 5 times on him. Those were the only 2 funerals. So when I was talking recently, I think we had a meeting in Chennai we were talking about MEL score, and Patrick Kamath told me, I said, what made you interest in MEL score? And he told me a very similar story about MEL score. So he had a patient who was going for TIPS procedure, and the wife asked, what are the risks for TIPS? And he said that, it shouldn't be too much of a problem for the patient to have TIPS. The patient had TIPS and decompensated and died. He said that really affected him a lot. And then he went into looking at the MEL score and liver function test to assess mortality of TIPS. And then now we have got the MEL score being used for transplantation. So this is really the background that that I went through my mind and I want to talk to you about. So really, you need to have at least 70% damage. We know that when we do a 70% hepatectomy, they don't have normal liver function tests. So 70% is probably a good amount of damage to cause really liver dysfunction. And it reminds me of the portal hypertension, even the small foci syndrome. The earlier phases are obviously the portal hypertensive phase, where you have varices and you have bleeds and maybe you have large shunts and chronic encephalopathy. I still don't know when to offer transplantation for these patients with very mild chronic encephalopathy. Mainly it is done, I think, for really quality of life issues rather than the risk of death. And then you have the later stages of systemic effect and very clearly requires decompensation. And you look at this, everybody knows this. You have a decompensated cirrhosis, your 1-year mortality, and I mean, this is 120 months, this is 10-year mortality. I'm still surprised that you've got the survival curve not touching 0. at 10 years for the decompensated cirrhosis. So we are talking about 1-year mortalities of more than 50%. So actually, I wouldn't even want to argue about when to transplant for decompensated cirrhosis. My worries all have been the compensated cirrhosis, the example that I gave you, where I felt that they are compensated cirrhosis and I get it wrong. I still get it wrong because there have been instances when I've told confidently to patients, you're going to be okay for another 4 years, 5 years, don't worry. And then a year later, they come with decompensation and they said to me, you said last time that I'm going to be okay for 4 or 5 years, now you're saying you need a transplant. So maybe all the hepatologists would know more clearly as to when, and I have been supported by many good hepatologists, and I've listened to what they say and do, and if you're a surgeon who just listens to what they say and do, that's fine. That Mesh is there. When I was working with him, I probably won't even argue with him. He says transplant, I will transplant. I worked with Professor Roger Williams. When he says transplant, I would transplant. There is no argument. I actually once opened up a patient and found he didn't even look very cirrhotic, and I asked Roger Williams to come into theatre and said, what do you want me to do? And he said, transplant. And I transplanted, once we have opened up. So now you've got the stable and the unstable decompensated here. So we earlier on saw compensated, so you don't need to worry. Compensated is still a problem for me. And then you've got the decompensated, and you've got now 2 varieties of stable decompensated and unstable decompensated, and which is defined as really no readmission after the first decompensation for 90 days, with a 1-year mortality of 9.5%. Obviously, you wouldn't offer transplantation because the mortality is equivalent to that of transplantation. So now you really come down to the unstable decompensated cirrhosis, where you would offer transplantation because the survival is better with transplantation. We won't go into ACLF. I'm not going to talk about ACLF. And this is the questions that you would ask these patients: recurrent variceal hemorrhage, refractory ascites, hyponatremia. We can look at each one of these so that we'll be able to tell patients what their risks of mortality are, because it is very important to tell them. And once you have this, the mortality touches 60 to 80% at 1 year. Now, this is important because now we are coming to compensated to decompensated, and when this is going to happen. Really, the transition from a compensated to decompensated stage occurs, according to this, at 5 to 7% per year. So you're talking about a compensated patient with a survival of almost 12 years compared to decompensated of 2 years. But when they move from compensated to decompensated, it really is an issue. Now, if you're somebody like in ILBS, where everyone will get an HVPG done, that is one good way of understanding which direction the patients are going. How many of you would routinely do HVPG on your patients who have got no symptoms? Can you put your hand up? 1 out of the whole crowd. So really, physically, this is not possible. So if you've got somebody with cirrhosis who got HPPG of 6 to 10, no symptoms, or 10, no symptoms, it's not an issue. But how do we know that these are the patients with low HVPG? As I said, the further decompensation is never a problem for me. Starting from encephalopathy on the 3rd row, jaundice, recurrent variceal hemorrhage, refractory, all these are, let's not even talk about it, because they are all indications for transplant. If a doctor is not referring, they're never going to refer, because they have no intention of referring those patients to you. You can't change them. But at least we know that those patients need transplant. I'm interested only in these patients who got very few symptoms. So that's why clinically, HVPG may be one way of finding out if they are progressing. But the simplest way of finding out is only 2 things that you all do clinically, maybe not even thinking about it, is an ultrasound scan and an endoscopy. Those are the only things that you need to really look at to find out when they are progressing from the compensated to decompensated. So now look at these three stages. Stage 1, which is no ascites, no varices. To know that there is no ascites and to know that there are no varices, you only need an endoscopy and an ultrasound. A cirrhotic patient with an endoscopy and ultrasound, both are negative, no symptoms, mortality risk is 1% per year. You're never going to refer them for transplantation. I mean, obviously, every year about 11% will exit, 7 with varices and 4.1 with ascites. So they keep on progressing. Stage 2, again, you only need an ultrasound and an endoscopy. No bleed, but minor ascites. Not clinical ascites. You've got small amount of ascites. Mortality risk is still only 3.4%. You're not going to offer transplantation. Stage 3 is when really you're going to think about it. So of all the things, the worst is really when you're managing patients with chronic liver disease, the worst is only ascites at the beginning. Everything else comes later, really. Then your mortality risk goes up to 20%. So let's look at the corner there. Stage 1, no varices, no ascites, 1%. Varices, no ascites, 3.4%. Ascites plus varices, no bleed here. Still remember, there is no bleed, it's 20%. And once bleed sets in with ascites, it's 50%, greater than 57%. So clearly there comes an indication for transplant. But this paper, it's the same authors, they don't address bleeding alone actually, because I've always been taught bleeding alone is not an indication for liver transplant, because these days with good EVL, with good synthetic function, you're never going to offer transplantation for EVL. So you need to know about that, and just look at the first 3 lines of this table, then you will know. Compensated cirrhosis without varices, 5-year mortality of 1.5%. 5-year mortality. Compensated cirrhosis with varices, 5-year mortality of 10%. You don't need a transplant. Bleeding without any other complication of cirrhosis, 5-year mortality of 20%. Still doesn't need a transplant. So bleeding is not the worst of them all. Ascites is worse than bleeding. Now we look at combinations really. So once you have bleeding, we just said bleeding alone, which can be controlled, is not an indication for transplant. But once you combine bleeding with encephalopathy, when they are admitted after a bleed with encephalopathy, the mortality increases dramatically. So suggestion of encephalopathy along with bleeding becomes automatically an indication for transplant. And I think these are for the purposes of explaining to your patient. Refractory ascites, 50% chance of being alive at 6 months. Recurrent tapping with refractory ascites. SBP, again, mortality 68% at 1 month. I mean 30% chance of being alive at 6 months. It's very clear. We saw all of these. These are, I'm just putting it up just to reinforce what I've said. Hyponatremia with ascites, 25% probability of being alive at 1 year. Any infection, chest infection, urinary tract infection, in patients with decompensated cirrhosis, there is a 4-fold increase in mortality. Acute renal injury, acute kidney injury, 8-fold increase in mortality. These are not debatable at all, actually. These are all very clear indications, and this is exactly saying the same. And encephalopathy is the same, other than my worry is the low-grade chronic encephalopathy. I wouldn't know when to offer transplantation. So your 3-year survival rate is, I don't know what's happening. Sorry, your time is up. I'm sorry. I'm coming to the end because I'm not going to talk too much. Sarcopenia is something that you have to add on. So now, with all of this, I think this is the intellectual hepatologists who look into the combination of symptoms and tell you when they need a transplant, and Patrick Kamath simplified it by just bringing in a MEL score, really. And I think most people now follow MEL score. And there is the MEL score to be relevant, it has to be above 15 for it to be beneficial for transplantation. And obviously, there are huge advantages to MEL score. You don't even have to ask all of these questions. It's been validated across different regions. It reduced waiting list mortality. It has even reduced listing patients for mortality. And obviously, there are many exception points for MELD. We saw all of those. Refractory ascites is an exception, chronic encephalopathy is an exception. Considering that, there are also problems with MELD that the serum creatinine may not be due to acute kidney injury, and cholestatic liver diseases with high MELD. And I would even put acute alcoholic liver disease, acute alcoholic hepatitis in the same example, where you will not use MELD as an indication for transplantation. So it does have disadvantages. So that's my final slide, really. This is what they asked me to talk about. I'll just put one slide to say, I think we all need to understand when to do transplants. And everybody knows when there is a decompensated liver disease, they are very straightforward indications for transplant. Where we make mistake is really the borderline cases, where we feel that the patients may do well, and even the gastroenterologists may have many patients they are following for years, and they think that it isn't the appropriate time, and suddenly they decompensate, and then you refer. And when these patients are referred to you, when a gastroenterologist has been managing for years, we should not think that they made a mistake, because I think even we make such mistakes. They only refer to you when they have actually decompensated. They've been looking after them for a long time. So when patients are referred late, this is the problem. So delayed referral, this is just defined as early referral is actually proper referral when they fulfill guidelines, compared to delayed referrals. Delayed referrals, less number of patients got transplanted because it's the DDLT setting, and patients with delayed referral had a 2.5 times more death compared to early referral or appropriate referral. So those are the consequences and the cost for patients, and we all know that sicker patients will stay in ICU for a long time and will be very expensive for the patient with increased mortality. And I finish with that. Thank you very much.
Thank you, Professor Rela. We will have you back on stage for the questions later. If you could, we'll have you back later. And now we have a case discussion on decompensated cirrhosis under evaluation for liver transplantation. The moderator for this case is Dr. Prashant Hangi, and Nikita will be helping him with the case in presentation. The panelists for this case presentation are Dr. Neeraj Agarwal, Amit Mandor, Saurabh Mishra, and Amrish Sani. Can you please come up on the stage?
Yeah, till we finish the case. So good afternoon, and we have experts, we have panelists, of course the moderators, and we have the audience. Why I say that is because I think there was a request. Professor Chawla said, we always speak about the successes. We always see what we did great, what we did and how we reached the transplant and we had a successful outcome. Getting there is not very simple, and even when you get there, things get further complicated. So Professor Rela spoke about the early patient whom you want to take to a transplant. We are going to deal here with two cases which were a little complicated and what happened to them towards transplant. So these are pre-transplant challenges, patients who have come to you for transplant and there is a problem. So I'll leave it to Nikita to start off with the case.
Yeah, afternoon all. The first case would be discussing is a 47-year-old male, O positive with a BMI of 27.5, a known diabetic, not a hypertensive, non-smoker with an LDL of 60 and a triglyceride level of 42. He was a known case of ALD with the CTP MELD of 10/13, and on LT evaluation, his 2D echo had an ejection fraction of 55% with mild MR and TR and a PSP of 28. So,
before going to this, I wanted to ask the experts. Now, let's look at this case. I think other than a type 2 DM, this patient really has no cardiac comorbidity. If you look at it, you did an echo, you found a 55% ejection fraction. There was a mild MR, TR, PASP 28. Dr. Saurabh, do you think that there is any problem in this patient that you want to evaluate further? Or if I can specify more, do you have any further cardiac evaluation that you would like to do in this patient?
Sir, based on this, patient has a higher BMI. He is diabetic and alcoholic also.
So, our stress echo may be beneficial in this patient to assess, to risk stratify basically before a transplant.
So stress echo negative, DSE negative.
So, I think that should do, or further if there is a risk factor, then CT coronary calcium scoring can be done.
Okay, but you would not do it straight away. You would do a DSE. If it is negative, you would go ahead. Amit, any change from your side?
So DSE has a lot of limitations in an end-stage liver disease patient because of the hyperdynamic circulation. So the meta-analysis is very clear that the sensitivity of DSE to pick up cardiac probability post-transplant is only 32%. So DSE not routinely, first a 2D echo. If you are considering a patient for a liver transplant, then maybe a CT calcium score followed by SOS CT coronary angio because he is diabetic and obese.
Okay, so I'll just move forward. So this is our cardiac evaluation protocol, and I think we've published this before. And if you look at the risk factors there, for us diabetes is a significant risk factor when we take these patients for transplant. And again, as rightly mentioned, there's alcohol to add to it, and he's a slightly overweight individual, though I may not call him obese. So we did follow this particular path, and we did do a calcium score, and then because he was diabetic more than 50, we did a coronary angio. So findings.
So he had a calcium score of 483 and a CT CAG followed by a CAG showed a triple vessel disease with the 80% stenosis in the LAD and 90% stenosis of the left circumflex, with the dominant RCA having 90% stenosis.
So next question, maybe I can ask Dr. Neeraj. What next? Do you think that this patient can be taken up straight away for a transplant?
Definitely. I need to send this patient to a cardiologist, and where we should think about PCI, coronary intervention for revascularization. As the patient is child-age cirrhotic, I believe that we do have some time to. We should do PCI first before transplant.
So triple vessel disease, cardiologist, intervention cardiologist says difficult. I'm not sure. There's all three diseases involved, all three vessels involved. The other thing is, and maybe I can put this to Dr. Amrish. This patient was sick. He needed an early transplant. Putting in a PTCA would probably mean 4 to 6 weeks of anticoagulation with dual antiplatelets, waiting for 4 to 6 weeks, and then doing the transplant. Any change in your thoughts other than a primary PTCA followed by transplant after 4 to 6 weeks?
If the cardiologist is not agreeing or patient can't wait till then, obviously we will take one opinion from CTVA surgeon also, though it will be a very massive input, but
so you mean
effort should be made.
CABG before a liver transplant, right? Okay. I'm just going to go, let's keep this time, the total time. I will keep it to within the time limit, don't worry. Dr. Piyush, any change in your, no, Piyush is not here. I think Dr. Mukul.
Yeah.
Dr. Mukul, any change in your thought process? What do you do in this patient?
Clinically, this is child C patient, bad status, and there is TVD. So, if you do one thing first, then you create a mishap to the second one. So if you plan for CABG, then definitely there is decompensation further of the liver disease, patient may succumb. If you plan for liver transplant first, then heart cardiac decompensation may be there. So I think in such cases we should plan both the procedures simultaneously, first CABG and followed by transplant.
Okay, before I comment on that or we see what we have done or what we published, I'm going to put this to the audience. Get your voting meters ready, and I have put 4 options here. PTCA, wait for 4 to 6 weeks followed by LDLT. Combination of CABG and LDLT, same sitting. Any other option, I would say any other option you mark as C. And the 4th is there are many who believe, and I'm telling you there are people who believe in the UK and the US that this does not really matter. If you were not to do the CACS, if you were not to do the evaluation with CTCAG and you found that everything was okay, maybe upfront transplant straight away, and then let's see what happens. So let's vote first. Let's see A, B, C or D? Can we have the voting on? Do we have the voting on? No. Okay. Just let's raise hands. PTCA followed by LDLT. Okay, so I think about 20%. CABG plus LDLT combined single procedure. Wow, I'm amazed. Let's see then how many have done it. Third, any other option, or I'll go to the last one, upfront LT. Anyone would think of upfront LT here? Okay, so we still have about 5 people who are going to think of that. Okay, so I just want to show you that there are large studies that we have published in this. This is the pre-transplant coronary intervention, where we have now somewhere around 80 patients who've had a PTCA followed by a transplant. And very recently we published this combined living donor liver transplant with CABG grafting. This is published in JCEH just last month. This was 8 cases of CABG with LDLT. I can tell you that in this particular series, we had 2 post-operative deaths. Both of them were not related to a cardiac event, and whatever cardiac arrhythmias happened in the post-operative period, they were controlled. But these patients, we had 2 post-operative deaths. Long-term outcomes were good in these patients. PTCA, good outcomes in the long term when you are able to wait for 4 to 6 weeks and transplant them as a routine. So again, there is a lot of people who said that we would do a CABG plus LDLT combined. How many have in their centers actually done more than one CABG plus LDLT? So I see one hand, and then our center has done 8. So this is a procedure which is associated with about 20 to 30%, maybe 20% of mortality, if we could put it that way, and that's much higher than a single procedure, either an LDLT alone, which will be associated with 5%. And as rightly pointed out by Dr. Mukul, I think doing any one procedure always gives you a difficulty whether you'll actually be able to do the second procedure or not. Now this is what we did for this patient. So he had an so our cardiologist, we discussed it with both the cardiothoracic surgeon, we discussed it with the cardiologist, with our intervention cardiologist, and they said we could do this intravascular ultrasound with a drug-eluting balloon. So this is just a balloon angioplasty without putting in a stent to the RCA and to the left circumflex. So this was done, then he was discharged on a dual antiplatelet, and the plan was that we'll do a transplant after 4 weeks. Now in between, unfortunately, this patient had a fracture of the humerus and fracture of olecranon, and then we had to wait for another 2 months for this. When we were going to take him for a liver transplant, this was his echo with a mild MRTR with a PASP of 31, and he did have a transplant in February. The post-operative course was not simple. This patient post-operatively went on an IABP. He required an intra-aortic balloon pump because he had, he went into hypotension. There were problems he could not really sustain. So it was not easy, the post-operative course as well. So the reason for putting this particular case, I think a few learnings. One is, even if you have one risk factor, and this was only diabetes in this patient, there may be a lot of things that you may be missing in terms of the heart. So I think a detailed cardiac evaluation sometimes is warranted in these patients, and you find much more. Number 2 is that even if you have the experience with PTCAs, with combined CABG, LDLT, you always fear that combined procedure, and you think that, can I do a lesser procedure and then take him for a single transplant alone? So that is a thought that comes to mind. Number 3 is that it's not always even that the post-operative course or the immediate follow-up in these patients is very straightforward and simple. So this was the reason why probably we put this case up. Any comments? Yes, Dr. Naveen?
So, Dr. Prashant, they're nicely done, but most importantly, if your stress tests are okay. I know not everybody does an angiogram because only one risk factor, age, is not really bad. So if you go ahead with this transplant, many times, most of the times, maybe you'll get away with such things because you've done 2 stress tests. You can do a stress thallium, you do dopamine stress echo. Okay, sensitivity might be low, but most of the times, I don't think many people still do an angiogram.
Yeah, that's why I raised that upfront transplant, because there are people who still believe in that. Sarela?
Mic working? Yeah. Now, one of the problems, I personally think a combined operation is a major undertaking. We've done it in King's, I've done it here. The cardiac surgeons are not used to operating on patients who are severely coagulopathic. Their anastomosis starts bleeding a lot. That's been our experience. So the outcome of the combined procedure, even in your expert hands, you're saying carries a 25 to 30% mortality. Let's look at the other option. The triple vessel disease, you say there is a triple vessel disease. All cardiologists and the cardiac surgeons want a perfect outcome to whatever they do, because what is acceptable for them is only a 2% mortality. So they will do a perfect operation. But for you, you don't want a perfect revascularization. You tell them 90% stenosis of LAD, you sort that out, and the risk of mortality for liver transplant will completely come down. So what is actually a surgical patient becomes a single vessel treated interventional cardiology patient, because that one vessel which has been revascularized would be enough for you to sort out. So you don't need to resort to surgery just because they're saying that's the best thing. You tell them, you vascularize the LAD for me, what is the risk of death from coronary event in the perioperative period? They'll say it's negligible. So that's something that we need to actually sit down and argue with cardiologists.
Sure.
The second thing, this thing waiting for 4 to 6 weeks is to reduce the risk of thrombosis. And you ask the cardiologist, if I did only 2 weeks, what is the risk of thrombosis? Nobody has an answer.
So they say it's higher. They say it's twice.
Yeah, twice is 2% to 4%. Your risk of mortality without transplantation is 80%. So you want to delay an operation with an 80% mortality because the cardiologist doesn't want to increase his risk from 2% to 4%, and that is absurd. That's because we are not arguing with them as to what is best for the patient, because no cardiac surgeon wants a mortality of more than 2%, and no cardiologist wants a stent occlusion of more than 2%. So I think this requires a lot of discussion to think what is best for the patient. For a cardiologist, it's okay to die of liver disease, sure, but not okay to die following a cardiac intervention.
Sure. So, having said that, we in each of these patients, and always there has been a multidisciplinary team meeting. Dr. Vora is here. He is, of course, our chairman of anesthesia. Sir, you want to make a comment on this?
So, really, we do have a multidisciplinary meeting, and our criteria have changed over the period. You just don't look at the stenosis. Like he mentioned, do another stress test. Yes, sometimes we are, try and give them another stress helium. We look at that. If under the stress, if it is more than 10% decrease, and then you say, look, yeah, this stress is this okay. Again, another thing what they have started doing is FFR. You discover the stenosis, but you see the fractional flow reserve. You go, put a catheter, see the flow here, proximity, and see beyond. So, ideally it should be 1, it should be the same, but if it is less than 80, then they go ahead. So again, you really don't go in looking at the coronary angio, 80%, 90%. Typically, anything more than 70%, they say it needs intervention. But having said that, for these guys, we really go a little beyond, try not to do intervention, but if FFR is low, probably you really need to do some intervention, be it PTCA, or if that is, sometimes they say the vessel is not amenable to, putting a stent, angulation or whatever. Then those are the patients you really end up with the combined procedure.
Prashant, in your previous case, the 2D echo values actually deteriorated after the procedure. Your last case, 2D echo values are poorer than the previous one.
So,
that is one. And two, what is your final word? Upfront transplant or still doing the dual procedure?
No, we would still do a dual procedure. The risk of this patient with triple vessel disease, with everything, I don't think the values deteriorated. The values were in the before transplant. Yeah, almost the same, but that's not the point here. The point here is the possibility of developing a major cardiac event, developing a MACE after the transplant. So that's the reason why it was done. I don't think there was a problem with the left ventricular fraction or the LVEF in this patient. There was never a problem. The problem was with the vessel itself and the high chances of thrombosis post-op or a MACE post-op.
You will still do a dual procedure instead of upfront.
No, we would do a PTCA. As I said, we have done 10 combined CABG and LDLT. Here they said that it was amenable for a 2-vessel balloon angioplasty and we could go ahead without putting a stent. We'll go to the second case quickly.
So the second case is a 36-year-old male from Jammu and Kashmir who is again a case of ALD-CLD with history of alcoholic hepatitis, ascites, alcohol withdrawal syndrome and portal hypertension. And his index presentation was in 2019 with alcoholic hepatitis with a bilirubin of 19 and an INR of 1.87. Subsequently, he's had 2 to 3 admissions with recidivism and alcohol withdrawal syndrome. And this current admission, he presented with complaints of progressively increasing jaundice, abdominal distension, altered sensorium, and reduced urine output. So he's admitted in the ICU in view of shock and septic shock and altered sensorium. So his TLC on presentation was 28,000 with an INR of 3.64 with a creat of 4.1 and bili of 31.6. And his viral markers were negative. Ammonia was 286. CT brain showed no evidence of evidence of cerebral edema, and an upper GI endoscopy done showed small esophageal varices.
So I think this is again not the ALF patient that we discussed in the debate. But look at this patient. This is your typical patient. This is about 35% of patients that we get today in Medanta for transplant. So high TLC has come with a creat of 4.1, has got an above 30 bilirubin. That cerebral edema was mild, means the comment was there, but really looking at it was more of an ACLF. It was not nowhere like an ALF picture. You have an ammonia there which is 286, which is also very high. And you have a decompensated patient. So, can I ask maybe Amit, what is your evaluation strategy in this patient? What are the key points, 1, 2, 3 that you would like to look at?
I think key points would be first is to rule out infection. That would be paramount in such patients. Send cultures, blood culture, urine culture, also do an ascitic tapping. Look for any focus of infection, get a good chest imaging done. The other thing would be to look at the creatinine is 4.1, so urine routine. The patient is also having very high bilirubin, so whether there are any whether any casts or anything, or it is standard. So, and the third would be the volume assessment.
Yeah.
The volume assessment would be important so as to treat the patient as AKI HRS, or are we dealing with an ATN. So these are 3 things which upfront on day 1 we would like to do and start management accordingly.
Dr. Amrish, you want to add anything other than these 3 points?
Sir, I think I will like to see for treatable causes, and Dr. Amit has mentioned beautifully.
Dr. Naveen?
And broad spectrum antibiotics should be added.
Sure. Dr. Naveen, anything additional? So key points, I think infection screening, hemodynamics, volume assessment, very important. And obviously, we will have to look for some sources of bleeding, if at all, with all this, there is some occult bleeding, and he's, having some degree of, he's having 31 bilirubin. So we did an ascitic tap. So this guy has SBP. In addition, upper GI endoscopy just showed mild PSG, lactate of 6.9. So if you look at the complete diagnosis, he's an ACLF. He's got severe alcohol-associated hepatitis, steroid non-responder. He had received steroids somewhere else. And obviously, he's got ALD-related cirrhosis. Now, let's look at the points, what we are dealing with. He's got 4 organ failures: liver, coagulation, circulation, renal. He's got SBP. He's got grade 2 HE. And these are his numbers. His CTP 13C, 40 MELD, grade 3 ACLF, ARC score of 14, Cliff ACLF of 102. So broad treatment plan, Dr. Saurabh, we've spoken about broad spectrum antibiotics. We've done the volume assessment. Anything else here at this stage, in addition to antibiotics?
Sir, in addition to antibiotic, if the patient is volume status, if it is normal filled or lower filled, then we need to start IV albumin or fluid resuscitation in this patient. And if the we have to monitor urine output also, whether the patient is satisfying conventional criteria for renal replacement therapy, then we might have to start the patient on that.
So Dr. Neeraj, before I go to the option of transplant in this patient, when you see these patients with creatinine of 4.1 with such a bad liver failure, 30 above 30 bilirubin, do you even consider that these patients immediately can be considered for a liver transplant alone, or you think otherwise? I think your mic is off. Yeah.
We should be evaluating whether he's responding to vasoconstrictors or not. If he's responding to the vasoconstrictor, the MAP is optimizing and all, then we can do a single liver alone transplantation. However, if the creatinine is not improving even after all this vasoconstrictor and CRRT, then we should also be thinking about
So
SLT.
would you do CRRT in a patient who's got a creatinine of 4.1 and he's non-oliguric?
So definitely we will first try with the vasoconstrictors, but like in this patient, time of the essence and stabilization of renal function will be important consideration before.
Dr. Narendra, you want to add to this? I'm coming to the surgeon, Karthik.
So if no psychiatric contraindication, early transplantation should be done once infection improves, because it is very high MELD. There is a history of relapse earlier. So if there is history of frequent relapse, then no. Otherwise, early transplantation should be done.
How long will you wait for SBP to resolve, Dr. Karthik? What is your threshold for waiting in terms of time or in terms of investigations?
See, in this case, at least we need at least a couple of weeks to make sure SBP has settled. And like Narendra said, we would also want to know about is how many times he has relapsed, how many times de-addiction failure has happened, and I'm sure he would have been a very sarcopenic patient.
No, he was okay. Not very sarcopenic, no.
Yeah, so that will, and second, CRRT, somebody said why? Because the lactates are also 6.8 something, right?
Yes,
so I don't want the
6.9
lactate to go up again, because we are staring at a failing liver because of underlying SBP. So I would definitely initiate a CRRT to make sure the lactate is coming down or less than, or a single digit.
Dr. Mukul, do you think he'll survive for 2 weeks?
I think he is not in the right window of doing transplant, upfront transplant. We have to optimize him before that, because with the creatinine of 4 and patient is having sepsis, SBP. So we should treat by multiple methods. First, vasoconstrictor along with CRRT is very important in this patient, and antibiotics with the background of carbapenem resistant variety of infections. We have to cover that also. And whenever we find an optimum window, if there is improving creatinine or sepsis is improving over a period of 4 or 5 days, I think we should go for transplant in such patients.
So I think for SBP, if you have a sensitive antibiotic and your response tap is okay in 48, 72 hours, I think you can go ahead with a transplant because the window is very small. Objectively, if it's a sensitive bug and if you have a response tab which is respond to antibiotics, I think that's the window.
Yeah, I think that's something that
50% fall in the initial count to.
Yeah, so I think there is a change in that thought process as well, that if you have good broad spectrum antibiotics, organism which is not very pan resistant, SBP, usually 5 days, or a repeat tap which shows you after 3 days that there is a further decrease. So broad spectrum antibiotics, meropenem, he did not tolerate terlipressin, so we put him on norepinephrine. Terlipressin, I think, was started subsequently. It was okay later on as the NORAD requirement was low. He had some low BP as well. So renal worsening, do you all agree that this patient would benefit from a CRRT at this stage? What about SLED? What about therapeutic plasma exchange? Dr. Amrish, you want to tell us about SLED?
I will definitely go for CRRT in this patient.
Why?
And because patient is not hemodynamically stable. In SLED, there is an issue with this patient is already having a mild edema, cerebral edema and encephalopathy, and of course hemodynamics are not stable. If we are doing SLED, there will be a time period of rebound in rise in ammonia, and during SLED also hemodynamics can go worsen. So in my opinion, CRRT will be a better choice for.
Dr. Amit, plasma exchange?
Absolutely no plasma exchange. I think if there is worsening renal function, if the hemodynamics are okay, then any conventional form of hemodialysis, otherwise a CRRT. No role of therapeutic plasma exchange for this patient.
So I'll just go to the next one. So CRRT was done. This is day 2 of CRRT. On day 2 it was started, and you look at the trend there, the TLC continues to be at around 25,000, INR is 2.5, creatinine is 3.6, it's gone up further. He is producing urine, but borderline. Bilirubin has gone up to 47 now, with the AST, ALT which are on the higher side. He's on terlipressin, not on any other inotropes. All cultures as of now are sterile.
Prashant, here we should also look for other causes of renal failure, especially with such high bilirubin. We should rule out cast nephropathy, we should rule out an AT and not just think of an HRS kind of a phenotype.
Hemolysis also to be ruled.
Hemolysis, yes. That's the other thing that probably we need to look. What next? I'm not going to go for want of time to discuss, because these are things that have been discussed way in and out. I'm not sure any of these things except for that last one actually helps. Unfortunately, this is what happened in this patient. So what we had to do, he didn't have a ready donor, and obviously at that point of time he was not fit of plasma. Patient remained clinically stable, encephalopathy and shock improved. He became non-oliguric, and that remained persistent. There was CRRT first, little amount of urine, and then non-oliguric, and initially that was persistent. This happened up to day 12, and you will see here with the plasmapheresis, these are the sessions of plasmapheresis that were done. This is what it was. So there were 3 sessions of plasmapheresis, and day 14, there it comes. He started having fever, E. coli, and then CLEB and multi-drug resistance. So I think, again, the reason for putting this is real life scenario. This is what we try to do, try to get these patients up there. We try our best, but sometimes we are not able to get them to that particular stage, and this is an oft debated issue as to what we should do in these patients and whether we can actually get them to a transplant. And we all know this diagram. I think, again, we want to insist or maybe stress on the fact that in ACLF, they all benefit from early transplant. Sometimes it tilts over where they become too sick for transplant, and therefore, maybe you can use as a bridge therapy, but ultimately transplant is what is going to save them. So, any comments from anyone or any questions from the audience, I think, and then we can go to the next set of questions. Professor Rela is also going to be here for the questions, I guess.
The house is open for discussion, and we would like to have Professor Rela at the stage.
So regarding delay in sending patients to a transplant unit, ACLF is classical example. Generally, we get patients at kidney failure stage, and sometimes we are not able to improve from that stage. In decompensated cirrhosis, it is common to see patients first time when we can count ribs by unbuttoning shirt, severe sarcopenia, and most of delays happen at physician level. I believe not at gastroenterology level. It happens in small cities. These patients are managed by MD medicine. And it is financial incentive, lack of awareness that we get patients late. And sometimes patients are referred by another patient, not by physician.
So how relevant is your TLC in absence of other known sepsis in ACLF? Is not
I think one
General
point we have to
ACLFs.
understand in ACLF, we always speak of that golden window period. But that golden window period is a first week. But by the time a patient reaches, it has to be from the day of when the illness has started. By the time the patient comes to the hospital, he may have already been beyond that golden period and maybe in immune paresis phase where the infections becomes MDR. So many a times when we speak of bridging therapies in that golden window, by the time the patient reaches the tertiary care hospital, I think that period has already gone.
Totally agree, because they'll be on high dose antibiotics and already carbapenems and all that. But one important thing is, as we are talking about the bridge, many people would do the bridge if it does not work and then start working on transplantation. So the idea is to start working on transplantation. If it is taking time, you do the bridge therapy, because you lose so much time on once you start thinking about transplant. Once you failed, after 5-7 days. So that's one thing that we should think about.
Also, we should be thinking
My
what
question
is the
to Dr. Rela, Professor Rela.
I think he's just stepped out probably.
Okay.
Yeah. Neeraj.
Also, we should be checking the utility of plasmapheresis late in the ACLF, because as it removes the toxins and bilirubin and other thing, it also removes the beneficiary factors and good immune molecules as well, and that paradoxically increases the risk of infections.
I think we have been saying that since morning, that the role is very query as far as ACLF is concerned. Dr. Bora, Dr. Joshi, any?
Now, I just had a query. I just want to ask people present here. Does anybody, this is about the other patient, not this one, about the cardiac one. Do we still use bare metal stents? I mean, bare metal stents, the advantage is you give 4 weeks and you are ready to discontinue your dual antiplatelets and then get on. Is anybody still using dual platelets to get your patients ready for transplant? He had a coronary artery disease, stents is required. Do we use it? Bare metal? No. No?
I asked my cardiologist, but they are not using it.
I think
nowadays they are only doing balloon. They are not putting, if the patient is for transplant, they are just doing balloon. Only while ballooning, if there is any dissection, they put a stent. That's
So that's important to point out whenever you talk about ballooning, if they have very significant CAD, very significant blockage, during the ballooning, if they were to rupture that plaque and that plaque disrupts, they can land in a mess. So you need to have an expert intervention cardiologist who is doing that, and you also need to be prepared that they may have to put in the stent. So you will have to be prepared that you will have to wait that period with anticoagulation for a period of time. So that's one of the things about the ballooning.
Is that what type of stent they put also is very important. Like the everolimus stent and all that, they say 1 month only you have to wait.
But we don't
so
find
4 weeks is
we don't
something
find
that-
such daring cardiologist, because sometimes the length of the plaque itself, it
Is
matters.
long.
So
Yeah.
a lot of time, why we're not able to do a stent is because the length of the calcified plaque is very important. But usually, whenever there is a triple vessel disease with long-standing diabetes, hypertension, you never get a small segment of calcification. That's when we are forced to do bypass
True.
along with the transplant.
True. I think last question.
Coming to basic question, this patient is alcoholic, came in withdrawal, ACLF, 4 organ failures. If you're talking about LDLT, we are risking donor, financial implications are there. Would we even be giving choice of transplantation to the family and give them also?
So, our typical attitude in these patients is, if you have an ACLF4 who over a period of time, over their initial treatment of 7 to 10 days, have come down from ACLF4 to ACLF2, we should transplant him. If a patient who has gone from ACLF2 to ACLF4 or has remained maybe at ACLF3 or ACLF4 with multiple organ dysfunctions which are really going to compromise your post-transplant outcomes, you would not transplant them. The problem is that if you don't give the option of a transplant right in the beginning, LDLT logistics are such that you are going to require 7 to 10 days for that donor to ultimately get worked up in terms of being ready with a committee, with logistics, with the money, everything. So our approach is that the moment you think that this patient may require a transplant or he may become transplantable, put the thought into the family so that they can think about the donor, they think about the finances, everything, arrange for the same, and if you find a delta where he's actually improving to a stage where you think he's transplantable, we can go ahead with transplant. At ACLF4, probably we would not have.
Short-term and long-term outcome of looking at this scenario.
I think this is published. Naren, you want to tell our short and long term
If
outcome?
no psychiatric contraindications, no history of multiple relapses, outcomes are good. If psychiatric contraindication or we are following patient for several years, he improves, again start taking alcohol, improves, again alcohol, then we don't offer. Otherwise, ACLF patient with short abstinence, good outcome, and harmful relapses almost 10%. 90% of patients, they will not go again for alcohol. Occasional relapse doesn't matter in transplantation.
I think coming to the question of futility, the Easel-Cliff score is very good to determine the futility because it's always very subjective whether he is improving or not. If you calculate the Easel-Cliff score at day 4 of treatment, if the score is more than 64, the outcomes even after transplant are going to be bad. And if it is so, I think there is where the role of Easel-Cliff score is very good, which goes on multiple objective criteria.
But
whether the patient is.
I think we can close the session.
Now, one more thing I want to say, that whatever is the grade, whether it is ACLF 3, ACLF 4, the only thing of worry is uncontrolled sepsis and rising vasopressors. If these two things are not there, I think we should give a chance for
I think the third is pulmonary, because
definitely if it is pneumonia per se, then you have to avoid it. But it is elective ventilation, then you can go ahead.
so if I'm not mistaken, ACLF3, our published data is 79% survival, right? So if you have ACLF3, it doesn't mean that you should, and this is published data. So important thing is the delta, important thing is the worsening, important thing is of course the grade, and I think these three are bad. Inotropes, pulmonary, these two are really bad, and infection, sepsis, kills. So these three, if you can exclude, I think we can still go ahead.
Just a quick comment to make on the case. In your
I think, Neeraj, we will have to end because we are running short of time. We can have
Thank you.
questions,
Thank you.
So, we would like to have all speakers and panelists to come for a photo at the backdrop. And for the next session of keynote lectures, I would like to invite the moderators, Professor Y.K. Chawla sir, Dr. Devendra Singh sir, to take their seats on the left hand of the dais. The chairpersons for the session are Dr. Surinder Singh, Dr. Deepak Lahoti sir, Dr. Rajneesh Monga, Dr. Anil Gangawar, and Sushil Chaudhary to take their seats in the center and on the right side. Would like to call Dr. Mark Muthaiya to deliver his keynote on can cirrhosis be prevented in MASL, GLP-1 receptor antagonist transforming management. Dr. Mark Muthaiya.
Hello. Hi. So I'm Mark. As an introduction, I'm one of the transplant hepatologists from Singapore. Oh. Yeah. And so I'm one of the transplant hepatologists from Singapore. I'm also from the National University of Singapore. So firstly, I'd like to thank the organizers for having me here. And it's really an honor and a privilege to come here and speak on this topic, which I'm quite passionate about. My topic is on can cirrhosis be prevented in MASL, GLP-1 receptor agonist transforming management. So these are my disclosures, and I think of note I will be touching on the off-label use of GLP-1 receptor agonists clearly in this talk, and I do have a research grant from Novo Nordisk, which is the producer of one of the most common GLP-1 receptor agonists. So I think the outline of my talk today I'll cover is on the MASH patient, unique features of MASH cirrhosis with relevance to liver transplantation, GLP-1 receptor agonists in MASL and MASH, and some of the potential pitfalls and other possible agents. So firstly, the MASL-MASH patient. So what is the MASL-MASH patient? So I come from Singapore, which is in Southeast Asia, and we have a really huge prevalence of fatty liver disease or MASL. Our prevalence is 40%, higher than 40%. And in US, this data shows that MASL and MASH is rapidly rising as an indication for liver transplantation. In our center, we come from a similar, like a Asian center. We used to have hepatitis B as our top cause for liver transplants. Now it's MASL, MASH, HCC, or liver failure from fatty liver disease. And Southeast Asia has the highest proportion of liver cancer due to fatty liver disease. So really we're seeing a lot of this disease, and it's affecting quite a lot of our patients. Detection is difficult. I think one of our colleagues talked about the use of abbreviated MRIs earlier. So what exactly is the MASL-MASH patient? And I think we must understand this patient in context. So firstly, there is caloric excess or energy overload that then overwhelms the biochemical pathways in the liver. And when you have overwhelming of the biochemical pathways, you have diversion to toxic lipid species, which then drives inflammation, necroinflammation in the liver, and apoptosis, which then gives rise to liver fibrosis. So this patient has a liver that's that's overwhelmed by chronic energy surplus, we have lipotoxicity, cell death, and inflammation. But one end has fibrosis, which we're all familiar with. It's in a lot of liver injury. But the key condition, which we alluded to in the last few sessions as well, is these patients have multiple metabolic comorbidities. So we're not just dealing with a patient with liver problem, but we have to talk about cardiac issues, atherosclerotic disease. But what are we really concerned about in these patients? We're really concerned about liver-related events, which are what? Overt hepatic encephalopathy, ascites, variceal bleeding, HCC, a MEL score of at least 15, because that's when we would transplant a patient, and liver-related mortality. And who gets these? Patients who have at least, who are at risk of developing these are patients who are at least stage 2 fibrosis of the liver. So how about unique features of MASH cirrhosis? So really when we look at cirrhosis, and I think this was alluded to by Dr. Rela earlier, we see patients who have a trajectory of disease with liver cirrhosis, any liver cirrhosis. And we have the compensated disease, compensated advanced chronic liver disease or compensated cirrhosis. And these patients generally have a HVPG of between 5 to 10. Then we have clinically significant portal hypertension, initially with no gastroesophageal varices, and after that clinically significant portal hypertension with gastroesophageal varices. And finally then, the patients can progress into later stages of decompensation, further decompensation, and death. And really, I think the trigger that was alluded to was a HVPG of more than 10. So looking at NASH patients, this is unpublished data from our work with the Liver Forum, we can divide these cirrhotic patients into stratum A, stratum B, and stratum C. And really the main thing that drives these is actually the HVPG of more than 10, or clinically significant portal hypertension. And these patients are at greater risk of developing the MALOs, or the major adverse liver-related outcomes. So what is the risk of decompensation in MASH patients with cirrhosis? Trying to consolidate all the data, we see that a number of biopsy-proven studies have demonstrated really that these patients, once a patient reaches cirrhosis, and especially once a patient reaches clinically significant portal hypertension, there is an increased rate. So we're going to have a lot of patients with cirrhosis and a fewer proportion, but yet those who have higher proportion of clinically significant portal hypertension. Now, this is something that we published recently from the UNOS data. So looking at the UNOS data, which is the US Liver Transplant Waitlist Registry, what do we see? There is interestingly a greater burden of portal hypertension in patients with fatty liver disease. So what we see is patients with fatty liver disease in light blue, in the graphs in light blue, tend to be listed at lower MEL scores. They tend to have lower MEL scores. Yet they tend to have further higher complications of portal hypertension despite these MEL scores. What do I mean? The MEL score is driven by bilirubin, INR, and creatinine. And bilirubin and INR are not truly markers of portal hypertension. So these patients with fatty liver disease have a higher burden of TIPS, they have a higher burden of portal vein thrombosis and hepatic encephalopathy, which may be driven by shunting. And patients with MASH cirrhosis have an increased risk of portal vein thrombosis. The other thing is that we see that patients with MASH cirrhosis who are waitlisted have a higher renal impairment or higher CKD. Now, whether this is associated with their underlying associated metabolic comorbidities or whether this is a HRS type 2 phenomenon is hard to say. But really, I think what we look at, when we look at it closely, is the deltas. So what you see, and if you can see the graphs C, D, E, and F, and if you can look, graph C looks at the MEL score and the rate of change on a waiting list of a MEL score. And you see what is expected. A patient that's listed on a waiting list will have progressively worsening disease. And this is seen in both NASH and non-MASH patients. However, when we look at the creatinine, the rate of rise of the creatinine outstrips the rate of rise of the bilirubin and the INR in these patients. So what is happening to these patients is the renal dysfunction is what is driving the the MEL score. And these patients are having portal hypertensive events, yet are having low MEL scores until the point where the creatinine goes up. And what happens also is these patients, this data is from Singapore, where we show that patients have worse outcomes. So MASH patients, as compared to Hep B, which is our universal control group for non-MASH patients in Singapore, have worse outcomes after the first onset of ascites. So the other thing that we see is MASH patients have a longer wait time on the wait list, as well as a higher wait list mortality. So if I can summarize the MASH patient as a pre-transplant patient, these are patients who stay around longer on a liver transplant wait list. They have a higher burden of portal hypertension despite lower MEL scores. They have challenging to manage ascites. And of course, they have a sudden acceleration of deterioration once their creatinine rises. And really, these patients also have cardiovascular comorbidities where things like terlipressin become challenging to use. Now I'm going to shift to touch on the incretin hormones. I know my task was to talk on GLP-1s, but I think we have to talk about the incretin hormones, GLP, GIP, and GCKR in continuum. So these drugs have taken the fatty liver disease space and a lot of other metabolic diseases space by storm. So I think the initial study that looked at it, the lean study, the liraglutide data on the right side of the screen, demonstrated a benefit in phase 2 data. But what was very interesting was that looking at the semaglutide study, and this study, phase 2B study by Phil Newsom and colleague that was published, was the first study to demonstrate a benefit in resolution of NASH with no worsening of liver fibrosis. And if you can see, it's about 60% benefit. So everyone started getting very excited. And so we started looking at more GLP-1s. And so when you look at the other FDA endpoint, decrease in one stage of fibrosis with no worsening of MASH. So there are a number of FDA endpoints: resolution of MASH with no worsening of fibrosis, and at least one stage improvement in fibrosis with no worsening of MASH. What we see is, even though this was not statistically significant, there was a dose-dependent effect. So really it pointed to some potential benefit. This was in the phase 2B study for semaglutide. Now, recently, so this data has not been published yet. It was presented at ASLD 2024. I had to modify a photograph I took from the presentation. But really, this is the phase 3 data that has come from semaglutide. And what can be seen, and I'm sure everyone will notice the very, very high placebo response rates. But other than that, what can be seen is that there is a 62% or 63% resolution of steatohepatitis with no worsening of liver fibrosis, and then a 37% improvement in liver fibrosis with no worsening of NASH. But the caveat to this is these were patients with only stage 2 and stage 3 fibrosis and not cirrhotic NASH. Other drugs included survodutide as well as tirzepatide. So these are tirzepatide is a GLP-GIP and survodutide is a GLP-GCKR. And really we're starting to see improvements in the disease, or 62% improvements, 62% on both sides. So really significant improvements. And for those of you who, I'm sure a lot of people remember Hep C, we saw that significant upswing in clearance in Hep C, and we're starting to see it in fatty liver disease. And of course, for improvements in fibrosis, this is really impressive with survodutide at 52% and 51% in tirzepatide. So really, and these, while they're only phase 2 data, they show us where it's going. So how about the potential pitfalls of GLP-1 receptor agonists in MASH cirrhosis? So this data really, I think, poured ice water on all the excitement. Why? Because not only was there no statistically significant benefit in cirrhotic patients in a phase 2B study, there was also numerical harm and a potential. In fact, the placebo group performed better than the intervention arm. So why was this the case? And we suspect, because if we've used GLP-1 receptor agonists, we see a lot of the patients having poor appetite, not taking well. And what do we know about our patients, our cirrhotic patients? They need good nutrition. Sarcopenia is a problem, and we see sarcopenia worsening with progressive disease. And we do see sarcopenia progressing not only with progressive disease, with the presence of MASH, but with MASH cirrhosis, it is even worse. And what do we see with GLP-1 receptor agonists? Yes, there's a loss of fat, but there's also loss of fat-free muscle mass. And this really may be driving the severity of the disease. So I think we need to be cautious before we just use GLP-1 receptor agonists in all patients. And currently, the very encouraging data is for stage 2, stage 3 patients. The other thing, and this comes from US insurance data, this is, patients whose medications are being paid for by a third party are still having high rates of discontinuation. So really, beyond financial issues, these drugs are not very tolerable. And are there other possible agents in MASH cirrhosis? Yes. And what other possible agents are there? So firstly, we have SGLT2 inhibitors. This is a very nice study from Hong Kong, from the Hong Kong University group, Mark Leung's group and colleagues. So basically what they looked at was choice of anti-diabetic agents in diabetics with hepatitis B. Not MASH, but I'm extrapolating from here. And they really showed us a significant reduction in liver cancer with the use of SGLT2 inhibitors. So while everyone's very excited about GLP-1 receptor agonists, we should not forget the potential benefit of SGLT2 inhibitors. Secondly, I think this is the compound that has demonstrated benefit in cirrhotic patients. Again, this data was just released in January, so I had to pull some of the data, but this is FGF21s. So we have efruxifermin, pegozafermin, and basically what do we see? This is in cirrhotic patients, but compensated cirrhosis, not decompensated cirrhosis. We see a 30 to 40% improvement in regression of cirrhosis. And it sounds very nice, and at least one stage improvement in cirrhosis. But let's be clear that these are not decompensated cirrhotics. So really, we have these patients who potentially can benefit, and right now we're running, the trials are ongoing both by 89bio and Akero, testing their compounds in patients with clinically significant portal hypertension. So in summary and to the conclusion, MASH is fast becoming our top reason for liver transplants, and patients with decompensated MASH cirrhosis have unique trajectories driven by portal hypertension. So incretin mimetics are poised to play a game-changing role in the disease, but likely at an earlier stage. So can they treat our MASH cirrhotics? Thus far, the data seems not. Other pharmacological agents may have more value, but coming back to my original question, can it help prevent cirrhosis? Potentially, but this comes to healthcare financing, like what we see in IBD, top-down versus bottom-up approaches. Before they develop any liver problems, do we want to treat all patients with incretin mimetics? With that, thank you, and I'm happy to take any questions. Thank you.
Thank you, sir. I request you to kindly take a seat on the dais. We will have question and answers after all the 3 lectures. For our next speaker, I would like to invite Dr. Dharmesh Kapoor, who will speak on should sarcopenia and frailty be a part of prognostic model for patients with end-stage liver disease.
Good evening, everyone. Thanks to Neeraj, Narendra and Swapnil for this invite. So we all know that patients with chronic liver disease, especially cirrhotics, they have varying degrees of malnutrition, which is a very subjective and a vague term as we use it in the clinical parlance and in our clinical context. And this happens because of a number of reasons, including bad diet, no salt, poor appetite, cachexia, ascites, so on and so forth. And to make matters a little more objective, came in how to estimate the muscle mass, and that defined the sarcopenia that we talk of these patients. And this is basically the skeletal muscle mass that arbitrarily is defined in the spine at the L3 level, and it is normalized to the age of the patient. So it's different for men and women, and it has been estimated as different values in the Western world, though we do not have any such data for the Indian context. So 50 in men and 39 in women. And then came the concept of the functional status of a given patient, which to my mind is the most important of the 3 things, which is defined by the frailty. So this basically is a multi-dimensional construct which talks about not just it talks about your current status, but also your physical reserve in response to various stressors. And if all these stresses, they trip the balance and make you more vulnerable, and they alter your outcomes and also make you more dependent either on your family or on the healthcare system, then you are said to be frail. So mind you, other than malnutrition, the second and third terms were earlier defined only for the older people by the European group. And now this has been basically extrapolated to a number of other diseases, including chronic liver disease. So just to set the record straight, in patients with LV dysfunction, the occurrence of sarcopenia is about 29%. In patients with cor pulmonale, it's about 24%. And in cirrhotics, undefined, that means all comers, it's anywhere from 40 to 50%. And it might be higher as the disease progresses. So how do we incorporate these entities into our clinical assessment of a given patient? So there are various ways of doing it, and this is an extremely elaborate process. And one of the reasons why this subject has become so hot and so hotly debated is that earlier it used to be just an eyeball test or end of the bed test, that you will see someone walk into a clinic or in the ICU or on the wards, and you will say, yes, this patient looks good to me, this patient does not look as good to me. So subjective global assessment, this still is the mainstay of how we look at our patients. Of course, there are some components of history, whether they feel exhausted, whether they have had an unintentional weight loss, what is their activity scale, so on and so forth. And then we assess sarcopenia, which is basically an assessment of muscle mass, like I just alluded to a little while ago. But you can objectively also look at the muscle strength and muscle performance. So you can do a bedside, or in your clinic, you can do use a Zamar dynamometer, which has become very commonplace, to look at the hand grip strength. Then you can make the patient do some very simple maneuvers, and you will calculate a score. And assessment of frailty basically means that what has this patient been going through in response to various insults in the recent past. And now this is the most contentious of the issues in a patient who's got cirrhosis. And obviously it's a no-brainer to say that all these things probably should figure in our care of a cirrhotic patient. But the important question is, do they actually change the course of illness, or do they actually alter our management plans for these patients? So let's just talk about some seminal work which happened more than a decade ago. So basically two groups in North America, one the UCSF and then in Alberta. And I saw in the brochure that Punita's name was there, and probably she's done some remarkable work in this particular condition, and probably a much better person to give this talk. So what these groups defined was, how do patients with sarcopenia and frail, they perform when you have the far end of the spectrum of disease, which is patients who have got end-stage liver disease and who are going to go in for transplantation. So what these groups found was something which was similar. So those patients who had a low MELD score, and mind you, beyond 2002, this was the defining moment for referring a patient to a transplant center, scores between 15 and upwards. So the UCSF group, on their follow-up of just 1 year in about 300 patients, found that patients who had got a low MELD score and who did not have frailty, they did very differently from those patients who had frailty. And even at a low MELD score, if you were frail, you either died or you were delisted off the wait list. That means you became too sick to be transplanted. And they used the various batteries, and again, this particular protocol has evolved over a period of time. So you will hear about various instruments like the FFI, which is the frailty score, the short physical performance battery, the activities of daily living, and instrumental activities of daily living. So they define roughly your muscle strength, your performance, gait, what you do with respect to taking care of yourself in a very simple way, like bathing, clothing, coming up to the dining table, so on and so forth, and whether you can do a few things higher than that, like doing your laundry, ordering your groceries, so on and so forth. So these become the ADLs and the IADLs. So these are extremely important, and there is a scoring system given for that. So what these authors found was that, again, if you were frail, there was a high chance that you would die even at low MELD scores. And this was indeed proven by the mortality on the wait list. What Punita Tandon's group found was that the effect of sarcopenia, or a reduced muscle mass at L3, which is also called the skeletal muscle index or SMI, is more important or more impactful in men compared to women. And as the Child-Pugh status deteriorates, so does the sarcopenia. Again, this is very intuitive, but what is important to remember is what you heard from the speaker just before me, that when you are trying to lose your fat mass, something also happens to your muscle mass, and there is probably something to pick up from that. And they also found that there was correlation with the dry weight BMI. So dry weight BMI means that you are correcting it for the grade of ascites as well as edema. But there, as you can see in these box plots, there is a huge overlap in the dry weight BMIs between the non-sarcopenic group and the sarcopenic group. Again, in the men, you can see that as the BMI is low, most of these patients are sarcopenic. The impact is much higher in men than in women. And the sarcopenia correlated with the Child-Pugh score, but not the MELD score. And obviously, like I mentioned, the male sex and age. And it is again very intuitive because these terms were first defined for elderly people. The same group, Alberta group, also found that the waitlist survival in these patients was significantly compromised if they were frail. And they actually proposed that these patients should probably be given extra MELD points so that their care or their shot at an organ was not hampered just because they had a low MELD score. And these authors, they mooted the idea of adding 10 to their calculated MELD score, especially if the MELD score was less than 20. And again, you can see that the 6-month survival on the wait list was much more worse in patients who were sarcopenic than who were not sarcopenic. And a very recent study also which came from Buenos Aires, and again you can see this is the battery of tests which these authors have used to define sarcopenia and frailty in this cohort of patients, and they found that about 1/4 of their patients, they could predict that they will go on to develop ACLF on wait list. And obviously this is well known that it is not just about you having low muscle mass, it also predisposes you to sepsis, development of hepatic encephalopathy, your response to any other stressor, so on and so forth, and that is why this particular condition is so important. However, the important thing to remember is that the correlation between assessment tools of sarcopenia and frailty were poor. That means you have to run both the two things. And mind you, it is not just the SMI at L3. If your SMI at L3 is poor, but you still have got good muscle strength, it does not make you sarcopenic. So both of those two entities have to be bad for you to be able to have sarcopenia. And as expected, if they were to include the sarcopenia and frailty also to the MELD score, they were able to have a much better prediction model, as you see in the bottom right of the slide. But obviously, again, you can see that there is a huge overlap between the green peaks and the purple peaks. So just as you saw in the Alberta group paper that in the dry weight BMI, there is a huge overlap between the non-sarcopenics and sarcopenics. So is it important only on the waitlist survival and leads to death and delisting? No, it is also extremely important for the post-transplant survival. Again, from the Alberta group, where they showed that the overall infections were were different and they were numerically higher in the sarcopenics, predominantly bacterial infections, as also the viral and fungal infections, but it did not alter the overall survival. However, if they did a subgroup analysis, those who had the extreme sex styles, especially in the male patients, they had a worse post-transplant survival, and also those patients who recovered their sarcopenia after transplants, they tended to do better. So I will repeat this because this is again something that we oftentimes don't talk of. So we only talk of sarcopenia in the pre-transplant period. But please remember that sarcopenia persists into the post-transplant period also, and it's not something that gets better in a jiffy. And even in the post-transplant scenario, only those patients tend to do better who have a recovery from their sarcopenia. So there is an important message in that statement. Now, what about the healthcare utilization post-transplant? Again, a no-brainer. This particular study again, which is from the frailty trial, and I would recommend this trial. This has been going on for a number of years, more than a decade, for all of us who are interested in this subject to read about it, that it is not just at 1 year, but 3 years and 5 years also, that their survival is significantly different from those who are not frail. And as you can see in this table, the post-transplant length of stay, ICU stay, days with hospitalizations within the first 3 months, and non-home discharges are significantly more common in the sarcopenic group. So this brings us to the question that has been assigned to me. So should sarcopenia and frailty be included in decision making regarding liver transplant? Of course it is extremely important, but it should not be done in a negative manner. Now, these are the groups again from the frailty trial that now you have defined a liver frailty score and a liver frailty index, and if you are more than 4.5, you are supposed to be very frail. What do you do while you are waiting on the wait list? So again, as you can see that a number of patients were delisted, but if you were to follow up these patients, the delta LFI over 3 months improves only in a marginal number of patients. In most of the other patients, it either remains stable, which is 1/3, or there is worsening. So you must remember that this is a disease which is a continuum, it's not a one-off thing. So if you want to say that your patients are sarcopenic and frail and I am not going to take them up for transplant just because of this very reason, probably we are harming these patients, because also in very closely regulated clinical studies, you are really not able to make a huge impact, which again is very intuitive because these patients continue to get one insult or the other. So this is not like the elderly patients who might not have any insult over a prolonged period of time. Again, an excellent study which is from the UNOS database. So you can see the denominator, it runs into thousands. So what happened in this? Group 1 is the patient in whom, so in the US, when you are being allocated an organ or you are being assigned to a liver transplant center, the Karnofsky's performance scale is a part and parcel of the data that gets uploaded. So group 1 is the patients in whom, as you can see, the MELDs are not very different. In group 1, the KFS does not change much, whereas in group 2, it deteriorates. So look at the wait list times. It is much higher for those in whom the Karnofsky performance scale deteriorates, and it has a direct impact on patient survival time as well as graft survival time. But look at the group 1 also. Here also, while you are waiting only for about 6 months, there is a decrease, or there is a difference in the KPS, whereas here there is a sharp decline in the KPS. So what one is trying to say is that in an attempt to improve the patient's performance scale, you are probably harming this patient, but not by not taking him up for transplant early, and in the process you are having a deterioration in both the survival time as well as the graft time. So if you were to plot the Kaplan-Meier curves, you can see that this is for the complete cohort. So those in whom there was a decline in the functional state vis-a-vis those who had an improvement in functional state, again no brainer. The one in whom there was not much difference in the KPSS, they did much better. But look at the group 2, in which for the whole cohort the score dropped from 70 to 40. You can see that even a decrement of 10 points was significant in reducing the survival probability for these patients. So the important message is, you might have defined the LFI, you might have defined the KPSS, but when an attempt to improve upon this while the patient is waitlisted, this might not bear fruits. And how do we do when it comes to the nutrition in these patients? So again, an excellent high risk malnutrition clinic data from Alberta, and you can see that we really do very badly amongst patients who have got SGA-C. So these are the patients who have got significant malnutrition with respect to both the caloric intake and protein intake. So it's not very easy to make your sick patients eat well, and hence you hope that yes, their muscle mass will get better and their functional status would get better. So should sarcopenia and frailty decide waitlist prioritization? Probably in a deceased donor setting, it will be a little different from a living donor setting. We should all make an effort to improve the patient's functional status. If you were to ask me that I want a patient who's more sarcopenic vis-a-vis more frail, I would say I would probably have do better with the patient who's more sarcopenic but not so frail. So there is not one-to-one correlation between the two entities. So the mortality risk associated with frailty and sarcopenia is high in pre-liver transplant setting, but it does not mean that it becomes normal in the post-transplant period. These are not completely reversible after transplant, and also with the standard interventions that we have, they don't get better. So this is a very contentious subject. I think we still understand very poorly as to how these patients can be fed. So you just heard from me that after transplant also they don't get better, but it is not the same impact as you see while they are on the wait list. So they might be having persistent sarcopenia, they might develop sarcopenic obesity, but still these are patients who are more functional. They are not as frail. So therein comes the role of nutrition, cognition, metacognition, and substrate utilization, about which we know very little. So in the interest of time, I didn't talk about myostatosis, which is again a very, very hot topic nowadays, that don't look at the whole muscle mass, but look at also the muscle mass, which is pure muscle vis-a-vis fat. So all this while we are thinking that fat in the muscle is bad. But what did you hear from the earlier speaker? Just think about it. I don't think fat in the muscle is bad. Thank you very much.
Thank you, sir. We will request you to take a seat on the dais. And for the next keynote, I would like to involve Professor Shivkesarin, who who does not need any introduction to this audience, and he will speak on acute on chronic liver failure, the Kyoto Consensus.
Thank you, Dr. Neeraj and Dr. Soin, for inviting me. I would like to bring some greetings from ILBS, but the consensus is developed by close to 150 people across the country and the world. I have nothing to disclose, but I'll just update you straight away to the Kyoto Consensus. This was published and Ashok led the thing along with some other colleagues. This is an old slide just to remind you that an acute insult, either alcohol, virus, drug, and I'll show you some of them, they will lead to a series of intrahepatic injuries which release cytokines. The inflammation occurs, you have SIRS, it goes back to the liver, and it may start from dysbiosis and a leaky gut. So you have an inducer, you have a sensor, you have a mediator, you have a response which could lead to organ failure. And the options for us can be remove some of these. So this is where the Kyoto Consensus starts, a spectrum of liver failure in a patient of cirrhosis. So F3, F4 or a compensated cirrhosis, there is a precipitant. This precipitant possibly can have several mechanisms. So it can have an ACLF, decompensated cirrhosis. Now you can have acute decompensation, which is defined as a decompensation without jaundice in 3 months' time, or a non-acute decompensation, which the patient may already be decompensated. We are not confusing, this is the easel ASLD, but the apostle is straight. Then there can be a recompensation or regression in 12 months' time. Then there can be several other courses of ACLF, recovery, liver transplant, multi-organ failure or death. So this is an important slide to show you the differences: chronic liver disease, compensated cirrhosis or decompensated cirrhosis. Now, what is the real time for non-transplant options? Don't think of transplant, non-transplant options. So apostle, Japanese, Koch, ASLD, Mexican, all of these have liver failure at its center and bilirubin of more than 5 in INR. In them ascites, but no extrahepatic organ failure is unique for apostle and Japanese, while others may include organ failure. Now up to here, if it is just the liver, it may be a good time. Now if you take the definitions which are by Easel Cliff, you will have several variations of these, and extrahepatic organ failure is mandatory. It may be late. They also may not need any jaundice. While if you have patients who are already decompensated, you will have further decompensation. Because of any of these mechanisms, you may have 2 or more organ failure. This is NCR, the North American definition. This may be too late. Now this is the natural history. So what Kyoto Consensus did was to define it like this: ACLF type A or type B. Type A is one which has mainly hepatic component. The patient comes, he has got jaundice, liver failure, maybe kidney, maybe anything else. So liver, coagulation, cerebral, this is type A ACLF. What is type B? Type B have Easel, Cliff, ASLD, NCR, where you have extrahepatic organ failures. And this can be assessed by ACLF severity, by ARC, Koch, Cliff and any other scores. I am not going into detail, but trying to say now it is simple, type A or type B ACLF. What is the etiology? This is a database of some close to 11,000 patients. Now the acute insult, surprisingly painfully, is alcohol and then others including Hep B. While the chronic liver injury also is alcohol and then virus. contribute, join ARC and enrich the database. Now this is also an interesting conceptual diagram. So patient who has got compensated advanced chronic liver disease, it's like F3, F4 in a way. The person gets an acute insult. This is the total liver reserve. In a cirrhosis, the liver reserve is less. In ACLF, it shrinks rapidly to a smaller liver reserve. Well, if the patient improves, there is reversal. It doesn't come back to the same, but maybe it is there. In acute decompensation, there is also a regression in the liver reserve. Now, a patient can recompensate. The liver cirrhosis to some extent can regress. However, patient maybe alcohol, maybe drugs can have ACLF again. So this cycle can go on. What is shown here is that there is a possibility, and I'll come to it, reversal of ACLF. This concept I'll show later. Also in the pathogenesis of acute portal hypertension, all these are diagrams in the ACLF consensus published. Normally the HUPG is less than 5, but it can rise to subclinical, then maybe clinical portal hypertension, development of varices and complications. The basic pathogenesis is an increased intrahepatic resistance and portal pressure, which suddenly increases due to liver cell death, and because of which sudden liver cell death, you have a decrease in systemic vascular resistance, MAP, cardiac function, and there is a higher cardiac output. All this is related to bilirubin also. So the mechanism of acute portal hypertension in ACLF is cell death, inflammation, cytokines as I showed you, activation of stellate cells, endothelial cell dysfunction, impaired vascular relaxation, vasodilatory effects of hyperbilirubinemia and bile acids. This can make within 4 weeks, less than 4 weeks time, development of high risk varices from no varices. So the message is, please look into your patient for development of varices if he is at end of 4 weeks. Also, you may have less than low risk varices in less than 4 weeks. Progression can lead to bleed, ascites, SBP, HRS. Now, as far as assessment of a patient is concerned, the POCUS, point of care ultrasound, has been included in the assessment of the patients, and you will be able to assess sepsis, circulatory failure. All these are indications for using POCUS in ACLF. Kidney injury, when you are doing paracentesis, PICD, cardiac output, you are giving fluids, you are managing AKI, hemodynamic. So remember, POCUS is now an integral part of an ACLF management. And you will have to see at admission at 24 hours, at 48 hours and 72 hours. And this will tell you also the fluid, the cardiac contractility, cardiomyopathy, adverse events, predictors and all others. I would request you to go through it and make it a part of the management. Now this is a beautiful new diagram. It was developed by several groups together. We were always trying to say organ failure. Let me define organ failure first. Cerebral, in a way this is cognitive dysfunction, this is the better term, HE grade 3 and 4. You may have respiratory, PaO2 to FiO2 less than 200, circulatory, patient needs a vasopressor, and kidney stage 3 AKI as per ICA or ADQI. But important is the organ dysfunction. So the first rule in managing a patient of ACLF in an ICU is to prevent organs. Don't do things which will make organ dysfunction to failure, or no organ dysfunction to organ dysfunction. What is it? Grade 1 and 2, the FiO2, PaO2 FiO2 is more than 200, no need of vasopressors, MAP is above 65, and kidney stage 2. And then you can easily use the ARC grade. which is up to 7 okay, 8 and 9 is bad, and above 10 certainly is bad. And you are fully aware of the ARC grades. But let me tell you again and its importance. So ARC includes jaundice, coagulopathy, encephalopathy and lactate. These four put together are the liver failure, and which is a driver for kidney failure. And just to give you an example, patient may come to you in the beginning with a bilirubin of 22, HE is not there, INR is abnormal, lactate is high, creatinine is still less than 1. So you have to preserve your kidney, and his ARC score is 9. This ARC score, you have to see that it comes down. And this is after day 4. This patient now has got higher INR, higher lactate, and creatinine has worsened, and ARC score is 12. And if the ARC score is above 10, the mortality increases in day 7 by about 20% or so. Now, new things in the management of ACLF with AKI. So you will have a patient who has ACLF and AKI but has no shock, and then you have to identify the phenotype, whether it is a functional AKI or a structural AKI. So 6-hourly IVC assessment is integral. Monitor, map, urine output and create. If the AKI is persisting or progressing, you will have to use IVC collapsibility, IVC distensibility, all through. Volume expansion with 20% IV albumin, dose has to be individualized, is very careful. The current guidelines say wait for 48 hours, but the new guidelines say just wait 12 hours. If 12 hours, this is called early study, early terlipressin. In 12 hours, if there is no benefit, then you may switch on this patient. If there is no response, then either dose escalation or renal replacement therapy. So the switch is continuous monitoring, IVC monitoring and albumin only 12 hours. The new algorithm for managing HE, now patient has come, you will see whether he needs an ICU admission, then you monitor with ammonia, specific treatments, purging and others, and manage the cause. If he is in grade 3 or 4, MELD is high, ARC is high, he is a criteria for early transplantation. It is grade 1 and 2 with a lower MELD of less than 30 or ARC, where you will do and you will employ all possible strategies, dynamically assess, and like ALF, you please look into ONSD and manage these patients. This is to give you an idea. This is also a diagram which is not there in the current Kyoto, but we have prepared it. The methodology for managing artificial liver supports can be divided. Albumin based dialysis, you can also have non-selective dialysis, you can also have selective dialysis and semi-selective dialysis, and you will have renal replacement therapy. I am not going into details, but just to tell you, replacing albumin, then by pumping albumin, the best method is replace albumin by one method or the other. Managing acute portal hypertension, I told you this diagram I showed you, but this is the complete diagram. Beta blockers like carvedilol or even propranolol, they decrease portal pressure, and if the pressure is decreased, AKI, HE, bleed is decreased, and survival can be better. The new kid on the block is midodrine. Midodrine compared to non-selective beta blocker is far superior for managing ACLF. HVPG by midodrine is better responder. So you give beta blocker or you give midodrine. If the MAP increases by 8 millimeter, portal pressure has come down. So give midodrine, wait for some time. I don't have time for telling you, but increasing MAP and the beta blocker response comes. PICD can be a major challenge for us, and therefore such patients must receive albumin, and you have to prevent PICD in your patients, which is much more. In the cirrhotics, the incidence may be 20 to 30%, but in ACLF, very high, even in hospital settings. Today only I saw one. Alcohol, ACLF is a very challenging thing. How do you decide at baseline my patients will respond? Here is the parameter. If the ARC score is 10 or less, there is reduced mortality with steroids, and steroid responsiveness is there if the ARC score is less than 10. So calculate and use based on ARC. Now if the patient can recompensate or not, so how do you call it recompensation? I wish I had time, but alcohol, HCV, HBV, all these, if you are managing and including alcohol and obesity, there is a sustained improvement over 12 months. We have recently got this paper under review that only 11% of the ACLF reverse by day 90. But if they have survived day 90, you have to follow them for 12 months' time. Liver transplant is an important thing, and this is the Asian data. The survival for ARC1, ARC2 and ARC3 is reasonable and compared as to the West. This is my last slide. The algorithmic management of ACLF from ARC and from the Kyoto consensus. This is slightly revised from before. If the ARC score is about 10 and MELD is about 30, you will wait but start transplant workup, and by day 4, if the ARC score has decreased, improved, then maybe medical management. But otherwise, this guy should be ready for transplant by day 7. If the ARC score is increasing by day 4 to 7, emergency transplant. If the patient has got more than 2 organ failures, you will give PLEX or ALS, artificial liver support. If he is stable and improving, emergency transplant. If not improving, maybe we declare futility, and INASL has proposed. And if the patient has come with 4 or more organ failures or ARC is above 13, the patient would require a counseling for futile transplant. I hope the newer consensus which are developing on ASLD and EASL coming up and Beijing consensus in 2025 will add more light. The whole idea was unification of type A and type B ACLF. Thank you.
We can have the question and answer and expert insights. All the 3 keynotes have been delivered and the house is open for discussion.
Any questions? Shiv, I'll just start with you. There is a concept of pre-ACLF. Does that still hold true? And just elaborate more on further decompensation. These 2 things.
Pre-ACLF is a concept which came up. Initially, they were only using patients with decompensated cirrhosis or patients with cirrhosis. When we came up with F3, F4, then the pre-ACLF concept came that he hasn't gone into failure as yet. So I think right now it would be very difficult to define pre-ACLF. I would say, and the new consensus developing are using hepatic dysfunction between 3 to 7.5 and above 7.5. So I don't think pre-ACLF would stand. And further decompensation is a very different concept. One is your acute decompensation from which you can improve, then you are stable, and then second time you have another decompensation, then you call it second decompensation, third decompensation. Further decompensation was given by Bevino, and this is a patient who has improved and now has another acute insult and he gets. Surprisingly, they did not include jaundice into decompensation. For whatever reason, they included ascites, bleed and HE, but not jaundice. So the debate is on In my mind, further decompensation is natural history of this.
Thank you. Any more questions?
Yes. My question is for Mark. Mark, thank you very much. Our experience in Europe is a dramatic decompensation of metabolic balance after liver transplantation with overweight and diabetes. Would there be any rationale in treating these patients upfront after liver transplant?
So I think that's a very important point, and I think this has been alluded to before, that MASH is a systemic disease. There's an abnormal metabolic milieu. We're just taking out the liver, and we're putting in a new liver that's at risk of developing issues. I think there's one study that has demonstrated actually that MASH patients have increased weight gain post-transplant and increased adiposity post-transplant with persistent abnormal metabolic flexibility. So I think there is value in using metabolically targeted agents. We know that these patients do develop cardiac dysfunction. MASH patients have persistent diastolic dysfunction post-transplant. Initially we thought cirrhotic cardiomyopathy, but they have persistence of the diastolic dysfunction. So I think there is a role to do it. I think the problem is that one of the challenges is these drugs are new. A lot of the pharma companies do not like to test their drugs in our post-transplant patients. We have, I think a few of us got together and wrote a statement on how to analyze and how to evaluate drugs and endpoints for metabolic endpoints. So we're hoping that eventually that these will be taken up and that they will be used. There is, however, very clear safety data in the post-transplant population, because with SGLT2 inhibitors there's a risk of urinary tract infections, worsening of diabetic ulcers. I think the data for infections is very clear. Some of the emerging data for GLP-1 receptor agonists in terms of progressive proliferative retinopathy, it potentially may be a concern. So, but otherwise, there's very clear safety data for these drugs. And I think, I know there is, North America, there's a multi-center study looking at early GLP-1 receptor agonist post-transplant. But I think we have yet to see. Thank you.
So I have a question for Kapoor, sir. Sir, actually we have a frail and sarcopenic patient with cirrhosis. They have poor post-LT outcomes also as compared to non-sarcopenic patients. And when they are on wait listing also, they have higher mortality. So what should be our approach? Should we offer them a liver transplant upfront, or should we put them on some rehabilitation program like intensive nutrition therapy and some exercise program which they can tolerate according to their CTB status, which will improve their functional status and outcome also? Or we should offer them liver transplant alone, because you showed in your presentation that even if we offer them some nutritional program, then also it is not sure whether they are only a few percentage of patients will improve their nutritional and sarcopenic status. So your comments on that, sir.
So I think prehabilitation always works. So the extent to which it works is again not very uniform. It will depend on the patient cohort. Now again, to set the record straight, this would be different in the living donor setting vis-a-vis a deceased donor setting. I'm not very sure, and we are sitting in New Delhi where more than 95% of the transplants happen the living donor way. How many of the centers would just be looking at the sarcopenia and frailty? So sarcopenia is probably extremely common, but I don't think as impactful as frailty is. So I think a functional patient is far better than a person in whom you have just done one cross-sectional imaging and defined that they have got a low SMI. We also do not know how the SMI would behave. Like I said briefly in the talk, that different muscle groups need not necessarily work the same way. So you might be sarcopenic in one muscle group but not in another group. Also the way that you define it, whether everyone undergoes cross-sectional imaging vis-a-vis the other tools which are used in the Western world, mainly bioelectrical impedance and the DEXA. So they will again get altered if you have got edema and ascites. So of course the effort should be to build up the nutrition. So as a transplant hepatologist, I keep telling my patients that the only two things that work is diet and exercise, and I mean every letter of the two sentences. The other things are at best, not very predictable. You have to get your patient to a stage where you think that this patient can be safely transplanted. And it also becomes very challenging, especially if your patient has got encephalopathy. Those are the things which I didn't mention, but again, there can be huge challenges in prehabilitation. So we should try to improve every patient's nutrition, but more importantly, we should try every patient's physical status. In our program, long story short, anybody who's wheelchair bound, we don't transplant. So you have to be able to walk unaided. If you are coming into the transplant clinic and you are in a wheelchair, it's a no-go for transplant.
Can I add something to what Dr. Dharmesh said? Firstly, I enjoyed your talk, Dharmesh. We had a randomized trial where we tried nutrition, exercise versus nutrition, exercise and testosterone. This was the thesis of one of the students and presented but not published. And those who were frail became pre-frail, maybe close to 20-25% with NECs. But when testosterone was given for 6 months, I think the response rate increased to close to 50% or so. So and we use it now regularly, testosterone. This was the first study by Sinclair. In my assessment, exercise and nutrition alone may not be enough. Maybe testosterone should be tried, or other similar anabolic steroids can be tried.
So the agents in pipeline are testosterone, like you rightly mentioned, then growth hormone analogs, myostatin inhibitors. So these are the drugs which are in the pipeline, but there are issues in using them because of their at least animal model studies of predisposition to hepatic masses. So that is something to bear in mind.
The best myostatin inhibitor is natural, yellow of the egg. It has folistatin. So folistatin is the best inhibitor of myostatin. So people only give white of an egg. So giving yellow of an egg along with white is better than white.
My question to Dr. Mark, in the last presentation you have shown that SGLT2 inhibitors significantly reduce the risk of SCC. Whether it is related to the delaying the preventing the progression to the cirrhosis or any other direct effect of the SGLT2 inhibitors in
So that was an observational study from the Hong Kong group. So they didn't really have mechanistic interrogation. They just generally showed that diabetic patients with hepatitis B, when they corrected for the standard hepatitis B risk, so all the patients were aviremic, when they looked at the choice of anti-diabetic agents, they saw a benefit of SGLT2 inhibitors. I think one of the problems is that in the metabolic world, when people were conducting studies, when the SGLT2 studies were being conducted, there was very little liver phenotyping. So we see, and they just ignored the liver completely. And so because of that, there were very little liver readouts. Whereas when they conducted the GLP-1 receptor studies, they did carry out some markers of liver fibrosis, liver injury, more than just the standard drug-induced liver injury markers. So because of that, there were signals for them to progress in the studies. But I think right now they are investigating this, so this will be quite relevant. I think in our patient population, maybe even in the post-transplant population, we have patients who have albuminuria, proteinuria. In my center, we push when we transplant high-risk HCCs. We push the everolimus, we get proteinuria, we actually add on a SGLT2 inhibitor and an ACE-ARB because we're trying to minimize the recurrence of HCC. So these are some of the off-label strategies that we use. But again, I think the data for this space is very, very minimal.
Just a comment on sarcopenia and frailty. So we've done 2 studies on nutrition, one in decomp cirrhosis and one in ACLF. And dietitian-guided nutrition therapy shows significant improvement in frailty, and the functional outcome definitely improves. Survival will also improve, and the hospitalization definitely comes down if you give good nutrition to the patients. My question is to Mark. Mark, you've shown some very interesting data on loss of muscle mass with GLP-1 receptor agonists. So my question is that what is the ideal method to assess muscle mass in such patients, and is it the L3-SMI or you should do a BI? So, and what was the method used in this paper?
So in a lot of the studies that, a lot of the data has come from the clinical trials. In the clinical trials, they actually do MRI-based body composition profiling, which is where they evaluated the loss of the fat-free muscle. And I think my understanding right now is that they are developing amylin analogs. So I think there's a drug, CagriSema, that is muscle sparing. So right now people are trying to input muscle sparing into the GLP-1 receptor agonist. But at the end of the day, if it's a disease of too many carbons, you have to get rid of the carbons. You can't just take a magic pill. I mean, that's the counter argument.
So Sunil, I don't think you need a device to assess how you are losing the muscle mass. The description Ozempic facies comes from this only. So you are losing muscle. You cannot lose fat without losing muscle. And the CagriSema study actually is a negative study. So this is again a Novo Nordisk product. So I think one has to live with it. You cannot lose fat without losing muscle. It's almost unthinkable. So that's why I made a very provocative statement at the end that we all think myostatosis is bad. It's not bad. Just think about it.
So my question to Dr. Sareen. Sir, I agree with you that just giving protein is not enough. You need testosterone for protein to be assimilated and converted to muscle. But the issue is testosterone, how long, till when? Because the problem is testosterone will lead to further testicular atrophy and other complications like Dr. Dharmesh has mentioned, other than that painful gynecomastia and all those things.
Actually, Dharmesh should answer. It was his topic, but I just pitched in. Testosterone levels normally 2 to 4, but almost 90% of cirrhotics are 0.1 to 0.4. We give it till the time it reaches around 4. Some people can reach it in 2 months' time, too short. Some take longer, but not more than 6 months. We don't want tumors in the liver. And these are generally patients who are waitlisting for transplant.
But it will lead to testicular atrophy and
they're already
level
atrophied. They're already,
go down again.
a male is a female and a female is a male. We have to wait. Get the liver.
Okay, one last question, please. That's all.
My question is to Dr. Mark as well as Dr. Dharmesh, sir. You both are talking about the muscle mass, fat, and about the use of SGLT2 and GLP-1 inhibitors. Do you really feel that a combination of a glitazone along with GLP-1 will do better, or GLP-1 alone?
So actually, I personally do not start my cirrhotic patients on GLP-1 receptor agonists. I think both from a data standpoint, I think the phase 2B data that Prof. Rohit published in Lancet Gastro had, I think that was quite relevant. And I think there are a number of issues in our cirrhotic patients that there's a lot of other things that need attention in terms of, I do not want them vomiting. I do not want a poor nutrition status. So I'm quite particular about that. In terms of glitazones, we are, I guess we have a very, at least in my center, we have a very high threshold to use glitazones. I think the PIPA pathway is quite attractive and valuable, but I think there's always a worry for the side effects. I think in our entire patient population, we can count on one hand the number of patients that are on glitazone. So unfortunately, I don't have very much experience, but I agree that the PIPA gamma pathways are quite attractive.
So I don't think this combination has been studied. They might be acting by different pathophysiological mechanisms, but like Dr. Mark said, someone who's got cirrhosis or advanced fibrosis, one should be extremely careful in using pioglitazone. So it is one of the most wonderful drugs which is probably underutilized because not many drugs actually act on insulin resistance, and this one does. But still the side effect profile is quite severe. So one has to be very careful in using this drug when you've got advanced fibrosis/cirrhosis.
Dr. Dharmesh.
I think we'll end now.
Just one question, sir. You said that you can't lose fat without losing muscle. You said that you can't lose fat without losing muscle.
Yep, that's what the observation is. That
no, but
it's
if
difficult
you
to lose.
include vigorous exercises for your patients,
yeah.
I think that's not true. You can.
Yeah, so, okay, we'll talk about it maybe after this, because like I said that the muscle mass is very different in different parts of the body. Like I consider myself to be sarcopenic in the upper body and not sarcopenic in the lower body. So sarcopenia has only been defined in one cross-sectional imaging, which might not be the whole truth. That's what I was trying to say. And also, just because you have got low muscle mass does not make you sarcopenic. You also need to have bad muscle strength or performance. So just by one cross-sectional imaging, you cannot define this entity.
Okay, we'll end this session. I'd like to thank Professor Sareen, Dr. Dharmesh, and Dr. Mark for their wonderful talks, and all the chairpersons and the moderators. We can have a quick picture. And we'll break for tea for 10 minutes and then reassemble for the last session of the day.
running late, so I think we will be starting the next session on vascular disorders of the liver. And for that, I would like to call our moderators, Dr. G.S. Lamba sir, Dr. B.K. Agrawal sir, to take their seats on the left hand side of the dais. I would like to call the expert discussions. Dr. Ranjit Sood will be joining in a while. Dr. Sandeep Thareja sir, Dr. Sharad Putta sir, and Dr. Sanjay Kumar to take their seats in the center. The first session lecture is by Dr. Gokhan Kabakam. Due to some medical emergency at 11th hour, he couldn't make it here in person. So we are running a pre-recorded lecture of Dr. Gokhan, and we will have a discussion at the end of the session. He will be giving a talk on the use of anticoagulants in cirrhosis, a major research gap.
Dear colleagues, ladies and gentlemen, I would like to thank to the organizing committee, Dr. Neeraj, Saraf, Prashant Bangui and Avisoin for inviting me to this very important meeting. Clinics in liver disease and transplantation, holistic management of liver disease. I'm terribly sorry that I couldn't be there with you. Although everything was arranged until last minute, there was an emergency development. I couldn't make it. So my task today is the use of anticoagulants in cirrhosis, a major research gap. We know the coagulation pathway is affected, modulated by several different medications, oral and parenteral. And there are two tails of coagulation in the cirrhotic patients. There are both anti-hemostatic changes, thrombocytopenia, coagulation changes, and prohemostatic changes that affects in the system in both ways, and there is continuous rebalance of prothrombotic and antithrombotic factors. So there's a clear bleeding tendency in cirrhosis with low platelet, high INR, spontaneous anticoagulated state, hepatic encephalopathy and frailty-related falls and minor trauma causing both portal hypertension and non-portal hypertension related bleeding in the patients. So we see a patient like this in the emergency department having a hypotensive shock, having a overt variceal bleeding, as you may see here. This is a case of mine. I have the patient to the endoscopy unit, put a band ligation with high adrenaline in my blood and everything, control the patient and go on. So when we have a patient like this, we have to keep calm and scope on, of course. However, we have to be confident and sure to prevent the patient coming to this scenario, so we need to understand the dynamics here. Portal vein thrombosis is a reason, a clear reason we know to have the bleeding state in this patient. Although it's a thrombotic condition, we have variable clinical presentation and significance in the portal vein thrombosis. There can be genetic reasons, there can be prior embolic conditions. Slow portal flow is a clear risk factor with some other problems we see in these patients, and it can cause technical complexity of liver transplant. Also, some extrahepatic variables exist, as we already know. So the Poisson's law is very important because three primary factors, it says, that determine the resistance to blood flow within a single vessel, which are vessel diameter, vessel length, and viscosity. And this law states those with 50% lumen obstruction have a 94% reduction in the blood flow in that vessel. So this physiologic impact of the clot is very important. What does it cause? There are small vessel thrombosis which may promote the fibrosis progression and organ atrophy which may cause parenchymal extinction. And also the medications we are using to control the varices in our cirrhotic patients, for example, the non-selective beta blockers, as you may see here, may decrease the portal flow and may increase the portal vein thrombosis in these patients as well. So the 2020 ASLD guidance states the portal vein thrombosis to recent and chronic, location of the thrombosis, length of the clot, and also more important, less than 50%, more than 50%, complete obstruction. This is minimal, this is partial, this is complete obstruction, which we will state soon. So anticoagulation for indications not related to liver disease is maybe can give us a clue, because regardless of the etiology of cirrhosis, atrial fibrillation is, for example, more frequent in the recent years, and there's a 10% increase in the prescription of direct-acting anticoagulants in these patients. In a US national study having CHALCO-A and atrial fibrillation patients, drugs decreased overall mortality with no major increase in the major bleeding, and they are safer than warfarin actually. So what is if we have a patient with portal vein thrombosis with anticoagulation indication? So the studies are not so robust, mostly retrospective cohorts. Extended thrombosis is believed to increase the risk and complications and even death of the patient. This is well known. So we have a patient with portal vein thrombosis which is partial. Only 12% of the partial thrombosis will progress to complete. Not so major risk maybe, but 45% will improve even spontaneously. When we give them the treatment, anticoagulation, this increases to 60-70%. Impact of anticoagulation on the natural history of the patients with cirrhosis. So there are some preclinical data that says reduction of fibrosis and portal hypertension, and also some retrospective studies showing decreased portal hypertension and also complications and improved survival. Few RCTs, randomized controlled trials, though, preliminary results of a small RCT comparing rivaroxaban versus placebo says that there is a better decompensation-free survival in CHALCO 7 cases in the treatment arm only, which was presented in EASL Congress. So these are the summary slide of some murine models of cirrhosis having different anticoagulant medications, and we can see here that the beneficial effects of anticoagulation include reducing liver fibrosis, stellate cell activation, portal hypertension, liver function, and even survival. This study is done with obese rats, showing even the dabigatran can reduce the weight gain, not only the inflammation and hepatocellular damage, but also some other actions. So we have a patient, cirrhotic patient, we want to prevent development of portal vein thrombosis. Is it doable? So in this small study having 34 in the treatment arm or 36 in the other arm, using prophylactic enoxaparin delays the occurrence of hepatic decompensation and improves survival. You see probability of portal vein thrombosis is lower, decompensation is lower, and also survival is better in the treatment arm, in the prophylaxis arm. So we have a portal vein thrombosis development, then we use anticoagulation. What happens? Anticoagulation appears to reduce all-cause mortality in patients with cirrhosis and portal vein thrombosis. The beneficial of the anticoagulation on survival is independent of thrombosis severity and recanalization, and anticoagulation increases the rate of portal vein recanalization as it's expected, but there's an expense of increased non-portal hypertension related bleeding in these patients. If we see a patient with portal vein thrombosis, if we initiate the anticoagulant early, what we have, the portal vein recanalization overall and complete recanalization is better in the treatment arm, early treatment arm, and thrombus progression is better as well. But the survival is not affected too much, although bleeding is less in the treatment group. And also, if we have a chronic portal vein thrombosis in a cirrhotic patient, there is no much major bleeding, as you may see here, but clear survival advantage with some amount of recanalization and response. So this meta-analysis states that anticoagulation reduces all-cause mortality in the cirrhotic portal vein thrombosis patients independently of thrombosis severity and recanalization. You can see mortality is lower in the treatment arm. Which agent to use? It's pretty much difficult to say with this low amount of evidence, but there are some meta-analysis showing DOACs are better than vitamin K antagonists in chronic portal vein thrombosis, as you may see here. And we should also keep in mind in these patients, if the thrombus extends to the SMV, then this may cause the edema in the enteric system and limits the bioavailability of the oral anticoagulants, and this may diminish their action. So low molecular weight heparin is the treatment of choice in these patients. If we have a patient with Child-Pugh A and B, you can use any agent. If you have Child-Pugh C, low molecular weight heparin is safer. But still, we need to say that, we need to remind that robust evidence for clinical translation of all this evidence is lacking in randomized controlled trials. As a result, there are some guidelines published for therapeutic anticoagulation for portal vein thrombosis in patients with cirrhosis. Boveno 7 published in 2022. Which is maybe the most recent one. I will only express this here. They are pretty much similar. Recent, meaning less than 6 months, complete or partial occlusive thrombosis of portal vein trunk, or minimally occlusive thrombosis of portal vein trunk that is progressive on short-term follow-up, or compromising SMV, which may cause intestinal ischemia, that are symptomatic portal vein thrombosis, that are potential liver transplant candidates, we should treat them. Preferably, of course, initially low molecular weight heparins. The maintenance can be with anything. If the patient is Child-Pugh C, low molecular weight heparin maintenance is safer, relatively safer. And we shouldn't wait too much before controlling varices, although it seems to be difficult to apply in the clinical practice. It can be dangerous, you may understand. So the most recent guideline is coming from AGA, the clinical practice update on management of portal vein thrombosis in patients with cirrhosis. If we have portal vein thrombosis and there's intestinal ischemia, we should have urgent anticoagulation with interventional radiology, applications and everything. If there is no ischemia, we perform prophylaxis for variceal bleeding. If high risk varice present and non-selective beta blocker intolerant, then there are three ways. If there's a recent thrombus, less than 50% of main trunk, splenic vein or mesenteric vein, we can just consider observation and serious 3-monthly follow-up in these patients. If there's a progression, if there's a symptomatic development, or if the patient is transplant candidate, we should consider anticoagulation. If there's a recent thrombus with more than 50%, less than 100% occlusion, mesenteric vein inclusion, anticoagulate. If there's a complete occlusion and chronic with collateralization, there is no obvious benefit. Also, we should keep in mind the largest potential benefit is in the liver transplant list, progressive thrombus and additional hypercoagulability. So take-home messages, ladies and gentlemen, anticoagulation should be considered as a therapeutic option in cirrhotic patients. Data are inconclusive for robust recommendation and guideline. Probably certain subgroups of patients will get benefit, clinically significant and symptomatic portal hypertension, and also we can suggest it in asymptomatic but progressive portal vein thrombosis and liver transplant candidates with portal vein thrombosis. Prophylactic use, we are not there yet, I don't think so, and more research to be done. So by this, before I end, I would like to thank you for your attention, and I would like to invite all of you to Singapore in the end of May for a liver transplant festival, ILTS Congress, and thank you for your attention.
So this was a pre-recorded lecture. We will have question and answers at the end of the session where he will be present online. For the next session, I would like to call Dr. Neeraj Saraf for his panel discussion on recurrent variceal bleed in splenoportal thrombosis, management and optimization. And I would like to call the panelists on stage, Dr. Praveen Sharma sir, Dr. Zubin Dev Sharma sir, Dr. Sanjay Baijal sir, and Dr. Ravichand Siddhacharya sir, to take their seats at the center of the dais.
Thank you. So I'll be discussing a case of extensive splenoportal thrombosis who has recurrent variceal bleed, and we'll also talk about how to manage this patient and optimize him for a transplant. So this is, I had just kept this, but I think this has already been covered by, but we'll still see how many people listened to Dr. Gokham's lecture. So this is a question which he showed in his slide. So which is false regarding indication for anticoagulation in PVT in cirrhosis? Can we have the voting? So PVT in cirrhosis, who's a LT candidate, recent PVT with more than 50% occlusion, symptomatic PVT, less than 50% lumen, and any extension to SMV. Okay, so I think most people were attentive in the lecture, and D is the correct answer. So if you have less than 50% occlusion, then you wait and watch and follow these patients, and they are not indications for anticoagulation. So I'm going to skip this because I think this is all already covered by Dr. Gokham. Just I want to talk about just for 30 seconds on PVT classification, because this is going to be important. So when you have, these are the grades of PVT, the Yardle classification, where you have grade 1, grade 2, grade 3, grade 4, and grade 4 is complete portal vein thrombosis with extension into splenic vein and SMV. I'll skip this as well. So coming to the case, so this is a 44-year-old male, no comorbidities, no addictions. He was, he's from one of the CIS countries, was evaluated in his country, found to have HBV-related chronic liver disease and started on tenofovir alfenamide about a year ago. 6 months ago, he started developing ascites, which was diuretic refractory, And in the last 3 months, he has required 3 times large volume paracentesis. He also has jaundice for the last 3 months. He was just carrying a ultrasound, which we translated, and so the only thing we could really understand was that he had cirrhosis and ascites. Did not have any endoscopy report, no cross-sectional imaging, and he was basically referred here for liver transplantation for jaundice and refractory ascites, and came with a blood group matching donor. So as a transplant team, we thought it's straightforward, has a donor, has a clear-cut indication, and a young male, and we thought this is going to be a smooth transplant. So when he came to us, his bilirubin was 5.3, albumin was low, 2.3. He had the ascitic fluid, did not show any SBP. It was a high SAG ascites. The CTP score was 11, and the MELT sodium score was 22. And you can see he had large esophageal varices. And we did an ultrasound here, a Doppler, which showed liver cirrhosis with ascites and no flow in the portal vein. Subsequently, a CT was done, and you can see a very small liver ascites, and don't have a pointer here. Anyway, so he had complete portal vein thrombosis, splenic vein thrombosis, and it was just entering the main trunk of SMV. This is the reconstructed images. So, Dr. Ravi, you're a transplant surgeon. So here we have a patient who has complete portal vein thrombosis extending into the SMV and into the splenic vein. So how do you approach this patient for transplant? Would you say no to him? Would you transplant him? Or would you do some procedure to get him better, or improve the thrombosis?
So this patient has a PVT with extending him to SMV and splenic vein. So almost like Erdl's grade 3-4. So first, planning is very important for this patient. We need to have a good portal flow for a transplant. So I would sit with the radiologist, go through the CT scan, see the extent of thrombus. Are there any collaterals or shunts? And whether, is there any possibility to recanalize this portal vein by either anticoagulation or by PVR tips or some procedure? If this is an extensive thrombus and we can't straight away take him for transplantation, I think it is better to have some planning and get a good portal vein flow established before transplant would be better.
Yeah, so I don't think anticoagulation is going to really work in this, and you probably need a recanalizing procedure before you could take this patient up for transplant. So we do multidisciplinary team meetings for all our transplant patients, and so we decided that this patient should have TIPS with portal vein recanalization and subsequently plan a liver transplantation. So the workup for the donor as well as for the recipient was started. And but on day 4 of admission, while he was being worked up, he had episode of hematemesis, and obviously we scoped him, and he had large varices like I showed, and we banded him. He was continued on injection terlipressin. So before we move on to the case, so like I said, this patient was decided in the MDT that we're going to do a PVR tips on him. So Dr. Bajal, can you tell us what is a PVR tips?
So conceptually, PVR tips was a term which was developed with the intention to enable transplantation in patients with portal vein thrombosis. So the purpose of this is that if you can get a good outflow, then even if the portal vein is partially thrombosed or partially recanalized by IR procedures, the good outflow and the good inflow would finally result in the washing out and maturing of extrahepatic patent portal vein of adequate quality, which can be used for transplant. So that basically was PVR tips.
Okay, so this is, Dr. Bajal, you want to comment on this? So this is just schematic pictures of PVR tips with the stent extending into the, you want to comment on that?
So here, so This picture which we are showing to you technically is actually an extended tips. So I can see Prashant thinking on that. So technically extended tips and a PVR tips is slightly different. In PVR tips, the effort is to leave the extrahepatic portal veins supraduodenal portion without any device, so that it matures and the surgeons can then operate. But if we do what we do as an extended tips, is to bring it down all the way to SMV, it will recanalize, but it will be a stent assisted recanalization, which the surgeons would then have to cut that stent, extract all the wire meshes, and then see what's left behind about the quality of the portal vein, and then they're stuck during the transplant. So that's why PVR tips was made as a different entity as compared to extended tips.
Right. So that's what we had planned, that we would do a PVR tips in this patient and then subsequently take him up for transplant. We'll discuss how long to wait and all that subsequently. So these are his labs on day 4 when he had the first GI bleed. Hemoglobin was 7.2, INR was 2.1. Bilirubin when he came was 5, but then after the bleed it had risen to 9.3, and he had a CTP score of 12 and a MELD sodium score of 30. On day 10 he had another episode of hematemesis, and endoscopy showed post-EVL ulcers, and we did EST, we did glue, and nothing was working, so a Dennis Ella stent was deployed. By this time his INR had risen further to 2.6, his bilirubin had gone up to 11.2, and he had a worse CTP score and a MELD score. So this is a patient with extensive splenoportal thrombosis, and he's having a GI bleed, and then following that he has a resistant type of a post-EVL ulcer bleed. So after the stent was placed, he stabilized for a day or two, another episode of hematemesis and GI bleed on day 13, and went into shock, was shifted to ICU, resuscitated. We did another endoscopy. The stent was a little displaced. We played around with it. There was blood in the stomach. And I think after that he again bled. So he basically continued to bleed. We were giving him terlipressin, we were giving him obviously transfusions, but despite the stent, and I think obviously because of the extensive thrombosis, he was continuing to bleed. So Dr. Zubin, what do we do in this patient now?
So sir,
he has recurrent bleed or almost continuous bleed actually.
So at this point, sir, we have already kind of exhausted our endoscopic options. You had done a banding to begin with, followed by a glue, EST, and now it's already on a Dennis Ella stent. So I think apart from the resuscitation that obviously has to go on along like parallelly, endoscopically we first again check because that the Ella stent is still in the position or not, because that's something which is pretty common for it to migrate down. Secondly, if that is not a case and that's still in the position and you're still bleeding, I'll again scope to be sure that he's bleeding from the same site. If he is, I think this 10 days in between we would have probably done a preemptive or a rescue tips there and there itself. But now I think if that is not feasible at this point, I think Dr. Bezal sir used to do that antegrade, the embolization of the varices itself in the esophagus. That is one option that can still be done if not a tips. But if tips is still possible at this point, you would want to do it.
Yeah, so you're right. We kept planning the tips. Dr. Bajal is sitting here. We kept saying, okay, we're going to do it tomorrow. And then he just would bleed again, go back to ICU, hypotension, bring him back up, and then again he would bleed. Dr. Sood, your opinion on this, anything?
I think the option will only be tips, because there's very little which can be done otherwise, by doing varical embolization, and we have to ultimately go to tips, because that's the short-term and the long-term management of this patient.
Right.
So just one point. So just to ask, sir, in fact, at this point, even if you do tips, would you actually add an embolization to the vessels, right? Because only tips might not even solve the bleeding at this point.
Right. So to summarize at this point, this is a HBV-related CLD with ascites. Jaundice bilirubin is now 14.5, so this is something to be noted. no encephalopathy. Because of all these bleeds, his creatinine has also gone up to 2.1. MELD is 35 now. He has extensive splenoportal thrombosis, recurrent variceal bleed. So what next? Praveen, so we've sort of discussed this. Endotherapy is not working. Some people are suggesting tips and on transplant.
This patient is actively bleeding. So transplant option is probably no, and we do not have any option because patient has an extensive thrombosis. So
Right.
delayed transplant, it is not feasible at all. Second is endotherapy. We have exhausted all our things. The only thing which is left is tips. But doing a tips in this scenario where the patient is in ICU with a MELD score of 35, CTB score of 12, he has all the bad parameters which fits into a futile tips. But the only good thing for this patient is he has got a donor. So there are certain things which we can do because either we leave this patient alone and this patient is going to die. The second thing is we discuss with the patient that those tips will be maybe very difficult for him, but that is the only option that probably will make him live for longer. So I think the option left is the tips. We should go for the tips in this patient.
Right. So now the PVR tips has actually become a rescue tips rather than what we planned a week ago as a elective tips in preparation for transplant. So like you rightly said, this is a bad candidate for tips. So even at 5, we were a little reluctant. We waited a few days that maybe his bilirubin has come down. Now he has a bilirubin of, I think, 14.5, and I think it even went a little higher on the day. Are there any scores? How do you predict mortality after tips?
So in particular, this patient, because his CTB score is 13, so which is a bad prognostic marker. If we say his MELD score is more than 32, so this is again anybody who has a MELD score of maybe more than 30 with a CTB score of more than 13. These are the two bad prognostic score in this patient. Though we have some more parameters, which have now come up. Suppose this patient has got a Frisberg score, which we can calculate depending upon his age and his albumin status. But for this patient, I think anything which is more than 13, MELD which is more than 30, and if we can do a lactate level also. The lactate is also high, which patient is on inotropic support, then it means this patient is a very bad candidate for the tips.
Sharath, anything you want to say?
Yeah, I think this is an acute worsening. So more than the score now, I would also be interested in what was the MELD score and what was the child score when it all started. So this may not be a true reflection in terms of
child was 10, I think MELD was 22 when it started.
So I think in an elective setting, you take a cutoff of 20, but this is a setting where the expansive portal vein thrombus is contributing. Your patient is bleeding. I think up to 13, you're generally okay in an acute setting where bleed is dominating the picture.
Right. So I agree with you that, and Praveen, that I think any score you take, he is not going to fit into any score. So there are various scores, the CTB score, MELD score, the FIPS score, various scores have been devised. He's beyond all scores clearly. And this is just, and this is a recent MOT score, which is a predictor of mortality within 90 days of tips, which involves INR, urea, and bilirubin. So he's way beyond any of these scores because of the acute event. So we had long discussion. Obviously, one option was to not do anything, which was hardly an option because this is a guy who was just dying in front of us. So we had a discussion with the family, with Dr. Bajal, us, and we decided that we will go ahead with explaining to the family the high risk of the PVR tips, the procedure per se, the decompensation after that. And obviously he had a donor ready, so the plan was that we do a tips and we will subsequently do a transplant on him. And so we did a tips with a MELD of 35 and a CTP score of 12. Dr. Bajal, you want to, these are the videos of his,
so I
anything
think
you want?
he was specially bad because we couldn't show all the images in detail, but he had a SMV thrombosis which was quite extensive. So he has only one outflow vein, which was the superior most jejunal vein. That superior most jejunal vein was the outflow of his entire gut, and right from the top of that, where it would enter the the top of the SMV was the coronary vein, which was the collateral that was still supplying the varices. So we didn't even have an option of a splenic pulp embolization, which sometimes we would do to try and just reduce the portal venous outflow. So even that was not fitting. So what we did was we did this PVR tips, where you can see the important thing about this is that the tips has to finish high up in the portal vein. We did an extensive angioplasty, we did mechanical thrombectomy, we did aspiration thrombectomy, we did thrombolysis down the SMV and the splenic. Luckily for this patient, we did not require a transsplenic access, but we were obviously ready for it. And after completing the tips, we went up that collateral, that coronary vein, which Zubin was alluding to, and glued it on our way out.
I just ask you a quick question. So when you're dealing with such a high clot burden, what are the chances that you have a channel and some of it might embolize into the lungs?
So that's what we did. So we did a mechanical clearance as well. And after doing a mechanical clearance, we then cleaned out and sucked out whatever was movable. Then we've got to let it flow. It's very akin to how dialysis grafts are cleaned. So when these big PTFE dialysis grafts in the limbs are cleaned, all we do is we just pull a balloon across, and all that shower goes into the lung fragments and goes into the pulmonary periphery and lyses out. So it's the same concept that applied here.
Sir, in this setting, in case there are large collaterals around the portal vein which is thrombosed, would you do you think collateral tips might actually work or not? I'm not sure of this thing.
I know. So collateral tips is okay if you have the collaterals extending into the dominant outflow collaterals in the abdomen. But the problem here is that we also have to mature this portal vein. This guy is not going to survive only on the tips, like you all have just alluded to. He's a high mortality even after tips, to the extent that Praveen mentioned futility of tips. So we've got to get him eligible for transplant.
So, talking of collateral, yeah.
I agree with Dr. Sharath that when we are talking of worsening of the scores after an acute event, unless you prevent that event, the scores will not improve.
True.
So we should not be, in fact, multiple blood transfusions, loss of blood causing hypoalbuminemia, transfusions causing increased bilirubin load, scores will keep on worsening.
Exactly.
So I think our emphasis on the later scores after the event should not be that much as it should be the previous score before the event started.
Yeah,
for deciding our therapy.
Yeah, I totally agree with you, and that's why we went ahead and we did the tips.
Most of the time, if you are doing a rescue tips or we are doing a salvage tips, most of the time the patient will be like this one, because they will have a high score, they are poor candidate. Before this patient is probably lucky because he has got a donor, and probably we can think of that patient will probably prolong to the extent that we can do a bridge. But most of the patients who do not have a donor, and doing such type of tips in that emergency setting, one needs to be 100% sure that he understands the fact that this could probably a futile
Yeah, I think
later on.
Our main, the confidence level was that we can possibly at least transplant him soon after the tips. So this patient, this all happened in the last few days. This patient is still admitted, and today is day 5 after the PVR tips. His bilirubin is 22.5. His creatinine is almost the same, 1.9. His INR has come down a little bit. He is in early encephalopathy. The ascites is obviously decreased. There is no bleed now. He's on a small dose of NORAD. There is no obvious sepsis. And we did, because his bilirubin was mounting and his INR had gone up to 5 actually. So we did one session of plasma separation and heme adsorption. So not exactly plasma exchange, but more of a plasma filter. So now coming to the question. So Dr. Ravi, being a surgeon, like what is the ideal duration for which you should wait after doing a PVR tips for transplant? So can you do a PVR tips and transplant him the next day or a week or a month? How long do you wait?
So this is an acute setting. So this patient, you have done a tips, you have established the portal flow, and now he is not septic. His parameters are improving. So if you get a good window where if possible to go ahead with the transplant, because you don't want him to have some sepsis and then later, other problems starting. So I think for this patient, I would plan the transplant now. But in otherwise, if you are, elective tips, elective portal vein cannulation, recanalization, PVR tips if you are doing, then you can wait, you can anticoagulate, you can wait, and when the patient is stable, then plan this transplantation.
Yeah, so I think the ideal is what we follow is waiting for about 4 weeks. So in this, again, we had a team meeting. Prashant is here, and I think we had decided that we'll do him early, I think within a week. And Prashant, you want to say anything?
Yeah, I think there's a slight difference of thought here. So what do you mean by you've done a PVR tips? You've done a PVR tips means you've gone across the thrombus, you've tried to get off as much thrombus as possible. It does not mean that you have re-established the inflow and the outflow of the gut. See, what happens in these patients is ultimately what kills them in the post-operative period, even if you were to get a portal inflow, his SMV is blocked. Like Dr. Bajal said, the only place from where actually the bowel is draining is one superiormost branch of the jejunal, which is draining out. If you do not relieve the mesenteric congestion pre-operatively, before the transplant, your graft is going to fail. Post-operatively, you are going to have massive bleeding. You are going to have intestinal ischemia also, because now most of your blood is going to go towards the liver once you open up the portal vein. So the problem is that in 1 week, that does not get sorted out. Your SMV doesn't open up completely. Your portal vein is not that sort of a flow where it is endothelialized and you actually get flow ahead. So you may temporarily think that you will be able to establish portal vein inflow, but it actually does not happen. So in this situation also, I'm not sure, because there have been instances where we've had to redilate the pre-existing PVR tips. There have been situations where we have had to go in, extract clots and again do it. So it's not that just once you do a tips, your flow is established. It takes some time. I understand your point that this is an acute situation, but I'm still not confident unless Dr. Bajal does another run and sees if the SMV is still draining, if you've got a patency with hepatopetal flow rather than hepatofugal flow, and only then maybe. So maybe not 4 weeks, 6 weeks, but I would at least wait for 2 weeks to actually see whether this works.
And for the maturity of the tract, I think you need some time for that.
Can I just make a quick point, Neeraj? Anticoagulants and tips are comparable when it comes to clot dissolution or establishing flow. So I think the point that Prashant is making, looking back at the CT, the clot was expanding the portal vein. I'm assuming this was an acute clot, in which case it is more likely to be responsive to anticoagulants. So if you want your jejunal flow and everything else to be established, you might want to give it those 2-3 weeks.
Yeah, he is on heparin. So despite all the bleeds and everything, we had to obviously
once you put your stent and you start getting some forward flow, your clot resolution is going to be that much better.
Yeah, sir, you want to make a point?
Yeah, this patient decompensated, acutely decompensated because of PVT. So presently portal vein flow has been re-established. So where is the urgency? Maybe he will recompensate to some extent. Because if you
so that's the tricky part. I mean, you obviously want to wait a certain time, but the way his bilirubin is now 24. So this bilirubin is going up. His INR went up to 5.6. This is artificially lowered INR of 3.4, the one I'm showing you. So with a bilirubin of 25, INR of 5, creatinine of 2, early encephalopathy, inotropes, I don't think he's going to really last too long.
Because he's a high-risk case as per surgeon also.
But then the point is, just transplanting him is not the plan. You have to give him some kind of outcome after transplant. And like Prashant said, if you transplant him now, probably the outcome after transplant is going to be bad. So we are in a tricky situation.
Yeah, it's a very tricky situation. The window, we have to observe him daily and see when is the right window for him.
So that's what we are doing, trying to stabilize him, maybe wait long enough.
It's not too early, it's not too late also.
We'll see
I think what
how things go.
Prashant said, so in this situation, observe for a right window and then go in for a transplant.
Yeah, so that's the plan. I think I'll end now. The time is also up, and since I'm the organizer, I'm not allowed to shoot time. So thank you.
Maybe we can have 5 minutes of Q&A. Dr. Gokham is online for the question and answer session.
Well, can I
Just
ask
one
a
or two
question? Can I ask a question to Neeraj? But didn't you expect that this patient will deteriorate after TIPS? Because it's very well known in patients with TIPS, right? With a MELD of something 30 and CTP of 13, more than 13, the deterioration of liver function invariably will occur.
Yeah, it was expected, sir.
It was expected.
Yeah, but we had no choice, and we thought that if we can just sort of keep him alive for 7-10 days, then transplant him. So that was the plan.
And I will ask Dr. Baijal, did you find it is acute thrombus which has actually precipitated this deterioration and bleed, or it was a chronic thrombus with collaterals? And is there a difference of recanalization of portal vein in such situation? I'm not clear about that because we didn't discuss about that.
So in this patient, there were no large collaterals which we can see. There was not too much of cavernomatous change around the thrombosed portal vein, by which we can infer that this was a relatively newer and recent portal vein thrombus, which definitely, like you said, gives us a higher chance of recanalizing assisted mechanically as well as with pharmacotherapy. There's no doubting that. But having said that, whenever we've done aggressive work inside portal, in any vascular system, we clean it on one end, but we could also damage endothelium with our balloons and with our materials. So it's not a great idea to get these patients onto surgery and then the surgeons are stuck in the OT. So after we've mechanically cleared, the thrombolytics would clean out the portal veins, and then hopefully so from our data, if you see, the preferred waiting period is at least 4 to 6 weeks basis whatever publications exist in PVR tips. But I think the simple logic is that for a specific patient, extend and delay the surgery as much as you can.
That is a very important point, because what Neeraj showed in the first CT scan, cirrhosis was there. There was thrombus in the portal vein, one can see that, but there are no collaterals around, jump collaterals around that. And in that case, should you have started anticoagulation right away there? That was my question. I was thinking about that.
So
and would that have helped in preventing this bleed and these complications?
He was
retrospectively
bleeding.
maybe, but with the large varices he had with red color signs and everything, I don't think.
Wasn't he actively bleeding when he came?
No, he wasn't bleeding when he came.
That is not a contraindication of starting anticoagulation of acute portal vein thrombosis, even if the bleed. Because studies has not shown that it increased risk of bleeding. Rather, it is recommended. Because when I saw that, I thought that what you would have done.
I think
maybe.
Sir, studies also recommend that if you have high-risk varices with low platelets, that's a difficult area. You can't, you may not be able to start anticoagulation.
Hi, Doctor. That was individual cases, but invariably in such a patient who has a very small liver, you see, he is all out of his side. He is acute thrombosis. With high-grade varices, we have already seen. And even acute portal vein thrombosis, the risk of bleeding is high.
So I'm not sure if we can really call it acute. Maybe it wasn't, yeah.
Dr.
Maybe
Gokhan, hi.
Subacute or.
Hi, Dr. Gokhan. So, what will you use as anticoagulation in such sick patients? Child C, high MELD. So, what agent will you use?
Hi. So the safest way to anticoagulate this patient is, of course, low molecular weight heparin. Both in form of like any emergency development, the reversal of low molecular weight heparin is easier in shorter time. And although new data emerge with the use of apixaban, especially DOACs in some patients, but definitely we should wait for more randomized control trials to be solid on this recommendation.
In patients with partial thrombosis, more than 50% of portal vein is stable CLD. Any platelet cutoff below which you will not use any anticoagulation?
It's a very nice question. In the past, we were more reluctant to use the anticoagulants below 50,000 cutoff. But we know in our daily experience, many patients are already in hypersplenism and they are not too much prone to bleeding even in lower platelet levels. But it's not evidence-based. It's only like a expert recommendation maybe.
Thank you.
So one last question from Dr. Prashant, and then we end up.
Yeah, okay. Yokan, hi, Prashant here. So
Hey.
again, I just wanted to catch you on that point of low molecular weight heparin. So if you have a patient who comes to you with not a very chronic, but a subacute type of, portal vein thrombus, and I find that this is a change in this 2025 AGA guidelines that you've shown us, because till now we were meant to believe that how would you start low molecular weight heparin? Would you admit these patients or start it at OPD level? Because I think even if it was 50% of portal vein thrombosis in a cirrhotic patient who could tolerate it, we were still thinking of DOACs. And in fact, we just started using that 2 years back, and now we are going to low molecular weight heparin. So correct me if I'm wrong, but I think this is a slight change, right, as compared to what we were thinking all this time?
Yeah, so in this patient, directly we should start the low molecular weight in a therapeutic dose, not like a prophylactic dose. And even if the patient is hemodynamically stable, in right after controlling the variceal bleeding, if he or she has, we shouldn't wait too long to start the anticoagulant. So in my routine daily practice, of course, it's difficult to decide. You have a double-edged sword at your hands. But the most important thing, the most of the, although low level of evidence, the evidence comes showing the anticoagulants will work in these patients in the long run if he or she has especially a transplantable profile. We shouldn't hesitate.
Yeah, thanks.
So if the patient has got large varices with the red signs, should you eradicate the varices first or start the anticoagulation?
If the patient is coming to you with bleeding, we should first control the bleeding. But if it's not bleeding, according to the latest, Boveno and AGA guidance, you shouldn't wait too long. It's of course it's controversial. It's difficult to say, but you should start the anticoagulant even without eradicating the varice in this patient.
So thrombosis takes priority over the eradication of varices.
Yes, because there will be a very rapid, recanalization in some patients that help control the varice, and that will prevent the bleeding in such a case.
So chances of bleeding will increase or decrease after you start the anticoagulants?
This is another controversial issue. Of course, the recommendations or suggestions I make here are not too robust. I should remind you again. But if the patient has an acute or maybe a subacute thrombus, we should think that the varice here develops mostly because of this hemodynamic compromise due to thrombus, and we should try we should start the anticoagulant as rapid as possible in such a case.
I think we need to end up over here. We are running ahead of time. I would like to thank all the speakers and panelists to join us for the photograph over here.
Thank you.
Thank you.
Moving ahead with our next session on management of hepatocellular carcinoma, I would like to call our moderators, Dr. Amitava Goswami, Dr. P.K. Agarwal, and the expert discussants, Dr. Ashish Kumar, Dr. Joy Varghese, Dr. S.K. Acharya, and Dr. Sunil Tadish on the right hand of the desk. For the session lecture, our speaker is Dr. Sherry Buri, who will be speaking on combining and sequencing multimodality therapy in intermediate stage SCC and BCLC-B.
So speaker is well on time, huh? Dr. Sherry is here well on time to
Right,
speak
on time.
about.
I'm ready.
Yeah.
So I'm back, so bear with me, please. This is the title of this second lecture. Actually, lots have been said and done on this particular topic in the last year, so I would like to give you the update of this last year and show you what the effect of this strategy is on curative intense therapies. Okay, I would like to start with this slide. This slide is quite old. It goes back to 2012. But considering that HCC followed the mainstream of immunotherapy quite late, this is still true for hepatocellular carcinoma. And that means that the objective response rate is low. This is despite the positive trials. You see here all the 4 positive trials we have. And again, if you see the purple line, the objective response rate is not higher than 35%. That means that most of the patients do not respond, and this means they've got a primary resistance, or if they respond, they may develop a secondary resistance. That means stop responding. The mechanisms behind resistance are still very poorly known. We know that there are 2 main actors. The first actor is the tumoral cell, that means with its genetic and epigenetic changes, and the tumor microenvironment, which is a very complex interaction of communication network between immunocompetent cells, between stromal tissue, and between molecular mediators. It has a very intertwined connection. It has a multi-directional interaction, and these interactions determine whether the tumor microenvironment is friend or foe of our immunotherapy. Now, you should know that the HCC microenvironment is intrinsically resistant to immunotherapy. Why? Because the liver is actually an organ which is very, very tolerant. It has to be tolerant against all the antigens it receives from the gut. And that means that it has an immunosuppression and a natural immunosuppression. And this means that immunosuppression is something that favors tumor progression. In addition to this, we have other several characteristics, like, for example, chronic inflammation. We have a cirrhotic background, and this favors tumor progression. Now, the convergence of all these features and other natural features of HCC determine HCC as a cold tumor. Cold tumor means that it has a low T cell infiltration, it has low expression of interferon gamma, it has low expression of PD-1 expression, and these are all features that are instead present in hot tumors and that allow a very good response to immunotherapy. Not just this, but cold tumors reduce the capability of tumor antigen presentation, and this somehow blunts the activation of the immune cascade, and I'll show you in the next slides. What has this got to do with the title of this presentation? Very much so. And I'll show you that there is evidence that shows that combining immunotherapy with local regional treatments has a synergistic effect. I will show you that we do not just increase the number of patients, but we increase the depth of the response, and we are able to forward to curative intent patients we didn't ever think of transplanting or resecting. And I'll show you the results, preliminary results of the ImmuneXXL study, which have been presented at the last EASL HCC meeting, which is the trial we are conducting in Milan, transplanting patients after the combination of immunotherapy and locoregional treatments. Let's start with the first point, combining locoregional treatments and systemic therapies. We all know that whatever kind of tumor destruction, physical, chemical, thermal destruction, releases tumor antigens and somehow modifies the tumor microenvironment. What happens when we release more tumor antigens? You can see it here. Very briefly, the tumor antigens connects with the antigen-presenting cells. It goes inside the lymphoid structure. It activates the anti-tumor immune system. And all these immune competent cells can be further enhanced by adding on immunotherapy. That means that locoregional therapies produce neoantigens, and neoantigens are the feature that activate the anti-tumor immune cascade. We note that this is true for TACE. This is quite an old paper that shows that after TACE we have an increase of immune competent cells which are anti-tumor. And we know this also for radioembolization. We had quite some evidence for this. This is a paper we published. It's an immunomonitoring of approximately 50 patients after radioembolization. You can see it here from this pink line. Immediately after radioembolization, we have a significant increase of CD3 cells, which are CD4 and CD8, the T effector anti-tumor cells. And this spike decreases in the first month due to exhaustion. We know that these T cells are anti-tumor cells, but we also know that they get exhausted quite quickly. These are all the trials which are ongoing. There's many trials combining immunotherapies together with various locoregional treatments, TACE, radioembolization, electroporation, radiofrequency ablation. There are very many studies. We have now the preliminary results of 2 of them, both combining systemic therapies with TACE. This is the EMERALD-1 study. The primary objective, which was progression-free survival, is superior than the comparison arm. And this is a trial combining TACE plus durvalumab, which is an anti-PD-L1, and bevacizumab. And we have also the results of the LEAP-012, which is combining pembrolizumab plus TACE plus lenvatinib. Both are positive for what regards progression-free survival, but we don't know yet what's the results of these trials on OS. Anyway, we don't know what the exact combination is. Locoregional therapy plus immunotherapy, immunotherapy plus locoregional treatments together with an interval between them, we still don't know. What we know is that the various trials which are ongoing will give us an exact answer of whether this is truly a synergistic effect or whether it's just a merely additive effect. For example, the EMERALD-1 was a sequential pattern. That means locoregional treatment to free tumoral antigens and then immunotherapy. We have the NIVOLEP study, which is an interrupted study. That means immunotherapy, pause, locoregional treatment, and then again immunotherapy. Nothing is really concomitant. As you can see, there is always an interval, except in the continuous pattern, where we actually have together immunotherapy with on-demand locoregional therapies. Now, if we do have an interval, we of course reduce the probability of adverse events, but we actually do not catch what a simultaneous therapy is. But as I said before, all the results will give us answer while we go on. Last point, the results of the ImmuneXXL study, just to show you what we are trying to do in Milan. Now, first of all, I would like to say that the very recent EASL guidelines have been a very important change in the treatment algorithm of HCC. Why? Because finally, Europe has disattached itself from the BCLC guidelines. First, it was one stage, one treatment, one standalone treatment. Now in Europe, finally, this has changed, and the BCLC staging is just a staging treatment. What is suggested in the guidelines is that you should treat your tumor in whatever way, of course, respecting liver function, in order to try to perform a curative treatment in the BCLC-A stage and try to perform tumor control in the BCLC-B and C stages. And if the tumor control is done with combination treatments, and you see it here, and you manage to have a significant response, then this patient can be forwarded to a curative intent. This is a milestone change in the guidelines, at least in Europe. Because this means that if you treat with a curative intent, with local regional treatments and systemic therapy and whatever you want, you may have a downstaging to liver transplant. If you treat with a tumor control intent, with a palliative intent, but you have an exceptional downstaging, that is called super downstaging or conversion therapy. And that may allow to forward patients you would never think of forwarding to liver transplantation before. Having said this, conversion therapies, combinations, what we are witnessing today are several trials that are trying to transplant patients after immunotherapy. It seems as though all the attention is focused on immunotherapy, but actually all patients treated with immunotherapy come from previous local regional treatments. This means that if you think that the results of these studies are mainly focused on immunotherapy, you're wrong, because as I said before, they are patients treated before with local regional treatments. This is the study we performed in Milan. It's a prospective study. We just followed all the patients treated with immunotherapy. We had 49 patients treated with immunotherapy without extrahepatic spread, with no hepatic and vena cava invasion, and these patients could have PVT, of course, discussed within the multidisciplinary board. We had 49 of these patients. These patients underwent minimum 4 cycles of immunotherapy, and we captured the patients that did have a downstaging, an effective super downstaging. So as I said before, these were the patients included. We also had, and thanks to the information we received from the Medanta friends, we also included patients with portal vein thrombosis, and with a branch also invasion of the hepatic vein. And this was the endpoint, downstaging. And downstaging had to be a survival of at least 60% on the metro ticket calculator, a PVT of less than VP2, and less than 100 of AFP. If these criteria were respected, these patients were evaluated for liver transplant. We had 26 of these patients. 16 were forwarded to liver transplantations, and 10, for various reasons, were not transplanted. Okay, these are the 16 patients that we forwarded to liver transplantation. Just look, 12 out of 16 were treated with combination therapies. That means with TACE, Y90, or both before immunotherapy. 12 out of 16, 94%. Not just in this series, but also in other retrospective series in literature. Approximately 95% of patients apparently treated with immunotherapy before liver transplant are actually treated with combo therapies. And this is the result. Actually, look on the left-hand side of this slide. This is the reduction we had with local regional treatments. As you can see, some of them had a significant decrease, some of them had a stable disease, but combining together local regional treatments and immunotherapy, we had the significant reduction in the tumor bulk that allow us to achieve a super downstaging. 12 patients achieved a complete response, and we had quite a good correlation with histology. Have a look at what happened to the patients with PVT. Now, as you can see here, after ICI, we had practically all complete responses, or we had significant downstaging. These are the results of a 16-month follow-up of this patient, median 16 months. We had 1 death for complications and 1 HCC recurrence. Consider that these patients could not be transplanted upfront. As I said before, for what regards safety, we had a 50% of major complications. These patients are patients within a trial, so they are complicated patients, pre-treated, not exactly optimal grafts, so we had major complications. And we had one death, which was a graft failure together with rejection. We had 4 rejections which were treated with bolus of steroids and which completely regained their function. We also, probably not appropriately, compared the PFS of the patients we transplanted with the 10 patients which were not transplanted. I know this is not methodologically correct, but just to show once again the strength of liver transplantation as a curative treatment. One last message: if we go and see the flow of the T cells, we did an immunomonitoring, which was the main endpoint of our study, and enriched the information we had from the study. If we see the flow of the T cells after transplantation, we can see that after transplantation, the T cells increase. These are anti-tumor cells, and they increase at levels which were even higher than the levels we had during immunotherapy, stopping immunotherapy much before liver transplantation. And this was confirmed by this heat map, where you see actually the gene signatures of various proteins associated to T cell activation. And you can see that the T cells activation gets activated going far from liver transplant. So these T cells are actually anti-cancer cells. We know this because the ELISpot that we have shows that they have an antiviral effect, and they have also an antiviral effect, but they also have an anti-cancer effect. You all know that T cells are also responsible for graft rejection. So what we will envision for the next future will be patients probably with a very good tumor control, but probably with a high risk of low graft tolerance. I would like to end showing you one of these patients, patient number 10. He came to us with this tumor. He had a metro ticket survival of less than 25%. He underwent radioembolization. On the left, you find the result of, on the right, you find the result after radioembolization. Of course, he had radioembolization in the right hepatic vein, which treated the right lobe and parts of the fourth segment. And with this CT scan, he underwent 7 cycles of immunotherapy. And on the right, you see the result after immunotherapy. Just to close this talk and show you, this was the result of histology. At histology, we found very big tumor, 9-centimeter tumor, but the important thing was that the only vital tumor at histology was big 1.8 centimeters. All the rest was necrosis. And the maximum necrosis we achieved was 95%. That means that also at histology, we confirmed super downstaging. These are my conclusions. In downstaging, whatever treatment is allowed, as long as respecting liver function and having precise stopping rules in order not to compromise liver function. All patients with extended tumor burden within the liver deserve to be treated, first of all for tumor control, and in case of exceptional response, considered for curative treatments. Radioembolization or local regional treatments are part of this multimodal treatment proposal, which is finally present in the BCLC guidelines. And combining systemic therapies with TACE or with radioembolization is under investigation as a super downstaging process, and results should be interpreted as such and not just as immunotherapy pre-liver transplantation. And thank you very much for your attention.
Thank you, Dr. Sherry. Please take the seat on the dais.
Thank you so much, ma'am. Kindly take your seat at the dais as a panelist. Now
Let's start with the next case here.
Clinical discussion on management of unresectable and advanced HCC. I would like to call our case moderators, Dr. Pallavi Garg and Dr. Kaushal Madan. And for panelists, I would like to call Dr. Manasa Allah, Dr. Sherry Budi, Dr. Rohit Mehtani, and Dr. Nagendra Sharma will be joining us in a while.
So, good evening everyone, and thanks to Neeraj and Medanta for inviting us for this wonderful meeting and this particular session. And we'll carry forward what Dr. Sherry just presented. I think we'll continue with the same theme. Our case will probably highlight what she has presented in her slides. So I think next 10 minutes will be between Pallavi and the panelists. I'll just be on the side.
Good evening, everyone. So we start with the case. We have 75 years male with a history of non-obstructive coronary artery disease since last 40 years, diabetic, hypertensive, found to have MASH-related compensated cirrhosis in 2021. He was doing well. His etiological workup was negative. His triple phase CT done showed no HCC. Somehow he lost to follow-up. He again came back to us in 2024. On examination, his BMI was 24, and per abdomen, the liver was palpable. We got the routine investigations done, which showed a platelet count of 1 lakh. His bilirubin was 1.1, albumin was 4. Endoscopy showed no varices. Interestingly, his AFP was very high. It was 3800 and a PEVCO of 3800. So we got a triple phase imaging done. This is his dynamic MRI, which shows a cirrhotic liver and a single large lesion of around 5.5 centimeter into 4 centimeters in segment 4, which there's an enhancement in the arterial phase and a washout in the delayed phase. So, and there was no portal vein thrombosis. So we thought if we can go ahead with the curative intent and resect it, so we got a PET scan done, which showed there was FDG avid lesion in the liver, single lesion, and no extrahepatic involvement. So here we have a patient of child status A with an ALB score of minus 2.56, performance status 0, BCLC intermediate, and modified NASL shows B2. Audience poll, what would you offer?
Can we have the audience poll? This is a question for the audience. So these are your options. So there's no right answer here. I think you may have different opinions, we may have different opinions, our experts may have different opinions. We just want to know what you feel about this. So what would you offer to this patient? Non-anatomical resection, liver transplantation, tear, systemic therapy with immunotherapy, or a combination? I think most of them want to offer liver transplantation or tear alone. You just heard Dr. Sherry that I think we have to move away from single therapy in a patient who is unresectable HCC and move towards combination. So let's see.
So taking the opinion from Dr. Rohit, our expert, what are the treatment options here, and do you routinely use albigrade to decide regarding the treatment?
So this patient has a cirrhotic liver with evidence of clinically significant portal hypertension based on non-invasive evaluation, which showed an LSM of 30, platelets are 110,000, so there is CSPH. So upfront resection I would not recommend, especially considering the age also. Second question about transplant, upfront transplant with an AFP of 3800, DCP of PIVCA of 3800, again we should not do it. It's an aggressive tumor, we should achieve downstaging and then only consider liver transplant. Since the size of the lesion is 5.5 centimeter, both TACE with ablation or immunotherapy would be a good option considering the availability and the cost in this case.
Right. So the expert has rejected the most common options from the audience.
So the options offered by the treating units were local regional therapy in the form of tear or TACE and non-anatomical resection if it was feasible.
So I think we referred this patient to our liver transplant surgeons, and I think like Dr. Rohit also said, there was clinically significant portal hypertension and the surgeons felt that the residual liver would not be sufficient. So surgery was again rejected, and we offered this patient underwent tear after this. So he also talked about TACE. What about the issue is you have a patient who you can TACE also, whom you can tear also. So what is the data regarding TACE versus tear in a TACEable lesion? So a meta-analysis of 17 studies, more than 2,400 patients, although the time to progression was in favor of tear, but there was no effect on overall survival. But if you ask Dr. Bajal, who's sitting here, he'll tell you that this was done in an era when low-dose radiotherapy was being delivered by tear. Nowadays, they are using a process called partition modeling, where they give a personalized dosimetry with a minimum dose of almost 270 to 330 grays to the tumor and less than 120 grays to the residual liver. So comparing that with the standard dosimetry, you can see that the overall survival was significantly better if you deliver higher doses, and more number of patients could be downstage using this form of therapy with a longer overall survival. So I think we have also moved, and I think most centers which have been using a regular TARE have moved on from standard dosing to personalized dosing. Maybe the results would be better if we compare patients who undergo TACE versus TARE now. So regarding the ALB score, I think we all, yeah.
So ALB score we use specially in patients with CTP-A liver status. So it was devised for patients with in the early cirrhotic group as they predict prognosis better, because they remove the clinical features like ascites and encephalopathy. So in patients with child class A, ALB score is a better predictor of prognosis and survival than the CTP score. So it should be used in early cirrhotics. When we are planning treatment, those with a higher ALB grade should be considered for a less invasive therapies.
Right. And I would even go a step further and say that even in child's B, if you are contemplating loco-regional therapy, possibly LB gives you a better discrimination. So this particular study, in which the mean CTP score was 9.2, 66% patient had ascites, 58% had HE. They underwent TACE, 13% developed post-procedure ACLF, and ALB score was a better discriminant and not CTP score in determining which patient will develop ACLF after TACE. And they even defined a cutoff of minus 1.39 to predict this outcome. So,
Kaushal, can I ask one thing here in between?
Yeah, please.
In this case, did you go for TARE or did you go for TACE?
That's what I'm saying. Yeah. So we did for TARE with partition modeling with high dosimetry. So, and we'll build up the case as we go along.
Coming to Dr. Mansa, what would be your next plan? Just follow up, or will you add on some adjuvant therapy?
So in this patient with a tumor size of more than 5 centimeters and with a high AFP value, TARE was done, and I would assess the response at 8 to 12 weeks and also look at the AFP values. But I would also consider adding an adjuvant therapy in the form of lenvatinib, because this would be categorized under a tumor with high risk of recurrence with a high tumor burden. And coming to the choice of therapy for adjuvant, as Dr. Sherry pointed out, the trials on immunotherapy are still ongoing and the results are awaited. So at this point of time, with the current evidence, I would consider lenvatinib starting with a low dose and then dose escalation. However, the available literature is currently only on BCLC-C tumors rather than BCLC-B. But however, I would add lenvatinib for this.
Right. So we completely agree with you. We did exactly the same. We started him on lenvatinib, low dose, that's 8 milligram. After 2 weeks post-TARE, his AFP and PIVCA showed a significant drop.
So I think we've already covered, Dr. Sherry did cover all this part of combining loco-regional therapy with systemic therapy. This is the data of TACE alone versus TACE plus lenvatinib, all retrospective data. Again, showing that patients in which a combination therapy was given was better than TACE alone. But again, like Dr. Mansa said, benefit mainly seen in BCLC-C stage. Dr. Sherry did talk about this particular study, Emerald-1, in which the early results are out. 3-arm study, TACE plus durvalumab plus bevacizumab, TACE plus durvalumab, TACE alone, that is TACE plus placebo. Large number of patients included, and yes, the progression-free survival was significantly better in the combination group as compared to TACE alone. So yes, possibly once we have these results, we possibly would be moving towards a stage where we would offer upfront combination therapy in these patients rather than a single therapy.
So moving to our case, a repeat MRI was done after 6 weeks, which showed that the lesion has decreased in size to up to around 3.4 centimeters, and it was all necrosis with no enhancement in the arterial phase. Probably this was too early to image and decide. So coming to the clinical course, the AFP and PIVCA showed a further decrease And however, after 6 weeks of therapy, the patient developed generalized weakness, hypophonia, and hoarseness of voice, along with shortness of breath. We took ENT consultation for all this, and the cords were normal. So what we did was we reduced the lenvatinib to 4 mg once a day from 8 mg. So Dr. Nagendra, would you have combined immunotherapy after the tear? And is there any data to support this practice?
Right. So the whole purpose of combining this, the rationale is that whenever you are using a local therapy with systemic therapy, liver cancer itself is a immunogenic cancer, it's a highly vascularized organ. So whenever we are using the systemic therapy along with the local therapy, there is a PFS benefit, as you have clearly mentioned in the durvalumab plus DB. When we have used that, there is a leverage of nearly 6.8 months as compared to without durva plus the combination drugs. So point here is that whenever you are using it, it creates the environment which is conducive for immunotherapy to work. Only point here is that right now there is a paucity of data. As of now, there are some limited studies which are there in which atezolizumab is used, but the number of patients is very small. So we are up for it, but unless we are having complete evidence, we cannot recommend post here. We should monitor this patient with the lenvatinib, which you already did, and then we'll move forward.
May I just add a comment?
Can I add here? Yeah.
Yeah, Dr. Sherry, followed by Dr.
Sherry, yeah, please.
Ashish.
So unfortunately, in Europe, we can't add a TKI to local regional treatments because the previous studies, mainly the SPACE trial and the BRISK trial, were not positive. So we are not allowed to add lenvatinib. So you won't have ever any kind of evidence in order to combine these two treatments. The only study which did add lenva to TACE was the REFINE study, as you said before, but that was given to enhance the effect of the TK. Well, that was TACE given to enhance the effect of lenva in advanced stage patients. So this is actually a limitation. And the patient is 75, so I wouldn't actually have added on something else in order to evaluate them.
I think that's a very important point she's made, and I would ask other experts to also to dwell on this, because you've done a tear which you feel was sufficient and there was a good response. Was there a need to add lenvatinib? We did. Maybe we are wrong. I initially also said no one is wrong here. I think everyone has different opinions. So Ashish, you were making some point.
So what I was saying that we have very limited data on adding immunotherapy to tear. So Y90. So the cost also goes very high, but we have at least theoretical evidence that tear would make it, the tumor, cold tumor, much more responsive to immunotherapy, but so far the data is not there, the trials are not there, but it would be individual choice.
But I will also caution you that here you have a child, say, patient. You have used one effective agent and you have used more radiation than conventional 60 gray, which is more than, it's considered more than 60 gray is hepatotoxic, right? That is a conventional thing. Here you are using more than 130 grays to the radiation. That is number one. And if you add further immunotherapy, making him hot, there is also chance of deterioration. Here I will suggest he has clinically significant portal hypertension. I don't know what the professor from Italy will say. In such patient, deterioration of liver function can be prevented by a preemptive tips, right? Because there are many studies now. You see, you are trying to, because she suggested today, the effort is to treat with a curative intent. Every patient should be tried to be treated with curative intent, provided his liver function is good, his performance status is good. I'll be subsequently stratified, but if you are planning for a curative intent, even ALB is not very important, I will say. Because if you are providing a curative intent treatment, that should be kept in mind. So, because if you see there are multiple studies of preemptive tips in the tips in management of HCC when you are using such aggressive therapy, because that helps in liver function deterioration. That I will add to this.
I think he's made a very important point, and towards the end of the case we'll come to that issue. So like everyone said, very limited data of tear followed by immunotherapy, just a single arm, 10 patients, tear followed by atezolizumab, but it did lead to a significant progression-free survival of more than 70% at 12 months. But yes, we need to have more data on this.
So coming to our case again, tear and lenvatinib was started. The AFP was coming down, but suddenly 12 weeks after the procedure, when the repeat imaging was done, the size increased from 3.4 to 4.3 centimeter with some late arterial phase enhancement and washout seen in the delayed phase. The AFP also went up to 245 from 131. Dr. Sherry, what would you do here? And would you wait here or act?
It depends what your idea on this patient is. For example, in Italy, a 75-year-old patient is actually very difficult to transplant. So it depends on what part of the world you are, what availability you are. I think that what is said before is really very true. You should try and have a curative intent as the primary endpoint, if there is a response, of course.
Right, so there was a slight rise in alpha-fetoprotein and maybe some suggestion that there might be some residual disease. So does rising AFP suggest residual progressive disease? It's only 12 weeks after a effective tear. Would you want to wait more or would you want to act here? That's the question to all the experts actually.
I would wait. I would wait. I would be concerned about an increase in AFP.
Well, there is another condition. If there is a rise in AFP, AFP can also get rise if there is a metastasis to the other site, extrahepatic metastasis. Your primary liver tumor may be fine. But if you have, from the lower AFP, you have seen a rise in AFP, and that's another consideration, I will keep it at least in the mind.
And maybe some regenerative activity also. I'm not sure. Maybe that is what is driving it. We are not
But
sure.
it's very unusual for a cirrhotic liver to have a regenerative activity. You have cirrhosis with high ALP, where the regenerative activity is going on. But once there is liver cancer, the big liver cancer, the duration of cirrhosis is long in such patient, right? Likely, clinically.
A very important point you've made.
So the patient discussed with family members and all, and somehow they were keen to go for CyberKnife. So they went to Chennai and got the CyberKnife SBRT done, plus immunotherapy was started in Chennai with a single agent atezo, and patient received 3 cycles. 2 to 3 weeks after the 3rd cycle, he developed a urinary tract infection and dry cough. These were his liver function tests at that time.
So like you are wondering, we were also wondering why did he do that, but there are a lot of pressure in India from various family members and known to doctors who basically suggest them that why don't you try this therapy, why don't you try that. So he was lost to follow up and he decided to go and take this therapy. So Dr. Nagendra, is there science behind combining immunotherapy with CyberKnife or radiotherapy?
So the point here is that when we are using radiation therapy, SBRT, we are actually creating the state which is conducive for the immunotherapy to work, right? So in the tumor microenvironment, as we have seen that the trials which are there in the metastatic setting also, the atezolizumab, AMBRAVE trial, that now we have new AP and the steroid regimens also. So when we are using like especially SBRT to the portal vein especially, so it is creating a state in which it is making it, there is a abscopal effect is there, because of which you are having a anti-tumor activity. There is a reactive T cells will be created towards that site, and that will cause the immunotherapy drugs to work. So that's why it is driven by enhancing the immunological responses, and it is also depicted in the murine studies also, and that's why that's the rationale behind it.
Right. So, but are there data? So that again, small number of patients, recent data, radiotherapy received before or during immunotherapy. I didn't know about why the radiotherapist in Chennai planned to give atezolizumab single agent along with radiotherapy. So this was the data of nivolumab versus nivolumab plus radiotherapy in patients with HCC, and patients who received a combination therapy had a better PFS and overall survival. Subsequently, more data on this presented last year of radiotherapy combining immunotherapy. Again, TKI, anti-PD-1 plus SBRT, better overall survival as compared to TKI plus anti-PD-1 alone. Another study of sequential therapy, single arm, TACE followed by SBRT followed by immunotherapy, something akin to our patient, but our patient received TARE instead. So 64% patient had macrovascular invasion to begin with, and they were able to achieve a median overall survival of 30 months. But interestingly, 55% patients could be downstage to a stage where they were offered curative forms of treatment, something which Dr. Sherry also highlighted.
So after 3 doses of atezo, he developed severe shortness of breath and cough. He went to a pulmonologist who diagnosed him with interstitial lung disease, probably immunotherapy induced, and started him on steroids. Presently, the patient is stable on a very low dose of steroids. So Dr. Sherry, Dr. Nagender, how frequently do you come across immune-mediated adverse events with immunotherapy? And what kind of such adverse events do you frequently encounter?
As we know that this immunotherapy causes autoimmune side effects. So autoimmune pneumonitis, autoimmune hypophysitis, sometimes autoimmune hypothyroidism or hypothyroidism also we have seen. So all these patients we always monitor upfront only when we are starting. The serum cortisol level, the urine for micromegaluria, the free T3, T4, TSH, thyroid profile, and ACTH level, and monitor it more closely if the patient is dwelling with that. And if at all grade 3 or grade 4 side effects are there, we have to use a cross-consultation from other departments, and we have to take opinion for the tapering dose of steroids we have to use. And if it's grade 1, grade 2, we can re-challenge, but if it's grade 3 and grade 4, it's better to stop it altogether.
Right. Dr. Sherry, in your trial, the one you presented in XXL study, how many immune-mediated adverse events did you?
Well, the concern there was actually the rejection rate, because that's a particular population and those were transplanted patients. We didn't have any immune-related events aside from those 4 rejections, and that one death that was borderline between a graft rejection and primary non-function. For what regards NSAID patients in the pre-transplant setting, we have a very, very low rate of immune-related adverse events. My experience is mainly just on atezolizumab. And the most important, the most serious adverse events we have are endocrine adverse events.
So Dr. Nagender, you've been treating other cancers also with immunotherapy. Do you find any difference, I mean, in terms of liver enzyme derangement, in terms of autoimmune hepatitis-like picture, in HCC patient vis-a-vis non-liver cancer patients?
Right. So sometimes it's very, very difficult for us to find out whether it's an autoimmune hepatitis which is setting in, or it is the liver cirrhosis which is there, which is causing the derangement of LFT. So we require the test to be done periodically. We have to check that, and then we should be very sure that if it is autoimmune hepatitis, then we should use steroids. Otherwise, if it is a derangement because of the liver functions, we can manage.
So question to you as well as all panelists. Maybe you can answer, Dr. Acharya, this particular question. Do you biopsy when the liver enzymes get deranged? Do you biopsy to find out whether it's autoimmune phenomena which is causing this?
Well, no, mostly we don't. But I want, before I answer that, I want to ask you particularly. There are various immune checkpoint inhibitors which are used. We know durvalumab, tremelimumab, nivolumab, atezolizumab, and most frequently used is nivolumab. And in clinical practice, I personally have seen nivolumab-induced autoimmune hepatitis more often than any other agent. What is your comment? Because nivolumab is also used for metastatic cancer, various other metastatic cancer, right? And patients comes to us with severe autoimmune liver dysfunctions. Whereas in comparison to that, other immunotherapies do not cause. Is it right?
So only thing is that there are some nearly 18 indications of nivolumab in oncology, in which one is liver cancer. Now we are having a checkmate 8DW on which Nuvo plus ipilimumab is also used. But answering to your questions precisely, this immune-related side effects can, on a like person to person, we have to decide. It's not like that all the patients we can take a generalized
Or
statement.
since we have been using nivolumab since long, we are seeing it more.
No. There's a way.
But to answer your question, Kausav, whether we will do a liver biopsy in such a patient to decide whether it is an autoimmune hepatitis because drug induced, well, I will probably, without doing a liver biopsy, exclude other causes.
And start steroids.
And start steroids.
Right.
And see the response.
And just to answer your question, it's mainly a combination of CTLA4 and PD1 which is associated with maximum immune-mediated side effects. So that means tremelimumab, once that gets introduced in the market or we start using it more, maybe we'll see it more.
So no fresh changes after 6 months, but however the lab showed a low albumin of 2.73, ultrasound showed moderate ascites, and he had repeated bouts of hyponatremia with a sodium of 125 and He. So the repeat AFP done 24 weeks later showed slightly high AFP of 259. We added lenvatinib in a dose of 4 milligrams here, and after 4 to 5 weeks the AFP dropped down to 100. So now the questions are, the patient has got intermittent hyponatremia, grade 2 ascites, severe fatigue, intermittent grade 1 to grade 2 He, and now he's in child B. So how, audience question?
I think the issue raised by Dr. Acharya of deteriorating liver function. So question to the audience before we move on. Neeraj, can we have 2-3 more minutes, because we have 20 minutes of discussion after this. So audience question, what can be done next? Liver transplantation. He talked about tips, repeated LVPs with albumin, or palliative care. He's 75 years old, he's deteriorating child's BC. Wow, everyone says, most of the people say palliative. So would the panelists agree with this?
Yes, we agree with the audience. At this point of time, with history of recurrent infections, deteriorating liver functions, and various treatment-related adverse effects, would consider palliative treatment and management of complications.
Kausal, I would have done a tips before I started all this. I told you
maybe
that.
you can do it.
Because struck.
Maybe you can do it now also.
Yes, because it improves your liver function, prevents deterioration. It has shown clearly to increase overall survival in such patients when you are giving aggressive therapy and directed therapy to the liver,
right,
which can deteriorate later
Only
on.
issue is at 75 years, higher risk of encephalopathy, that's all, but yes, it can be done.
Yeah, but he's having recurrent encephalopathy now. So now
I think
it
that
would
was
be-
related to, possibly related to hyponatremia.
You see, there are, by now, there will be 20 or 25 study. And there will be meta-analysis and systemic review, which I was seeing probably, I don't remember, I saw long back. And I was surprised to see that TIPS-induced hepatic encephalopathy varies from 2 to 20% in such studies. And total number of patients of HCC who has been subjected to TIPS before therapy, by now would have been 1,500 in the literature. And that is a very important thing. If you have clinical significant portal hypertension, there is a large patient's data in the literature. I cannot give you immediate references because somewhere long back I saw that, and there must have been much more literature that has been added recently also.
Still, before you go forward, can I ask you one thing here? This patient was lost to follow-up in between. He went to Chennai for other treatment. Was the patient not on lenvatinib? Because you said, Pallavi, just that, that was added in between 4 milligrams. So was there a window period in between,
Yes,
or the patient stopped on it?
He received SBRT and atezolizumab that time. So I think
just want to add here is
we have to move
that
on.
He's a 75-year-old gentleman. The ultimate aim in oncology is to keep these patients as good as possible for as long as possible with the limitation of science. The challenges which this patient faces, they are not only physical, they are emotional, they are psychological, they are spiritual, and above all, they are financial. We should take a shared decision making, what exactly he wants.
Right.
That will be the best decision for the
But
patient.
as hepatologists, we have one more tool in our armamentarium, that's liver transplantation. So can that be done? So that's a specific question to Dr. Mansa and Dr. Rohit. Would you consider transplant for this patient, 75-year-old gentleman, now decompensated, HCC under control?
So I would have the discussion for transplant before starting all this treatment. What is the goal of treatment? Whether the patient is ready for a transplant or not. Then we should plan the treatment accordingly. So probably if the patient was willing for transplant, we should have done the transplant. At the time his AFP had gone down to 130 before the subsequent rise at about 12 weeks after tear. There was a good response to tear, and that time we should have subjected the patient to the transplant.
So at that time he was
But can I ask you a question? Is there not a rule that waiting period before transplant? That is the point. Tumor behavior, post-transplant recurrence is an important event. And hence, following down staging, there must be a waiting period.
So we had 3 months after the tear, sir, 12 weeks.
Minimum, because within that, if your alpha-beta-protein are raised, that is an Achilles heel for post-transplant recurrence. So that is the point.
Just one question. What is the functional status of this 75-year-old? If you're thinking of liver transplant, any unit would want to do it is if he's completely active, he's looking after his work and he's walking.
So when we started
functional
treatment,
status has to be important.
when we started treatment, he was PST 0. So he was very well compensated, fully functional, doing his work, driving also. And even up to 1 or 2 months back, he was doing that. But now, due to recurrent episodes of hyponatremia, severe weakness, that has come down. I completely agree, but that can be reversed by transplant. So, liver transplant for the elderly, that is the question. Meta-analysis of 22 studies, both mortality as well as graft loss between 65 and less than 65 years age, similar. Another recent study, 322 transplants, small number of patients beyond 70 years of age, 20 patients. After excluding medical comorbidities, cardiac risk, and psychological barriers, patients who did undergo transplant beyond 70, the length of hospital stay, 1 year patient survival, 1 year graft survival was similar in the two groups. So I think we'll have more discussion later, but these are my take-home messages. I think everyone emphasizes on this, that multimodality treatment with multidisciplinary tumor board appears to be the way forward for managing unresectable HCC. But for that, all of us need to come together, which we don't. LB score is a better determinant of tolerance to therapy and the risk of developing post-loco-regional decompensation than CTP score alone. Combination of loco-regional therapies and systemic therapies offer better PFS and overall survival, but yes, we need to have more data from RCTs. Dr. Sherry pointed this out. The combinations may or may not be synergistic, but even if they are additive, you get a better response. Age more than 70 is not a contraindication for liver transplantation after you have excluded medical comorbidities and cardiac risk assessment. Thank you so much for a patient hearing, and I invite you to this forthcoming debates and controversies in liver diseases 2025 in conjunction with annual LTSI Con in November 2025. Thank you.
Thank you, Kaushal. We have a few minutes. Dr. Acharya, maybe you can, I'm here.
5 minutes more.
We have a few minutes for questions for Dr. Sherry's talk or for this case. Anyone from the audience? Or any comments from the experts?
Dr. Kaushal, see, whenever we are going to go for the loco-regional therapy, if there is a good response with the loco-regional therapy, if there is after that the tumor markers are increasing, we have to repeat the imaging. Imaging wise, there is activities there. We can again go ahead for the loco-regional therapy because that we are practicing and that shows the very good outcome. Actually, it's a palliative, one of the palliative therapy. And here this patient, the SBRT adding, so I have no much idea about the cyber knife, but the
He went to your city, he went to Chennai.
Chennai, but actually it's not in my center. But actually SBRT we are seeing a very good response. Not the cyber knife, we don't have the facility in our center, but the SBRT is very good actually. It's showing that's why it shows the good response. This and another I wish to ask, what about the outcome of the combination of the loco-regional therapy? Now we have a talk on loco-regional therapy with immunotherapy, but sometimes we will go for combination of the microwave ablation with the TACE, RFA with the TACE. So that shows also, the paper shows the good outcome.
Can I ask a question to Dr. Sherry? Actually, she presented very good data on 16, 17 patients who underwent liver transplantation after immunotherapy. So what was the washout period before liver transplantation? That was one question. And second, did you use radiotherapy, SBRT also in some of these patients to downstage, or only Y90 and TACE? And
we just use intraarterial treatments, that means TACE or radioembolization. In one patient, we actually used surgery before immunotherapy, and this is the second answer. The first answer is that in the trial that we designed, because it was a prospective trial, we actually wrote that we had to have at least 1 month of washout, because in our immunomonitoring, we saw that the T cell activity in that 1 month of washout reduced, and that meant that we didn't have a high risk of rejection. But unfortunately, what happens in liver transplant is that when the graft comes, and you have to take it. At least in Europe, we don't have a very high percentage of living donors. And this means that we had an interval that went from 7 days to 200 days. And we didn't have any particular correlation between rejection and waiting time, even though literature suggests at least 30 days of washout.
So even 7 days you had, just 7 days, no rejection.
Sherry, excellent talk. I think we discussed this at length in Chengdu 2 months back with Professor Mazzaferro and you, and we spoke about PVTT and downstaging with immunotherapy. You've done it in 6 patients, we've done it in 69 now without using immunotherapy, without using systemic therapy, only with a combination of TARE and SPRT with systemic therapy, which included sorafenib initially and then now lenvatinib. So I'm not very sure because we've tried it out also in about 4 patients, I think 6 patients probably, immunotherapy pre-transplant. 2 of them have severely decompensated after use of immunotherapy, and in fact we lost those patients. So we did do a combination, we tried to do a combination. However, 4 of them have gone ahead and had a transplant after immunotherapy. My first question was about the length of waiting after doing this sort of downstaging in the super downstaging protocol. My second concern, and I'm not very clear about it, in EASL there was a diagram which said that if you have a lung metastasis and you were able to downstage this patient, you can still go to curative therapy. No. So, because I saw that, there was a lung met and then there was...
No, that was, in fact, that was curative, that's not super downstaging, okay? That was defining your curative intent and your palliative intent. And that was towards curative intent, but probably surgery, not transplantation. Unfortunately, EASL is very, very strict and very rigid. And we also had some problems in letting them accept our strategy for PVT, because also PVT for them is extrahepatic spread, which is not actually.
Which we've changed in the NASL guidelines. We've separated systemic disease from portal vein tumor thrombosis into C1, C2. So so I didn't want anyone to go home with the, because that particular diagram showed that a lung met guy can go to systemic curative therapy.
No,
so
in fact, extrahepatic spread was the gatekeeper of our trial also. If there were extrahepatic spread, the patient was out. If they had PVT, differently from before, they were included in the trial.
Yeah, so super downstaging, how long to wait after downstaging from super downstaging protocol after using immunotherapy and successfully downstaging? Did you have a waiting period?
You mean?
You had portal vein tumor thrombosis, you did a super downstaging, now it's gone. Did you wait for 3 months, 6 months?
We actually had a minimum of 4 months. 4 months. After 4 months, if they had partial response or complete response, we put them on the transplant list. Consider that that's another probably 2 months before evaluation is ended, but mainly 4 months were necessary, and that's the medium expected time to response in the IMbrave 150.
And do you want to wait a little longer before you come out with your results? Because I'll tell you from experience, these guys, if you've really done bad patients, which we've burnt our fingers with in terms of those who have hepatic vein tumor thrombosis, they recur early, there's no question. Within the first year they will recur, and therefore we've considered HVTT completely separate now. We feel it's more systemic disease rather than local disease. For portal vein tumor thrombosis also, I think, before you reach a 2-year median survival, it's very, very difficult to, actually extrapolate your results. So I think you may want to wait a little bit longer for a longer follow-up. Those results are excellent, but because from our experience, I think, recurrences at 1.5, 2 years, that's the period. We had 17, 18 months as the median time to recurrence. So I think you need to...
Our trial wants to be a phase 2, efficacy and safety, full stop. No sure and precise response on OS.
Thanks.
So that Kaushal
Prashant, always initially there is a lot of hype for everything, which is important. That has been experience of medical science as a whole. So we have to wait.
Hi, I think my question is to Sherry as well. In the protocol where you used, in terms of using immunotherapy pre-transplant, what was your immunosuppression regimen? Did you continue with your standard immunosuppression regimen, or did you increase your immunosuppression, prolonged duration of steroids?
In the first 4 trials, as we were quite afraid of rejection, we introduced a triple immunosuppressive treatment following the previous literature we had, mainly Parisa Brishan's experience. But we had very important infectious adverse events. Slowly, we started tapering. Now we have a little bit higher steroids at the beginning, but we immediately wean steroids. And we have MMF if the waiting time is below 1 month. Of course, CNIs as the main standpoint.
And perhaps one more question. I know various centers' protocols are different. Do you all routinely use basiliximab or do you not use basiliximab?
No, we don't. No,
so
we don't.
None of these patients got basiliximab?
No, because that was too much confounding for the immune surveillance program.
Okay, thank you.
So Dr. Kaushal, can I ask the last question?
Sure.
So
Last
as we know,
question.
in this category of patient, the combination is better than monotherapy. And among the combination, the TAIR is better than the TACE. So do we have any minimum dose of radiation which is to be delivered at least to the tumor or liver?
So
Like
I think
a
in
cutoff?
that study I did talk about at least 205 grays, but I think Dr. Bajal is sitting there, he might be able to answer that. But they try to go up to as high as 335 grays to the tumor and try to minimize the dose to the normal tissue to less than 120 or even less than 40. Dr. Bajal?
So any expected side effects of that high doses?
Don't they do dosimetry for individual tumor?
So they call
volume?
it ablative tear.
Yeah. They will calculate the dose for particular tumor, isn't it?
So this dose that he's talking about now, 337 gray, is now using what is called voxel-based dosimetry. It's more than partition modeling, because in that you would bring all the factors of tumor heterogeneity within the calculations. And with the voxel-based dosimetry, you get that to get complete response, you need at least 337 gray into the tumor. That's the mathematical model that's been derived using voxel-based dosimetry. What Dr. Acharya is talking about is what is the liver safe dose. This is the tumor kill dose. The liver safe dose has now been up to 70 gray, and that 70 gray to normal liver is also based on which is the kind of particle that you're using. It's different for glass and it's different for resin. So it's all very, very now customized and individualized, and we can keep liver safe and prevent adverse events.
So Dr. Bajal, is there any cutoff for
Ashish, we have to end, I'm
CTP or just last one point, cutoff for CTP for tear?
I know, so we want to keep it as B7, still keep it at B7.
Okay, I think we'll end now.
Yeah, I think we call the day, for the, we have got 2 parallel sessions now at the first floor.
Yeah, so we,
after this.
I think first of all,
And we thank you
for
everyone
this session, and
for
you can assemble
Thanks
for
to
a
the
picture.
panelists. Thank you.
So we have 2 focus group discussions on the first floor. So I request all the discussants who are here for that to move to the first floor, and the stairs are right across the hall. The topics are liver transplantation, what a non-transplant physician should know. And the second one is holistic management of alcohol use disorder. So I request the discussants and the moderators to please come to the first floor. Everyone else can join if they want, or they can take a break. There is a musical evening and dinner at 8:15 in about an hour from now in the same hall. So I'll request everyone to come back for the music and for the dinner and cocktails. Thank you.